we can't refuse to thank you for being here to have this day go on. We thank the organizers once again, but allow me also to thank our partners from the different universities in no specific order. Allow me to welcome and recognize our partners from Nigeria. Please may you rise for recognition. These are from the University of Jersey. Thank you for coming and balancing the gender, because most professors are male, but you changed the saying. It goes without saying. Allow me also to welcome and recognize our people who have joined us from Tanzania. Tanzania. That one I'll say a little bit. Karibuni. Welcome to Uganda. Yes, to our guest of honor and other people, we know that Swahili started in Tanzania. It grew up in Kenya, died in Uganda, and was buried in Congo. So when you hear that it's not a little bit messy, those are our stars in Swahili. So welcome. Allow me to welcome our visitors from Canada, the Canadian team. Yes. Ooh. They also balance the gender. Yes. Thank you for coming to Uganda all the way. They have talked about the spa, but I know you're fresh. You look fresh. You don't need the spa. Ladies and gentlemen, we do have also the different communities in Uganda. Those I will introduce within the other breaks. But for now, allow me to welcome and recognize the next person going to moderate the session. He is a senior lecturer in the Department of Pharmacy, and he's a medical, pharmaceutical, and analytical expert, chemistry expert. He is a senior lecturer in the Department of Pharmacy, Deputy Dean, Faculty of Medicine, the Vice President, Pharmaceutical Society of Uganda, and the Vice President of Commonwealth Pharmaceutical Association. Ladies and gentlemen, let's put our hands together for Dr. Jonans Tusimire. The CV is long. He even has Commonwealth. Keep clapping. Keep clapping. Yes, he's consulting. Thank you, Dr. Jonans, for accepting to be the moderator. And here you take over from me.
Thank you so much, Angela. Can we give Angela a hand clap? When Angela stands to speak, you cannot repeat her words. But I'll once again welcome everyone who has managed to come for this workshop. Thank you so much for coming. Once again, my name's Jonans Tusimire, and I'm a senior lecturer in the Department of Pharmacy and Deputy Dean, Faculty of Medicine. I have the pleasure and honor to moderate the first session, and so I would like to invite the following people to come forward and take your seats in front. We have Dr. Data Santorino, who is the Principal Investigator, Sim for Life, and the Director of the Simulation Center at Mbarara University of Science and Technology. Dr. Data also is a pediatrician and a lecturer in the Faculty of Medicine. Dr. Data, I would like to invite you to take your seat in front. Next, we have Professor Nalini Singhal, who is the co-PI of this Sim for Life, and a professor emeritus of neonatology at the University of Calgary. Please, can you also come forward? Thank you so much. Take your seats here. I'll also invite the Dean, Faculty of Medicine, Associate Professor Joseph Ngonzi, who is an obstetrician and gynecologist in the Faculty of Medicine at Mbarara University of Science and Technology. Thank you so much. So in this session, we're going to have a series of presentations from the principal investigators, Dr. Data and Professor Nalini, as well as some opening speeches from the Dean, Faculty of Medicine, and other presentations as we shall be mentioning them. So at this juncture, I would like to invite Dr. Data Santorino to give a presentation together with Professor Nalini Singal, the principal investigators for this project. Thank you so much for your attention. I like to request the Secretariat to project, and presentation. Okay.
Thank you, Dr. Jonans. The chief guest, Professor Sarah Chiguli, invited guests, our supporters, represented by the Elmer Philanthropies here. Good morning. The domestication of medical simulation in Africa is well underway. In Uganda and in East Africa, when we started about 10 years ago, it was not part of teaching timetables. But in Mbarara University now, medical simulation is integrated into timetables. It's examinable, and it's part of curriculum and routine exposure. We are at a point where, recognizing the challenges for the integration of medical simulation, we are expanding the network of like-minded people. And now, we in this room are proud to say the partnership with many institutions that are interested in medical simulation and would like us to learn together and grow together is expanding. This is a significant milestone for Africa. We have not made simulation only for teaching and learning at the academic centers. We have had a significant influence in the translation of medical simulation for skills retention and translation of learned knowledge into practice in clinical care. Turn it over.
When we do things in medicine, we always want to make sure that we keep our patients in mind. And that's what the Sim Center has been able to do, is to translate the simulation out in the communities so that the method of learning with peer learning, so that we can teach each other with certain adaptations and with certain technologies like Prisms, which you will hear about later, and certain technologies like the air device that help with education quality improvement. We've actually been able to bridge the gap and demonstrate that starting with simulation, we can actually make a difference to the outcome. We've used newborns and mothers as an example to demonstrate that, but we hope that it translates into every person that needs help, getting the help that they need and should get. Thank you.
So once again, welcome to the Simulation for Life Symposium. In Sim for Life, we say, hands-on practice to save lives. Welcome.
Yeah, thank you so much, Dr. Data and Professor Nalini, for your presentation. I would like to now invite the Dean, Faculty of Medicine, Associate Professor Ngonzi, to give his opening remarks. Thank you so much.
Thank you. Good morning. Good morning. Yes, thank you. My name is Joseph, and I'll try to be very brief. I know time is running very fast and would want to redeem the time. I want to acknowledge the presence of my teacher, Professor Sarah Chiguli, who is the guest of honor this morning. Let's welcome her. Our committed partners from Canada and the Elmer Foundation, the team from MAST that has organized this, of course working with others, led by my brother, Dr. Data. The visitors from Tanzania and Nigeria, thank you for coming to the best nation on earth. We are providing safe space for learners and faculty to be able to practice before they get on to the real patients is very commendable. I've seen simulation at MAST start, and Dr. Data, with your team, I'm one of your secret admirers. I remember very well when we agreed to integrate simulation into the learning process. It was not an easy match, but finally we are there. Students move with their logbooks, they attend simulation sessions, and they are very excited. Behind your back, they come and tell us that if everything else at MAST should go, simulation will be the last one. Of course, there is need for commitment in all aspects to have a sustainable program. Commitment not just in words, but commitment in appropriating resources to where the core functions of the university lie. Simulation is a very important component of the learning system, as we all know. And as a result, we have commitment in writing, but there is a move towards appropriating some resources to the Simulation for Life in whichever way. The issues and challenges of human resource are humongous. They are huge everywhere. But it's my hope that data working together will be able to advocate for this baby, which I believe is now beginning to crawl. And as it continues to breastfeed, as you know better than me, you being a pediatrician and your team, we should be able to celebrate the adolescent stage, and we watch as it moves into adulthood. So I congratulate you, and on behalf of the Faculty of Medicine, I welcome you. I was informed that the Vice Chancellor is in another meeting where I was supposed to be, and he asked me to give his remarks. There are not many, and I want to welcome you on behalf of the Vice Chancellor of Muni University of Science and Technology. When he gets some breather, hopefully he will pass by before this symposium ends. Have a good symposium, have a good stay for those who are visiting Uganda for the very first time. And to our Canadian friends, we hope we'll be able to baptize you with Ugandan names before you go back. Succeed we must for God and my country.
Thank you so much, Dean, for those great remarks. Our next presentation will be from Professor Simon Wiltock from the University of Jos. Professor Simon is a provost in the College of Health Sciences at the Federal University of Jos, Nigeria. He's a plastic and reconstructive surgeon and the PI, Sim for Life, Nigeria. Can we give him a hand clap as he takes over? Thank you so much.
Thank you very much. I don't know. Can you project this slide? I will be presenting on behalf of my team from Jos. I bring you greetings from University of Jos. Jos is located in central Nigeria. It's one of the second generation universities in Nigeria. This is just an area view of our Naraguta campus of the university. We run a multi-campus system. We know simulation-based learning is something that has been going on, especially in high-risk profession like aviation, but it has come into healthcare and is gradually being used for, training of professionals, and basically allows, learners to learn their skills without exposing the patients to high risk or risk of injury or delay in treatment and some other complications. And usually we use tools that will replace real patients. And it has been found to enhance learning and teaching in clinical competence. And this method is gradually being used and increasingly be used in training of healthcare professionals. For us, it's not a regular tool that we use in our university in training our students. So the story about SBL in our center started with a visit in 2019 by the team from Barara University, led by the VC, Professor Obuo. And with the team, he came with the principal officers of the university, along with Dr. Data, Kasim. The primary purpose is to visit our African Center because Moss just started a farmland track and they needed to see there. The primary purpose, like I said, is to visit our own center. The visit gave an opportunity for Dr. Data to present and showcase simulation for life, which they've developed so far in Moss and trying to scale it up. And that visit led to my invitation to attend the symposium in 2019. Thereafter, the phase 2 program was developed, and that's the expansion that has led to our part of being here and the team from Tanzania and other universities in Uganda. Okay. An MOU was signed in 2001. There are some delays, the COVID and the back and forth signing that ended up. But we finally signed the MOU, and that led to our first faculty development of the core team. Here, we had a training along with the Tanzanian team in November 2021. And subsequently, we had our own faculty development program that held with Dr. Data, Albert, and Shifra, coming all the way from Barara to be part of it. We had 2 faculty development sessions in the university, and we were able to train about 53 facilitators. Unfortunately, we had a prolonged strike in our universities, the public universities in Nigeria, which lasted for like 8 months, and that stalled a lot of progress we're making. But in the interim, we're able to run some refresher calls in between that period to be able to, retain so that we avoid knowledge decay. Okay, just move it from there. East. Okay. So like I said, we had 4 training programs, 2 of which are primary faculty development program, and 2 were refresher courses. And we had 53, and out of that number, 36 were male, 17 female. And out of that 53, 32 were lecturers within the university system, and the rest were hospital consultant, senior residents in training, clinical instructors who are not part of the core people who are on strike. So that we'll be able to, because these hospital consultants are involved in training our medical students and the clinical instructors and nursing students. So we developed 25 scenarios, and we're able to run it in 165 students. Not all the scenarios, but we'll be able to run scenarios that involve 165 students that are exposed. And in 25 rounds, And this is a distribution. 15 rounds was in anesthesiology, involving 104 students, 9 in obstetrics and gynecology for 53 students, and 8 students with a run in medicine. We intend to run more as as we go on, and involving more departments so that we'll be able to, achieve. Okay. So we've had some challenges so far. First of all is the strike, the industrial action that have occurred involving all the unions, almost all the unions in the university. And because of that, we had knowledge decay, and that necessitated our running some refresher courses to be able to keep the knowledge. We have space constraint, even though now we're being given a space, but yet to be fully developed. And the issues of the multi-campus system, we have a number of our departments scattered, and that has affected how we'll be able to mobilize students and run that. Then inadequate budgetary allocation, which we've been trying to push, and the very old ones that are finding it difficult to key into this new way of learning and teaching, which some prefer just all the bedside teaching as well as didactic lectures in classroom. What are the lessons learned so far? Because of that, we've been able to develop refresher courses that will be able to help us using our available space, offices, any available space that we'll be able to do, like in anesthesiology, we'll be able to use recovery room to run scenarios for the students. And the other thing is that we need to keep advocating, pushing for, so that we'll be able to get budgetary allocation. We know the challenges of the resources available, and at the end of the day, with the competing needs. We are hoping that we'll have increased budgetary allocation that will be able to help us develop what has been given to us. This is our medical library. I think data visited. So we've been allocated some space up on the last floor here, which will be modified and we'll be able to run. I think by the design, we should be able to have about 7 scenario rooms, which will be able to enable us run, cover a large number of classes within a short time once we have that, and the adequate facilitators. This is the space so far, 2 rooms that will be able to demarcate, and that will accommodate about 7 scenario rooms. Ultimately, we hope there is a design there, but because it's a public university, which we always rely on budgetary provision, we intend to have a dedicated structure for skills and simulation. Similar to, I visited one of our sister university. They have a structure almost close to the size of our library that has all the space. It will enable students to learn certain skills like suturing, passing catheter, doing lumbar punctures and other things. Have section for simulation and others. So ultimately, that's what we expect to have. So far, the implementation of SBL in our institution is a welcome development. There's been so much enthusiasm by our students, as shown by their national body. Fortunately, we are hosting the national body, that's the Nigerian Medical Students Association. And they are quite interested in that and trying to see whether we can have videos they upload on their own site. But we're looking at that we'll be able to develop it, but hosting it on our own site so that we'll have more people visiting. And we believe that implementation of full SBL in our program, in our curriculum, having schedule for it, will be able to change the way our students are trained and ultimately the quality of practice they have thereafter. Thank you.
Thank you so much, Professor. Can we give him another hand clap? Yeah, that's the experience from the University of Jos at Nigeria. We will have another presentation, this time from Bara University of Science and Technology. And the next presenter is one of those who have been behind the success of the simulation methodology at MAST, who is going to present on the student's voice in the integration of simulation-based learning into routine teaching timetables at a medical school in Uganda. May I invite Dr. Albert Muhumuza, a medical doctor, simulation facilitator, and the coordinator for the simulation in the Faculty of Medicine. Dr. Albert, please come forward and give your presentation. Please give him a hand clap as he comes forward. Thank you. So after Albert's presentation, we'll have a brief video, and then we'll listen to the guest of honor. Thank you.
Thank you very much. I am not sure if it's working. All right. Professor Yiltok was very kind to us while we were in the University of Jos. And I have very fond memories of the egusi soup and the palm wine. And I've been told that you've come with cola nuts for me, and thank you very much. So my name is Dr. Muhumuza Albert, and I'll be sharing with you the student's voice. And I believe this is why we're here. We're here for the students. And I'm going to share with you a study that showed that medical students and nursing students support the integration of medical simulation into their timetables. And this is a study that we conducted here at Mbara University in the Simulation Center. And as you've heard from the previous presenters, simulation was integrated some years back, and we have been having this in the undergraduate medical and nursing students. The students in this study were third year and fifth year medical students. And these are the ones that are allocated time in the master timetable. And they're exposed to simulation every 1 to 2 weeks. So every time they would come into the simulation, they would give them a survey. So they would complete a survey that we adopted from KidSim Center in Calgary. And we aimed to have feedback about the program, because it's one thing to deliver a teaching method, but it's important to know if the teaching method has impact on the students. So we aim to get feedback concerning the frequency of the scenarios, the session organization, their lived experiences in the simulation sessions, and suggestions for improvement, because as we always say, we are feedback people. So they had suggestions on there. So we had a total of 591 simulation sessions from September 2021 to April 2023, and 606 medical students were exposed to simulation during this time. And that gave us a total of about 3,503 student visits. And in these visits, we had 2,533 students respond to the survey. So the completion rate was 72%, and majority were medical students, 86%, and that's because they have more slots in the timetable. So they shared with us their perceptions on what they thought about the organization of the simulation sessions, and they scored it on a scale of 1 to 5, where 1 is strongly disagree and 5 is strongly agree. And as you will see here, they scored all the parameters 4 and above, and that means that they agreed or strongly agreed that the simulation sessions were well organized, that the group size was appropriate, the interdisciplinary involvement had positive impact, and that the realism was excellent. So they also shared with us what they thought about their experiences in the simulation center, and also on the same scale, you'll see most of them are 4 and above, which means that they strongly agree that the overall education experience is excellent. The simulation scenarios were appropriate for the learner type. The post-scenario debrief was helpful in learning. The learners were treated with respect, which we think is very important, and the goals of the sessions were met. I'm going to share with you some of the qualitative responses from the students. So we asked them what they found most useful about the simulation sessions. And what you'll see here is that their experience in patient management, patient assessment during the simulation sessions was important. And as you will see, one of the students said that, I learned how to manage a baby with respiratory distress. That was a 5th-year medical student. They also benefited from teamwork and interprofessional learning. And well, in simulation, they work in teams. And as you see, one of the medical students here say that working in a team is the way to go, because a patient gets helped in the shortest time possible. They also benefited from the post-scenario debriefing sessions. And these are really sit-down discussions after a simulation session where you get to learn from the tutor. And one of them said, I found this post-scenario debriefing very helpful in learning the management of shock. So they went on to share with us what they found very useful. And one of the things is that simulation builds confidence and decision-making skills. And as you will see, a medical student here say that this exposure and practice enables us to improve the skills and confidence. They found the simulation center a safe environment and the scenarios realistic. And it's important to us that it's a safe environment because that's the best place to learn, have errors, and then resolve the errors. So one of the students said that the case was very realistic and a common case on ward. So as feedback people, they also shared with us what they thought should be improved. So they would want that to have more scenario duration and frequency. And as you see, a medical student here say that simulation sessions should be organized more frequently to help student learning. Student facilitator ratio, that means that every time you're in a session, they are interested in having smaller groups, because the smaller the group, the more interaction and the more participation. And picking from a quote there is getting more facilitators so that we have smaller group learning and smaller groups and more people to fully participate. Interprofessional involvement, interprofessional learning and involvement of senior provider in their learning was something that they would like to happen. And really this, from a nursing student, the comment was to making the sessions interdisciplinary, involving other courses, because in hospital we work together. EG medical students with nursing students, pharmacy and physiotherapy, all in case management. Yes, please. And they continue to say that they found they would like to have an increased scenario variety, and this basically types of scenarios that they're exposed to and have more mannequin realism. And what a medical student here said was that give us more different cases per session because the experience is important. And lastly, they would like to have an increase in the simulation space. And this is largely to reduce the delay and to have more groups run in a short time. And one of the nursing students said that more simulation labs prevent overweighting by the students for the scenario or even rescheduling. So we get innovative sometimes when we run out of space, and we use the good weather of Uganda to have discussions. However, like any other place, sometimes it rains. So this may not be possible all the time. Next slide, please. So a large majority of the students, when asked about the scenario frequency, 96% of the responses would like to have simulation once a week, at least once a week. And in that percentage, you will see that 49% would want it once a week, 39% would like it twice a week, 8% would like it even as many as 3 times a week. Currently, we run it once in 2 weeks, and that is the 3% you're seeing there. And 1% would want it once a month. So, in conclusion, medical and nursing students rate their simulation experience highly. And they see benefit, and they would desire to have increased simulation in their learning. And what we recommend from this is that nursing and medical training institutions should consider simulation-based learning once a week, and preferably interprofessional, because in the universities we work in teams and we work with different professions. Thank you much. Thank you very much.
Thank you so much, Dr. Albert Muhumuza, for that presentation of the experience at MAST. For those who have just come in, this is plenary session 1 for this day 1 of the 2023 Symposium for Sim for Life. And we have so far had 4 presentations. One was the overview from the PIs, Dr. Data Santorino and Professor Nalini Singal. And then we had the opening speech from the Dean, Faculty of Medicine, Associate Professor Joseph Ngonzi. Then we had a presentation from Professor Simon. He'll talk about the experiences at the University of Jos in Nigeria. And then Albert, who has just presented. So as we prepare for remarks from the guest of honor, I would like Angela to take I would like us to have a video, a brief video about MAST, and then Angela will take us through some bit of body booster, and then we'll listen to the guest of honor.
We agreed to talk about our mistakes, and all the mistakes are chances to learn.
In learning, we will teach, and in teaching, we will learn. Sim for Life project based at Mbarara University of Science and Technology, also known as MAST, acknowledged that skills and knowledge decline after a short period of training. Hence, they designed the peer-to-peer methodology where health workers can practice and learn from each other at their health facilities.
We received invitation from Mbarara University on Sims for Life, where we sent 4 midwives on 2 occasions. They were trained on help mothers survive and help babies breathe.
We traveled to different sites that the peer-to-peer learning methodology has been implemented. With this learning methodology, health workers are supported to facilitate practical sessions at their facilities. This is a life-changing situation as teams embark on saving babies and mothers.
As a peer lead at St. Daniel Combon Hospital, it has helped me to help my fellow midwives on learning how to help babies breathe and helping mothers survive.
We learn from one another. What one is not performing well, you pick from your fellow midwife when you are carrying the procedure.
At least every week or in 2 weeks' time, we make sure at least some midwives have to practice so that we really improve our resuscitation skill.
Due to peer-to-peer learning, even those midwives who are not trained and even with the doctors were able to learn through the peer-to-peer learning, and we have improved on management of our babies.
I did not attend any training in helping mothers survive and helping babies survive, but through the continuous practice sessions we've had at the facility, I've learned how to help babies survive through resuscitation, that is bagging, sucking, and helping those babies who don't score well to come up. Through helping mothers survive, I've also learned how to manage postpartum hemorrhage, managing third stage of labor, management of second stage of labor, and also managing the retained placenta and many others.
We had knowledge gap in management of newborns, more especially the sick. You'd find we had challenges with the dosage and what, but through peer-to-peer learning and with the EIC materials we are able to give drugs when we are conversant, knowing the dosage for the newborns according to their kilograms.
The number of deaths is decreasing. If I may say it, even so minimal now. It used to be mass, but because of peers to peers and learning from one another and taking control of that golden minute, it has helped us.
The peer-to-peer training has so far covered 54 sites in southwestern Uganda. Several organizations have partnered with Sim for Life project to extend this methodology in different parts of the country.
Peer-to-peer learning has not only stopped at our facility, this facility being a health sub-district for our constituency, Igara West, we have done the same training to all the facilities which are under our jurisdiction. Usually we invite midwives here on a quarterly basis, and we have been able to get our trained midwives on peer-to-peer learning in these sessions to train them, and even after there have these midwives who are invited to also do the same kind of training on peer-to-peer. So this has helped not only our facility, but all our constituency, all the staff within our constituency to learn peer-to-peer sessions and to be able to manage babies who are born with some bit of distress.
In our reports, babies who score lower have improved greatly within a few minutes. Then also our referral numbers have reduced because we would refer almost every baby who would be born asphyxiated. But now we do resuscitation within a short period, the baby is gaining, and we continue with the management. It has also helped us to prevent wastage of drugs because you know what is needed for a particular child. Then also in management of our mothers, especially PPH, since it is one of the major causes of death among the mothers, pregnant women, and those who have delivered. But through peer-to-peer, we've also improved our skills of resuscitation and reactive management of third stage, and in case of PPH, the steps to follow so as to achieve a better health within a shortest period. Also, preeclampsia and eclampsia, most midwives had the challenge of giving out those drugs, injections, magnesium sulfate, hydralazine. Most of us would give, and instead of saving a life, maybe you cause a problem instead.
This methodology has also been adopted for implementation in different sites in Canada.
We thank Sim for Life, Mbaraya University, Science and Technology for bringing us peer-to-peer learning. And you have made us save life and life of our children and mother. Thank you very much. May God be the one to bless you and reward you. Thank you.
Special thanks go to our partners in the University of Calgary, Canada, under the leadership of Professor Narini Singhal, who has worked tirelessly to see this project make headway. We acknowledge the support from the district leadership, the different health workers in different health facilities, mothers and their families, and the MAST Team Sim for Life project. Thank you all. I have been your narrator, Angela Nakato, from the Public Relations Office. Succeed, we must. Yeah, this is technology for you. No worries, yeah? People from Canada, we once hosted the President of the United States of America, and he was with our president, and power went off. So that was not even news. So later, when our president visited the US, there was a certain building somewhere. They were seated at the gazebo, and power kept going on and off, on and off. And our president was like, the US is developed. What is that building that power keeps going on and off? So the president then called the butler and asked him, what is that building where power keeps going on and off? The butler whispered in the president's ear and told him, that is the Ugandan embassy. So our things keep going like that, like that. That's how it is in Uganda. So we don't have to worry about it. We move with our situations. Forgive us where we have failed you in terms of technology and ICT. It's hard for the guest of honor to speak when we're not fresh. So can we just rise up for something small, please? Thank you, Jonans, for this. Everyone has a paper with you. Please get a paper and your pen. Thank you. Just stretch your hands with that paper and put it on the back of your head. Yes, can you face someone? Dr. Singhal, face me. Dr. Data, face the guest of honor. So can you draw the person's face starting with a circle? Why are you laughing in my classes? Can you draw the circle? Yes, the face. Draw the circle of the person you're facing. Can you put the eyes? Can you put the eyes? Professor, draw my face. Can you put the nose? Can you put the mouth? Or the ears and the earrings, because they're there. The ones wearing the specs, you can put that. And people are laughing in my class, I'm not happy. Put the hair and the hairband. Now show the person the picture you've drawn. Yeah! That is what others think about you. Okay. Okay, that's what you think about. That is art. And that's what people think about you. Is that how you can draw me? No. Okay, one more, ladies and gentlemen. When you're representing a female, ignore the new things. Female is represented with F. Female, F. Are we together? Female and male. Okay. So when I say I, everyone is I. Okay. When the word has an F, you are female, you stand up. When the word has an M, the male stand up. I, everybody stands up. Are we ready? I will make. So I expect the ladies to sit. Fishers of men. Fishers of men. Fishers of men. I will make you. That are you male. So I'll take it in a song. I will make you fishers of men, fishers of men, fishers of men. I will make you fishers of men if you follow me. Oh, the guys have won us. Yeah.
That's great. Angela, thank you so much. Can we give her another hand clap? Our next presenter, the guest of honor, is a professor of pediatrics and child health in the School of Medicine, College of Health Sciences at Makerere University. She's also the director of the East African FEMA Regional Institute. She is also a principal program assessor for the Uganda Medical and Dental Practitioners Council for the accreditation of programs by National Council for Higher Education. Ladies and gentlemen, can we put our hands together and invite Professor Sarah Chiguri to give us our opening remarks. Thank you so much, Professor.
Thank you very much. I've been introduced to you. I hope that you now know a bit about me, but I normally tell people that I'm someone with a passion for children. That is my first love. And you've been told that I'm a pediatrician. My second passion has been medical education. And I've walked that journey for the last more than 20 years. And I have a number of scars, which you may not see because of that. So the Dean, Faculty of Medicine, Mbarara University, Science and Technology, Associate Professor Joseph Ngozi, who was with us, but I know that he's still with us. The Partners Simulation for Life project. I'll talk from here if it's not. I'm sorry, my presentation is not projected, but then you'll be able to look at me and I'll be the visual. The partners for the Sim for Life project from Nigeria, Tanzania, Kenya, Uganda, Canada. Do we have people from the US? But also all the other people present here. The faculty and students from Mbarara University, as well as other institutions, the sponsors, participants for this symposium, our master and mistress of ceremony, ladies and gentlemen, it gives me great pleasure to stand before you today, and I'm greatly honored and privileged to have been invited to participate in this symposium and officiate as the guest of honor at the opening ceremony. I was delighted to learn that there are people from Calgary here. Yes, I read about the Calgary guidelines for communication skills, and there's that small book. I think that's where my love for communication, for training started. It was about 18, 19 years back when I did my thesis of how to communicate with children. So I'm really glad that you have finally met people from Calgary, because your guidelines are very famous. And as I said, I've been actively involved in health professions education for over 30 years, working at the medical school. And many years have been involved in innovations, advocacy, and a drive to move the field. Therefore, talking about simulation for life and the symposium involves an important area of health professions education, that is simulation. As we've been told, simulation-based education and training has been around for some decades, but has grown in application and relevancy over the past few decades. This is mainly in the developed world. In the developing world, yes, we are going there, and it's good to know that Mbara University and the universities in Africa here are leading us. But we have not fully embraced it due to a number of reasons. We have inadequate knowledge and skills. The teachers were not taught mainly using simulation. So we don't know how to do it. And if we don't know how to do it, it will be very difficult to implement it. We don't have adequate infrastructure and equipment. And I think the presentation from Jos cited it as one of the challenges, that yes, we don't. Sometimes those are excuses, but they are real challenges. And many times we say, by the way, our hospitals are full of patients. We can't train our students in the hospitals, on the wards. The patients are there. Why do we need simulation labs? Why do we need skills labs? I've heard that comment many times from even my leaders at my institution. So all these, in addition to unsupportive leadership, many times, and the resistance to change. After all, I was taught how to do things on the wards, and I'm a good clinician, I'm a good nurse, I'm a good doctor. Why should we change? So those are some of the challenges we have. However, the growing number of students under us, under our care, and the challenges in the health system, and the high morbidity and mortality among the population demand that we need to change and implement a number of innovations in the way we train students, in the way we support the skills of the health workers. And simulation-based learning is one of those innovations that we need to adopt. Ladies and gentlemen, the Lancet Commission on Education of Health Professions for the 21st Century. This article publication came out some years back. I think it was 2017, if I'm not mistaken. Recommended that institutions should have both institutional and instructional reforms to transform health professions education. And this was aimed, or this should be aimed, at strengthening the health systems. Simulation-based education is one of those innovations or instructional reforms that was recommended. And this is together with other reforms, including competence-based education, e-learning, problem-based learning, among others. Therefore, the Simulation for Learning project is very important in transforming health professions education. This project also involves creating partnerships and collaborations, faculty development, and interdependency in education that are key attributes to the institutional reforms that were recommended. You know, the partners here from Nigeria, from Tanzania, from Uganda, from Canada, meaning that we are depending on each other. We are depending on our partners from Canada to train us. We are depending on Mbarara to train Lira, going to Nigeria. So we are working together. There's that interdependence in education. There's the collaboration amongst the different institutions. Collaboration among the doctors, the nurses you saw, but also collaborations between the training institutions and the health service institutions. So all of them are needed if we are to improve the health of our populations. And everything is actually demonstrated in the Simulation for Life project, even from the testimonies we had in the short video and the students' voices. Simulation-based learning has been around, as I said, for some years. We have lagged behind in Africa in implementing this. Therefore, I commend Mbarara University of Science and Technology. I commend the partner institutions present here for spearheading the implementation of this innovation in Uganda and beyond. I commend and I thank the principal investigators for having thought about this more than 10 years back. That is really commendable. A bit about myself. I normally want to talk about myself. One of my classmates at medical school is here. I need to introduce him, Professor Jerome. Yes. We entered Makerere together more than 40 years, is it? 1981, I don't know how many years those are, but we are still going strong. But in about 1999 or 2000, I was privileged to attend a summer course at Maastricht University, and one of the areas we were exposed to was skills training. And I was a woman among many men who said, now you, Sarah, go to that skills training. For us, we are going for assessment, those things which we are known. And I went. They sent me because they thought it was maybe not important. And that is where I was hooked on the skills lab methodology, which actually you need people to have the clinical skills, and then they can do the simulations so they can be trained. So both are there. And that is when I was first involved. So I was pleasantly surprised reading through what you do, that you even think about those gender things in simulation. Because these men, the students, maybe even during the training, may want to be the leaders. Maybe the doctors may also want to be the leaders in an activity that is collaboration. So yes, it is all important. And I put this here before I actually saw what was there. So the Simulation for Life project, which aims at training pre-service students, graduate students, and in-serving training of health workers in key priority areas of maternal, newborn, and child health. And I think the impact of this in reducing morbidity and mortality in child, newborn, and maternal health is great. Actually, the midwife on this video we saw said that they are seeing less deaths. So probably you were realizing what you set out to do. I know that it takes great leadership faculty commitment, and teamwork to introduce and sustain such innovations. Therefore, the leaders of Mbara University of Science and Technology, including the Vice Chancellor, the Deans, and the other leaders, I strongly commend you. But I also commend the faculty. We are always busy. We want to do other things, but sometimes we don't want to put in time for the new things. So I hope that we'll be able to sustain this. And that's where the scars that I talked to you about come in, because I've seen things come and actually going when the people who started them either move or when other new leaders come. It's good that Dr. Data here has more than 50 years of service at Mbarara, but also other people. But truly sustaining the change should be something that we think about when we are implementing this, so that we integrate, but also plan to sustain. The vision of the East African FEMA Regional Institute, I was introduced as the director for the new FEMA Institute in the East African region, is to transform health professions education through faculty development. And I think the vision is in line or aligned to the vision of the Simulation for Life project. So as the director of the new institute, I believe that we can work together with MAST and the partners here to reach more faculty and sustain this and other innovations in Uganda and the Eastern African region. Because we need to reach out, we should not be comfortable that we are in Lira, we are in Busitema, we are in Muni, we are in Arua, and we are in Jos. What about the more than 10 other medical schools in Uganda? What about the nursing institutions? What about the other health facilities which are not part of this? So we need to get more partners, okay, so that this innovation is practiced by everyone. I know that simulation-based training will enable MAST and partners to achieve competence-based education, especially in areas that have been difficult to achieve. And these areas include teamwork, leadership, and interprofessional education and collaborative practice. And what was presented there is a testimony that we are in the right direction. I would like to end by emphasizing that the WHO Global Competency-Based Framework for Universal Health Coverage, which was shared last year at the end of 2022, has identified key competence areas for health professionals, including patient-centered care, communication skills, teamwork, interprofessional practice, leadership, among others, and simulation-based education and training at all levels is a key strategy to achieve this. So the partners are many, the competencies are there. The challenge is, are we only promoting simulation or the whole package of the innovations, including competence-based education, including student-centered learning? I know we have community-based education, because we may need to change everything to sustain simulation so that everything is integrated. Everything talks to each other and aligned. Otherwise, if we are there with our teacher-centered learning, if we are there and our assessment is using old methods and we are bringing in simulation, we may not achieve what we hope to achieve. I challenge you, and I strongly recommend that you expand beyond the institutions and the partnerships that you have at the moment, so that we can get the benefits of this. I know it is difficult, but I believe it can be done. Moving beyond, I'll be happy if MUST can reach out to my university. Okay? I'll be happy if the Simulation for Life project can reach out to Makerere University, because Makerere has reached out to other universities in a number of things. And I should say that, yes, we need your energy. We need you to come and talk to our leaders. I know that when Professor Jerome was the dean here, that exchange and the collaboration was actually there, and it made each of our institutions grow. Makerere, MUST, and all the medical schools in Uganda at that time. As I said, we need to think about transforming the things we do. So that's the challenge, PI. So we might need a whole transformation and not just one innovation. That's a big challenge. But I believe that if we think about it, it's nearer than what we might fear. I would once again like to thank the organizers for this symposium, for putting up such a rich program. I congratulate all the presenters, all the participants from far and near who are here, the partners and the sponsors who have made it possible. I anticipate that more networks will be created during these 2 to 3 days, and a lot of sharing and learning will take place formally and informally. When people talk to each other at break times, when you have some time for sharing, please do so, because that is where the networks and the connections begin. I believe that, and look forward, I believe that I'll learn a lot. I've actually learned a lot, and I look forward to the presentations and discussions during the time that I'll be present. It's now my great honor and pleasure to officially declare that the Simulation for Life Symposium is officially open for God and my country.
Thank you so much, Professor Sarach Guli, for those wonderful remarks. Can we give her another hand clap? Yeah, thank you so much. You've been a very active audience, and I've enjoyed it. We have come to the end of the first session. We have on the agenda the group photo as the next activity. And Martin, I know Angela has gone out to organize for the photo, so I hand over to you as the next MC. Thank you.
All right. Thank you so much, Dr. Jonans. Let's give him another clap. So when I say Sim for Life, you say hands-on practice to save lives. Sim for Life? Sim for Life? And Professor Simon brought it out nicely. He said that learners learn the skills without exposing patients to any risk. And that's very important. So I want to thank Dr. Data and his team for making sure that actually happens. And we are here today to understand the dynamics of medical simulation introduction and institutionalization in Africa. And most of the presentations that we have actually had today are all in line with that. Before we proceed, I want to recognize our local partners from Lila University, the team from Lila University. You can stand up for recognition. We have the team from Lila. Okay. Bustema University, do we have some colleagues that have traveled from Bustema? Can stand up for recognition, let's clap for them. And the team from Muni University. Muni? Let's clap for them. I also want to recognize our international partners, the team from Kuhas University. Kuhas is the Catholic University of Health and Allied Sciences, and they have traveled all the way from Mwanza, Tanzania. You're most welcome. Karibuni sana. The team from University of Jos, Nigeria. You're all most welcome to Uganda. Today it's a little bit chilly, but you're so most welcome. And then we've been working with different health facilities, a total of 36 health facilities. So people that have come from those facilities, you can stand up for recognition. Thank you so much for attending in large numbers. So our next session will be chaired by Professor Jerome Kabachenga. Professor Jerome is the director of he's actually the founder and director of Maternal, Newborn and Child Health Institute at Mara University of Science and Technology. He's a professor of public health and has previously served as the Dean Faculty of Medicine from 2002 up to 2013. He holds a bachelor's degree in medicine and surgery from Makerere University and a master's of public health from University of Leeds and a PhD from University of Lund, that's in Sweden. He was awarded the Tisdale Court Global Health Leadership Award from Canada Global Health Research Institute. And throughout his career, Jerome has collaborated with several local and international institutions to support community-based health in rural communities. Professor Jerome will be our next chair for the next plenary session, which is going to be here. I know they had put in Tungamo Hall, but after our tea break, we shall come here for that plenary session. And now let's prepare for a group photo. Angela has been organizing, and after the group photo, we shall break off our tea break, which is going to be 30 minutes. Thank you. The group photo is going to be outside. Thank you so much. All right, let's head out for our group photo. Let's get out for our group photo.
We agree to talk about our mistakes, and all the mistakes are chances to learn.
In learning, we will teach, and in teaching, we will learn. Sim for Life project based at Muni University of Science and Technology, also known as MAST, acknowledged that skills and knowledge decline after a short period of training. Hence, they designed the peer-to-peer methodology where health workers can practice and learn from each other at their health facilities.
We received invitation from Barara University on Sims for Life, where we sent 4 midwives on 2 occasions. They were trained on help mothers survive and help babies breathe.
We traveled to different sites that the peer-to-peer learning methodology has been implemented. With this learning methodology, health workers are supported to facilitate practical sessions at their facilities. This is a life-changing situation as teams embark on saving babies and mothers.
As a peer lead at St. Daniel Combon Hospital, it has helped me to help my fellow midwives on learning how to help babies breathe and helping mothers survive.
We learn from one another. What one is not performing well, you pick from your fellow midwife when you are carrying the procedure.
At least every week or in 2 weeks' time, we make sure at least some midwives have to practice so that we really improve our resuscitation skills.
Due to peer-to-peer learning, even those midwives who are not trained and even with the doctors were able to learn through the peer-to-peer learning, and we have improved on management of our babies.
I did not attend any training in helping mothers survive and helping babies survive, but through the continuous practice sessions we've had at the facility, I've learned how to help babies survive through resuscitation, that is bagging, sucking, and helping those babies who don't score well to come up. Through helping mothers survive, I've also learned how to manage postpartum hemorrhage, managing third stage of labor, management of second stage of labor, and also managing the retained placenta and many others.
We had knowledge gap in management of newborns, more especially the sick. You'd find we had challenges with the dosage and what, but through peer-to-peer learning and with the EIC materials we are able to give drugs when we are conversant, knowing the dosage for the newborns according to their kilograms.
The number of deaths is decreasing. If I may say it, even so minimal now. It used to be mass, but because of peers to peers and learning from one another and taking control of that golden minute, it has helped us.
The peer-to-peer training has so far covered 54 sites in southwestern Uganda. Several organizations have partnered with Sim for Life project to extend this methodology in different parts of the country.
Peer-to-peer learning has not only stopped at our facility, this facility being a health sub-district for our constituency, Igara West, we have done the same training to all the facilities which are under our jurisdiction. Usually we invite midwives here on a quarterly basis, and we have been able to get our trained midwives on peer-to-peer learning in these sessions to train them, and even after they have these midwives who are invited to also do the same kind of training on peer-to-peer. So this has helped not only our facility, but all our constituency, all the staff within our constituency to learn peer-to-peer sessions and to be able to manage babies who are born with some bit of distress.
In our reports, babies who score lower have improved greatly within a few minutes. Then also our referral numbers have reduced because we would refer almost every baby who would be born asphyxiated. But now we do resuscitation within a short period, the baby is gaining and we continue with the management. It has also helped us to prevent wastage of drugs because you know what is needed for a particular child. Then also in management of our mothers, especially PPH, since it is one of the major causes of death among the mothers, pregnant women, and those who have delivered. But through peer-to-peer, we've also improved our skills of resuscitation and reactive management of third stage, and in case of PPH, the steps to follow so as to achieve a better health within a shortest period. Also, preeclampsia and eclampsia, most midwives had the challenge of giving out those drugs, injections, magnesium sulfate, hydralazine. Most of us would give, and instead of saving a life, maybe you cause a problem instead.
This methodology has also been adopted for implementation in different sites in Canada.
We thank Sim for Life, Muni University, Science and Technology for bringing us peer-to-peer learning. And you have made us save life and life of our children and mother. Thank you very much. May God be the one to bless you and reward you. Thank you.
Special thanks go to our partners in the University of Calgary, Canada, under the leadership of Professor Narini Singal, who has worked tirelessly to see this project make headway. We acknowledge the support from the district leadership, the different health workers in different health facilities, mothers and their families, and the MAST Team Sim for Life project. Thank you all. I have been your narrator, Angela Nakato, from the Public Relations Office. Succeed, we must.
We agree to talk about our mistakes, and all the mistakes are chances to learn.
In learning, we will teach, and in teaching, we will learn. Sim for Life project based at Muni University of Science and Technology, also known as MAST, acknowledged that skills and knowledge decline after a short period of training. Hence, they designed the peer-to-peer methodology where health workers can practice and learn from each other at their health facilities.
We received invitation from Muni University on Sims for Life, where we sent 4 midwives on 2 occasions. They were trained on help mothers survive and help babies breathe.
We traveled to different sites that the peer-to-peer learning methodology has been implemented. With this learning methodology, health workers are supported to facilitate practical sessions at their facilities. This is a life-changing situation as teams embark on saving babies and mothers.
As a peer lead at St. Daniel Combon Hospital, it has helped me to help my fellow midwives on learning how to help babies breathe and helping mothers survive.
We learn from one another. What one is not performing well, you pick from your fellow midwife when you are carrying the procedure.
At least every week or in 2 weeks' time, we make sure at least some midwives have to practice so that we really improve our resuscitation skill.
Due to peer-to-peer learning, even those midwives who are not trained and even with the doctors were able to learn through the peer-to-peer learning, and we have improved on management of our babies.
I did not attend any training in helping mothers survive and helping babies survive, but through the continuous practice sessions we've had at the facility, I've learned how to help babies survive through resuscitation, that is bagging, sucking, and helping those babies who don't score well to come up. Through helping mothers survive, I've also learned how to manage postpartum hemorrhage, managing third stage of labor, management of second stage of labor, and also managing the retained placenta and many others.
We had knowledge gap in management of newborns, more especially the sick. You'd find we had challenges with the dosage and what, but through peer-to-peer learning and with the EIC materials we have, we are able to give drugs when we are conversant, knowing the dosage for the newborns according to their kilograms.
The number of death is decreasing. If I may say it, even so minimal now. It used to be mass, but because of peers to peers and learning from one another and taking control of that golden minute, it has helped us.
The peer-to-peer training has so far covered 54 sites in southwestern Uganda. Several organizations have partnered with Sim for Life project to extend this methodology in different parts of the country.
Peer-to-peer learning has not only stopped at our facility, this facility being a health sub-district for our constituency, Igara West, we have done the same training to all the facilities which are under our jurisdiction. Usually we invite midwives here on a quarterly basis, and we have been able to get our trained midwives on peer-to-peer learning in these sessions to train them, and even after they have these midwives who are invited to also also do the same kind of training on peer-to-peer. So this has helped not only our facility, but all our constituency, all the staff within our constituency to learn peer-to-peer sessions and to be able to manage babies who are born with some bit of distress.
In our reports, babies who score lower have improved greatly within a few minutes. Then also our referral numbers have reduced because we would refer almost every baby who would be born asphyxiated. But now we do resuscitation within a short period, the baby is gaining, and we continue with the management. It has also helped us to prevent wastage of drugs because you know what is needed for a particular child. Then also in management of our mothers, especially PPH, since it is one of the major causes of death among the mothers, pregnant women, and those who have delivered. But through peer-to-peer, we've also improved our skills of resuscitation and reactive management of third stage, and in case of PPH, the steps to follow so as to achieve a better health within a shortest period. Also, preeclampsia and eclampsia, most midwives had the challenge of giving out those drugs, injections, magnesium sulfate, hydralazine. Most of us would give, and instead of saving a life, maybe you cause a problem instead.
This methodology has also been adopted for implementation in different sites in Canada.
We thank Sim for Life, Mbaraya University, Science and Technology for bringing us peer-to-peer learning. And you have made us save life and life of our children and mother. Thank you very much. May God be the one to bless you and reward you. Thank you.
Special thanks go to our partners in the University of Calgary, Canada, under the leadership of Professor Narini Singal, who has worked tirelessly to see this project make headway. We acknowledge the support from the district leadership, the different health workers in different health facilities, mothers and their families, and the MAST Team Sim for Life project. Thank you all. I have been your narrator, Angela Nakato, from the Public Relations Office. Succeed, we must.
We agree to talk about our mistakes, and all the mistakes are chances to learn.
In learning, we will teach, and in teaching, we will learn. Sim for Life project, based at Muni University of Science and Technology, also known as MAST, acknowledged that skills and knowledge decline after a short period of training. Hence, they designed the peer-to-peer methodology where health workers can practice and learn from each other at their health facilities.
We received invitation from Barara University on Sims for Life, where we sent 4 midwives on 2 occasions. They were trained on help mothers survive and help babies breathe.
We traveled to different sites that the peer-to-peer learning methodology has been implemented. With this learning methodology, health workers are supported to facilitate practical sessions at their facilities. This is a life-changing situation as teams embark on saving babies and mothers.
As a peer lead at St. Daniel Combon Hospital, it has helped me to help my fellow midwives on learning how to help babies breathe and helping mothers survive.
We learn from one another. What one is not performing well, you pick from your fellow midwife when you are carrying the procedure.
At least every week or in 2 weeks' time, we make sure at least some midwives have to practice so that we really improve our resuscitation skills.
Due to peer-to-peer learning, even those midwives who are not trained and even with the doctors were able to learn through the peer-to-peer learning, and we have improved on management of our babies.
I did not attend any training in helping mothers survive and helping babies survive, but through the continuous practice sessions we've had at the facility, I've learned how to help babies survive through resuscitation, that is bagging, sucking, and helping those babies who don't score well to come up. Through helping mothers survive, I've also learned how to manage postpartum hemorrhage, managing third stage of labor, management of second stage of labor, and also managing the retained placenta and many others.
We had knowledge gap in management of newborns, more especially the sick. You'd find we had challenges with the dosage and what, but through peer-to-peer learning and with the EIC materials we have, we are able to give drugs when we are conversant, knowing the dosage for the newborns according to their kilograms.
The number of deaths is decreasing. If I may say it, even so minimal now. It used to be mass, but because of peers to peers and learning from one another and taking control of that golden minute, it has helped us.
The peer-to-peer training has so far covered 54 sites in southwestern Uganda. Several organizations have partnered with Sim for Life project to extend this methodology in different parts of the country.
Peer-to-peer learning has not only stopped at our facility, this facility being a health sub-district for our constituency, Igara West, we have done the same training to all the facilities which are under our jurisdiction. Usually we invite midwives here on a quarterly basis, and we have been able to get our trained midwives on peer-to-peer learning in these sessions to train them, and even after there have these midwives who are invited to also do the same kind of training on peer-to-peer. So this has helped not only our facility, but all our constituency, all the staff within our constituency to learn peer-to-peer sessions and to be able to manage babies who are born with some bit of distress.
In our reports, babies who score lower have improved greatly within a few minutes. Then also our referral numbers have reduced, because we would refer almost every baby who would be born asphyxiated. But now we do resuscitation within a short period, the baby is gaining, and we continue with the management. It has also helped us to prevent wastage of drugs, because you know what is needed for a particular child. Then also in management of our mothers, especially PPH, since it is one of the major causes of death among the mothers, pregnant women, and those who have delivered. But through peer-to-peer, we've also improved our skills of resuscitation and reactive management of third stage, and in case of PPH, the steps to follow so as to achieve a better health within a shortest period. Also, preeclampsia and eclampsia, most midwives had the challenge of giving out those drugs, injections, magnesium sulfate, hydralazine. Most of us would give, and instead of saving a life, maybe you cause a problem instead.
This methodology has also been adopted for implementation in different sites in Canada.
We thank Sim for Life, Mbaraya University, Science and Technology for bringing us peer-to-peer learning. And you have made us save life and life of our children and mother. Thank you very much. May God be the one to bless you and reward you. Thank you.
Special thanks go to our partners in the University of Calgary, Canada, under the leadership of Professor Narini Singal, who has worked tirelessly to see this project make headway. We acknowledge the support from the district leadership, the different health workers in different health facilities, mothers and their families, and the MAST Team Sim for Life project. Thank you all. I have been your narrator, Angela Nakato, from the Public Relations Office. Succeed, we must.
We agree to talk about our mistakes, and all the mistakes are chances to learn.
In learning, we will teach, and in teaching, we will learn. Sim for Life project based at Muni University of Science and Technology, also known as MAST, acknowledged that skills and knowledge decline after a short period of training. Hence, they designed the peer-to-peer methodology where health workers can practice and learn from each other at their health facilities.
We received invitation from Barara University on Sims for Life, where we sent 4 midwives on 2 occasions. They were trained on help mothers survive and help babies breathe.
We traveled to different sites that the peer-to-peer learning methodology has been implemented. With this learning methodology, health workers are supported to facilitate practical sessions at their facilities. This is a life-changing situation as teams embark on saving babies and mothers.
As a peer lead at St. Daniel Combon Hospital, it has helped me to help my fellow midwives on learning how to help babies breathe and helping mothers survive.
we learn from one another. What one is not performing well, you pick from your fellow midwife when you are carrying the procedure.
At least every week or in 2 weeks' time, we make sure at least some midwives have to practice so that we really improve our resuscitation skills.
Due to peer-to-peer learning, even those midwives who are not trained and even with the doctors were able to learn through the peer-to-peer learning, and we have improved on management of our babies.
I did not attend any training in helping mothers survive and helping babies survive, but through the continuous practice sessions we've had at the facility, I've learned how to help babies survive through resuscitation, that is bagging, sucking, and helping those babies who don't score well to come up. Through helping mothers survive, I've also learned how to manage postpartum hemorrhage, managing third stage of labor, management of second stage of labor, and also managing the retained placenta and many others.
We had knowledge gap in management of newborns, more especially the sick. You'd find we had challenges with the dosage and what, but through peer-to-peer learning and with the EIC materials we have, we are able to give drugs when we are conversant, knowing the dosage for the newborns according to their kilograms.
The number of deaths is decreasing. If I may say it, even so minimal now. It used to be mass, but because of peers to peers and learning from one another and taking control of that golden minute, it has helped us.
You can come back on the inside so that we have a working tea. The people outside, please come back in so that we have a working tea. I want to recognize leadership from the different health facilities and districts. I want to start by recognizing Dr. Joseph Changwe. Dr. Joseph Changwe, the director of Kombon Hospital. Is Dr. Joseph in? Yes. Thank you so much for coming. Then Miss Christine Chomhanji, the ADH of Rukunjiri. Thank you so much for coming. Dr. Mary Nyantaro, Assistant Director, Masaka Regional Referral Hospital. She's still outside. Yeah. Then Dr. Sadiq, the DH of Mitoma. Dr. Sadiq is also still outside. Yes, Dr. Sadiq, you're most welcome. I'm going to reread the, just before I invite Professor Kabachenga. Professor Kabachenga is the founder and director of the Maternal, Newborn and Child Health Institute and Bara University of Science and Technology. Professor Kabachenga holds a degree in medicine and surgery from Makerere University. He also holds a master's in public health from University of Leeds and a PhD in public health from Lund University in Sweden. And he was awarded the Tisdale Court Global Health Leadership Award from Canada Global Health Research Initiative. And throughout his career, Professor Kabachenga has successfully collaborated with several local and international institutions to support community health in rural communities. Allow me and join me to welcome Professor Kabachenga to lead us in our next plenary session.
Thank you, MC, for that very elaborate introduction. I welcome you all to session 2 of today. As you have heard, by the time you become a professor, so you have many years of getting involved in teaching and training. But specifically for Sim for Life, I was somehow involved in its beginning because it came out of our Mbarara University of Calgary collaboration, which has been ongoing for the last 20 years. I remember in the first training of trainers, I also undertook the training. I still remember the safe environment whereby although mistakes are not allowed, but it is allowed to make mistakes. Then you can sit down as a team and see where you did well and where you did not do well. And for all of us who have been through training institution, health workers, whereas we did our training the way we did, but assuming you are the patient on the other side and students are learning on you before knowing the basics, or assuming there is an emergency and now people are fumbling around, they don't know what to do. So that's why I find that simulation training is very key. Although some people confuse it with like doing away with the clinical skills training on the ward, but it allows the students to get those skills, the basic skills, before they are exposed to the patients. So we have already lost some time, so we need to gain it. In this session, we shall have 2 presentations, and each presentation is expected to take 10 minutes, and I request the presenters to really observe that time so that we do not end up again affecting the presentations to come, where people now will be expected to cut down their time. And then after the 2 presentations, we are going to have 10 minutes for question and answer session. So the first presentation is by Dr. Datas Santolino, who has been the key lead in simulation for life program or project. I hope Dr. Data was introduced. I came in late, so I cannot go into his presentation. But in case he needs us to know a bit more specifically on him, he can also give it. But as most of us know, Dr. Data has been the key lead in innovations, not only this one and several other innovations. And as a pediatrician, he decided to move even from the ward and try to identify solutions that can help in the management of patients. So, Dr. Data, you are welcome. Now. So, can I also invite Ms. Shifla Nankunda to come and take a seat here? But she's
Thank you. Professor Kavachenga was very kind to say he was partly involved. He actually planted the seed of simulation in Mbarara University. Thank you so much, Professor. So when we set up on this journey of trying to get in more partners to join the simulation network, we knew that the landscape was not leveled for everyone, and we were going to have our own challenges, and every partner is going to have his own challenges. So we set up to learn and adopt. So this morning, I'm going to share with you what we thought were adaptations to medical simulation, introduction, and institutionalization in Africa. So we knew that medical simulation being relatively new, as Professor Sarah Chiguli and many preceding speakers have said, challenges were bound to happen. So we hatched a plan. And the plan was that we will train lead simulation facilitators from all the partner institutions. After training these lead simulation facilitators for 3 days, we will then send them back to their partner institutions and task them with the responsibility of training more simulation facilitators in their institution and expose students to medical simulation. And then we set up to also provide mentorship and track adaptations that we may need to make to challenges. So this scale-up preceded 3 years of implementation of simulation in Mbarara University. So we had certain learnings that we had planned adaptations to, but we also positioned ourselves to learn and change. So the framework we were using was a simplified framework where we will identify a challenge, brainstorm about that challenge, define an adaptation, deploy that adaptation, and monitor how the adaptation plays out. So in the course of implementation, we identified a couple of challenges. So the first challenge we identified was that after the first cohort of facilitators were sent out to their facilities to start simulation sessions, that did not happen as we anticipated. There was inertia. And we realized after investigating and brainstorming was that the exposure planning for students was not as easy as we thought. We assumed that what we had figured out from Mbarara University, they were going to figure it out. So at the end of it all, what we did was we extended the simulation faculty development course from 3 days to 5 days. The 2 extra days were meant for them to work with us to think through the logistical planning on how to expose an entire class to simulation in a limited time. So we will think through the logistics, we will expose the students to simulation in a limited time, and then debrief after that. That method unlocked implementation. The third thing we show was that human resources for simulation were going to be a challenge. So you need patient actors, but you needed also facilitators, and you need realistic mannequins. to be used. And so, for human resources, what we did was that we used volunteer patient actors who were either faculty staff or students from other classes that we will train to become the patient actors. And in the process, they also learned. And for human resources as for facilitators, what we did was from Mbarara University, where the volume of simulation sessions had really gone up, we decided to train postgraduate students as simulation facilitators as well. So when we did that, then the number of scenarios that were run, not by the project staff, significantly went up. And the uptake of simulation was better among the facilitators. The third problem we ran into was space. So some universities were lucky to have dedicated simulation space. Some universities did not have simulation space. But we said simulation space was not going to deter us. So up there you will see we repurposed an open room in Muni University. We partitioned it using curtains to become scenario execution rooms. And we did that, students learned, and simulation sessions were able to go on. So the third thing we learned was that in our first phase, we learned a conversational strategy called plus delta to facilitate the discussions. Now plus delta was using this approach where you will ask the participants, what did you do well and what did you do not so well in the simulation scenario? We realized that using plus delta, the participants who had knowledge deficit could not even tell what they did well and what they did not do well. And so we were not really learning or making the students reflect on their performance adequately. So we changed the conversational strategy to advocacy inquiry, in which the facilitators will identify a performance that happened in the scenario, talk about it, say what they think about that performance, and ask the participants how they were thinking during that time when they did what they did. And that deepened reflective learning, and we were able to understand the thought processes of the students that underpinned their actions and behaviors in simulation. And advocacy inquiry was very well welcomed among the junior facilitators, the senior facilitators, and also the participants. The other thing was that in Sim for Life phase 1, we had the facilitator retention was only 32%. So the number of trained facilitators who went on to conduct simulation sessions for others was only 32%. We wanted to find a bait or a recognition system that will enhance their continued participation. So we came up with this thing called the stackable certificate. So when you attend your faculty development course, you get a Simulation Foundations course certificate of attendance. After that, when you continue running the simulation scenarios and developing more simulation scenarios, your certificates can grow as your proficiency grows. And you will hear shortly that our attendance, our retention rate for facilitators has more than doubled. The third thing we sought, when we deployed, we were in COVID. So we said, okay, we need to provide mentorship. And the mentorship we thought, because of the COVID restriction, was that facilitators will be able to record their debriefing sessions, share the videos, and we will be able to discuss those videos. The quick learning, we realized with that many facilitators were a little bit uncomfortable with that. And that was because also the skill set decayed a little bit. So we went into in-person, physical mentorship, which had cost implications as well. But it worked really well. So probably the last thing we did was that for the adaptation tracking, we had set up to use this framework, the consolidated framework for implementation research, where we will identify a challenge and then try to map a potential solution using experts from outside the institution. We realized quickly that that was not the best approach. So we changed. From CIPHER, we changed to evidence-based practice for implementing change, which used a root cause analysis approach, where you will sit with the institution, identify the challenge, do the root cause analysis, and then discuss how they would like to solve that problem. That was very empowering for the institutions because they were able to look and reflect inwards. So, our lessons is that simulation approaches can be adopted for low resource settings. Temporary spaces can be made functional for simulation, and you can leverage postgraduates, other students as patient actors. So the thought I have for you, which is a question related to that, is think about it. What are the long-term requirements for a permanent simulation program at your institution? That is a critical question that we need to answer. And we saw that in-person mentorship is effective but costly. So if it's effective but costly, then how can existing simulation partners sustain a mentorship program across geographies? We would love to have your feedback on that. And the last lesson we learned is that quality improvement identifies gaps. And using the EPIC 10 steps process, participants are able to identify their own gaps, sit down, and develop their own solutions to their own challenges. I thank you so much.
Thank you, Dr. Data, in taking us through the experiences of adopting simulation for life outside MUST. Phase one, as you heard, it was from Muni University. There are learnings that we did, but going outside MUST to other institutions, there are other sort of lessons that were learned. So for those who have comments, questions, or additions, you can jot them down. After the second presentation, we shall have that time to go through. We shall have now Shifla to take us through the next presentation. So Shifla, you are welcome. I can't read the small dots. I forgot my glasses the other side. Thank you.
Thank you, Professor Jerome. So the previous presenter was talking about simulation-based training in institutions, and probably most of the presentations that you'll receive, that you're likely to receive today, I will be talking about simulation-based training in institutions. I'm here to share a different bit, which is simulation-based training in in-service health workers, using simulation-based training for in-service health workers, using a learning methodology which is peer-to-peer learning, where health workers learn from each other, coupled with mentorship and other innovations like technologies, protecting infants remotely by SMS or Prisms, and their effect on skills for the health workers. What we are going to hear most of the time is simulation-based learning for pre-service health workers in institutions. And I'm here to share simulation-based learning, using simulation-based learning for in-service health workers. So we know that most of the time, knowledge and skills often are important, and they play a very critical role in the quality of care that we provide, especially when we talk about maternal and the newborn care that we provide. However, most of the times in our settings like low and middle income countries, maternal and newborn care are often provided by health workers like midwives and nurses, and sometimes medical officers in most of the facilities, and these do not have specialized training, or they are not specialists trained to manage newborns and mothers. And in regards to that, several interventions have been put in place, like trainings, helping mothers survive and helping babies survive, to try and bring about capacity building for them so that they can bring their skills and their knowledge for maternal and newborn care. However, these have been related to skills and knowledge decay immediately after trainings. On realization of that, in our phase 1, we designed a learning methodology called peer-to-peer learning, where health workers learn from each other. And we tested this in 18 health facilities. From that, we reported that this peer-to-peer learning methodology was important, or it assisted in skills maintenance. And then also, like, we also came to realize that as innovations like technologies, such as the clinical decision support tools, they might provide support in improving their skills and the knowledge, thus to improve outcomes, especially for the newborn. So in this second phase, as we started, we implemented those interventions, and we evaluated their effect on maternal and newborn skills, as well as in facility newborn outcomes here in Uganda. The methods that we used, we randomized 36 health facilities in the southwestern Uganda, and these 36 health facilities were randomized to either control or intervention, so that the control had 18 facilities and then the intervention had 18 facilities. We conducted trainings, helping mothers survive and helping babies survive trainings. We conducted trainings, helping mothers survive and helping babies survive trainings in both. And health workers from these facilities, they received either of the training, either helping babies survive or helping mothers survive, in either of the arms. And the total, we had these. Before and after the trainings, we conducted assessments. We assessed their knowledge and we assessed their skills in helping babies breathe, essential care for every baby, which is a component of helping babies survive. And we also assessed their skills in helping mothers survive before and after training. Regardless of the training type that you received, whether you attended HBS training or HMS training, we did both all the assessments on each and every person. And we did similar assessments after 12 months of follow-up, and then also after 18 months of follow-up. In control and intervention, both, we trained these health workers on how to facilitate practice sessions at their facilities using peer-to-peer learning, and 2 health workers from each health facility were trained to be peer facilitators. One as the HBS peer facilitator and another one as an HMS peer facilitator. In addition to the facilities in the intervention, we gave them a technology called Protecting Infants Remotely by SMS immediately after the trainings. We had planned to do quarterly mentorships for a period of 18 months, and immediately after we had finished the trainings, we embarked on a challenge that involved restrictions due to COVID-19. And the planned mentorships were actually on site, where we were supposed to travel to these sites to build capacity for these peer facilitators to mentor them. And because of the restrictions, we ended up starting our mentorships towards the 12 months assessment period. And our first mentorship was actually at around 9 months after the trainings. And in both arms, we had the training, the mentorship start at that period of time. And this proceeded, up to the end of the 18 months period. In our results, some of the facilities that we worked with, they included referral hospitals, district hospitals, health center 4s, and a few health center 3s. They included public, there are government-aided facilities, and then also private not-for-profit facilities. The health workers that we trained included enrolled midwives and enrolled nurses, as well as registered midwives and registered nurses. Some of these health workers had received training in essential care for every baby and essential care and are helping babies breathe. In our results, we observed that through trainings, these health workers gained skills, they acquired skills, and this skills acquisition was not any different in either arm, whether you were in control or intervention. But we observed that after the training, they actually lost these skills. For the assessments that we did at 12 months, we realized that their skills decayed off. They died off after the training, and this skills decay was the same, almost the same. There was no difference in both arms. Whether you are in control, red is for the intervention and the blue is for the control. There was no big difference. And this is the point where we brought in mentorship towards the 12-month assessment period. And after this, we saw the skills growth. And the skills growth was not any different in both arms. However, we observed a different trend when we looked at the health workers that received helping mothers survive training and helping babies survive training. So we saw that health workers that had received the helping babies survive training had their skills grow and decay off up to a period of 12 months, and then they improved. On the other hand, we saw that health workers who had received the helping mothers survive training had their skills stagnate up to a period of 12 months. And after that, we saw a skills growth in the helping babies breathe skills after a period of 12 months up to 18 months. We observed similar trends in the management of newborn, which is essential care for every baby. And we observed a similar trend where we had skills acquisition with decay and then the revival. And similar trends were also observed here, irrespective of the type of, depending on the type of training. We saw that health workers who had received only helping mothers survive training, their skills in management of newborn started to grow off at a time between 12 months and 18 months. On the other hand, for participants that received the HMS training, in both arms, we realized that their skills were they acquired skills after the training, and these skills were maintained across the study period. We did not observe any difference across the arms. And on the other hand, we saw that participants who received the HMS training, blue being the participants who attended the Helping Mothers Survive training, their skills grew, and even after the training, they continuously grew. But after 12 months, they started to decay. On the other hand, participants who received the HBS training, we saw their skills gradually growing up to a period of 18 months, even though they did not attend the Helping Mothers Survive training. On the other hand, much as we did not observe any differences in skills across the intervention or the control, we observed differences in the neonatal outcomes across these facilities. In the intervention where we had also included the Prisms usage, the innovation, the Prisms usage for management of newborn care, we observed that with this total number of babies being managed, there was a 20% reduction in mortality among the intervention where we had the Prisms usage or the technology usage within these facilities. And these facilities were 1.8 times more likely to refer their babies as compared to the facilities that were not using Prisms. In conclusion, we observed that a combination of mentorship, peer-to-peer learning, where health workers learn from each other, and the technology called Prisms, they helped to retrieve or to revive the newborn care skills that had died off at 12 months. And here we are talking about helping babies breathe and essential care for every baby skills. We also noted that peer-to-peer learning and mentorship, they were associated with maternal and newborn skills transfer, where we observed that learners that had not attended the Helping Mothers Survive training gained skills up to a period of 12 months, and learners who had not attended the Helping Babies Survive training, they also had skills gained through the study period. And then we also noted that the use of Prisms was associated with a 20% reduction in mortality for facilities that were using it. And with that, Prisms usage may have potential to reduce mortality within facilities in low and middle income countries. Thank you.
Thank you, Shifra, for that presentation. I hope all of us have followed the two presentations. And now it is time to give our comments, questions, to seek clarification. We shall start with the first presentation, adopting medical simulation-based learning in low and middle income countries. What needs to be changed, as presented by Dr. Data. I note in the program there will be presentations from the different institutions which participated, but now we can see from Data's presentation, which gives an overview of adopting medical simulation in the different institutions. So, can we have another mic? It is already there. Any comments, questions? At the back.
Thank you very much, Professor Kabachenga, for giving me the opportunity. And thank you very much, Dr. Data, for the great work and your presentation. I'm Gertrude Chwanuka, Mbara University of Science and Technology. So I am really happy with your innovation, specifically the one concerning video recording for mentorship. One, because I realize that it is a sustainability strategy, because once you have a video, it means that it can be shared with whoever needs it. I mean, it doesn't rot. So the question that I have for you is these recorded videos on mentorship. Are they free? Are you sharing them with the institutions that you've talked about in the partnership? Is this something that you would maybe eventually even want to put a price tag as another approach of sustainability? I want to pick your thoughts on that, because when you have a video on something that you really value, especially if it is for purposes of training, then it can easily be shared by the amongst the institutions in your partnership. But also, on the other hand, you can also put a tag, price tag, so that whoever accesses it, maybe they pay or they subscribe, as another approach of sustainability. Thank you. Let me pick your thoughts on that.
Thank you, Professor Gertrude Chwanuka. Professor Gertrude Chwanuka is the immediate past Dean, Faculty of Medicine. So he is also somehow involved with SIM for Life since it was being implemented under his time. Any other questions? Yes, second question. Mike, a bit faster. It is behind you, behind.
Thank you very much, Chair. Thank you very much, presenters. When I attended this from the beginning, I was thinking about the simulation. And I remembered as I was growing up, when Mbara University of Science and Technology had started, people in the rural areas would say, don't go to Mbara Hospital because students are going to learn from you. So people would discourage admissions here.
So Professor Gertrude's question was related to the use of videos for mentorship. So the kind of videos for mentorship we were thinking about was that after the scenarios have run, both the scenario and the debriefing session could be shared so that people in the network could be able to give feedback. And so the idea was to form a community of practice of simulation facilitators who could be able to hold their hands together and be able to say, yes, in this discussion, this is what you did very well, and this is where you could improve. That did not take off for various reasons. But just yesterday, using the same idea, Professor Yiltok was talking to me about the demand from the Nigerian students, Medical Students Union, about recording simulation scenarios for the purposes that they could be able to review those scenarios, critique as students, and see how much learning they could get from there. I think there is a lot of potential in that, especially if the scenarios are scripted out and acted for the purposes of learning, compared to the scenarios that play out and then you will debrief on them. So there is a lot of potential in that, and we need to discuss more how to actually best position that so that the scenarios can optimize learning. Thank you.
I remember in your presentation that you also said that some individuals were not comfortable being recorded. Yeah, the ethics part of it is which has to be really studied so that people, because at any time they can withdraw their consent, that they don't want the videos, the involvement to be screened. Any comment? Yes, Mike, bring the mic to the front. Here, there is a hand.
Okay, thank you very much, Professor. I'm Dr. Jerry Ishto, an alumni of MAST, but currently working with Doctors with Africa QAM, supporting interventions in Karamoja, Lango, and West Nile. My question to Dr. Data is a bit, just some clarity for me about this plus delta and advocacy inquiry. You said you used it as a way of getting feedback from the learners. How different are they? Could it have been that what we noticed could have been maybe the methodology used by the people engaging with the learners at that point to get maybe one saying that, we are not doing so well, or the other one saying, okay, we have improved in this area. Just some more details on that, on these two methods. And then the other question that I had is for Shifra. I don't want to now leave the microphone. So Shifra, more about, we observed in the graph that you shared that there was some skills growth, even when there was no package for training. And you are saying, can you kindly just explain what could, that growth in the team that did not even have any training prior to the area that you were assessing? For example, you are saying HMS training was not conducted, but the skills for helping mothers survive improved. And also there was one on helping babies survive, training not conducted, but when you followed later. So I was failing to understand how that growth could have come about. Thank you.
Yeah, data first, and then Shifra, you will respond.
So plus delta, plus for the positive, delta for the negative. So as I said, you will ask the learners, so what do you think you did well in the simulation scenario? And what did you think you did not do well in the simulation scenario? And the responses you will get is totally based on the knowledge base of the what? The learners and their self-assessment. While in advocacy inquiry, for example, if you observed that a patient who was in shock did not get IV fluid bolus, what you will do is that you will start a conversation with the learners and say, okay, let's talk about management of shock. I noticed that during the simulation scenario, the patient's blood pressure and other vitals showed that the patient was in what? Shock. But you did not give IV fluid bolus. What was happening with you at this time, at that time? So then what happens is that the participant reflects on what was really going on in their what? In their mind. So you will find that some of the participants says, oh, I did not know that a blood pressure of 60/40 for adults was low. So then you quickly realize there is a knowledge gap here. Some of the participants will be able to tell you that, oh, I noticed that the blood pressure was low, but I was assigned to taking the vitals. I thought it was the responsibility of the person on what? On drugs to give the what? The fluids. And then there you understand where they were coming from in the way they what? They acted. So when they say, oh, I did not know that 60/40 is low blood pressure in adults, then you know there's a knowledge gap. You just need to teach to it. Okay? When they say, oh, I was assigned to drugs, I noticed that and I thought the other person was going to give it, then you know there is a teamwork and communication what? Issue there. Then you are more likely to go deep and address that. So advocacy inquiry was helping the students reflect on their own what? Performance, and also enabling the facilitators to quickly know what was going on in the minds of the what? The students, so that they can decide whether to teach, complement, or do something else. Thank you.
So thank you so much. Your question was related to the skills growth among healthcare providers that did not receive a particular type of training. So the trainings were conducted in a way that different health workers attended different types of trainings. For example, I attended Helping Babies Survive training, and then he attended Helping Mothers Survive training. And both providers were trained on a learning methodology called peer-to-peer learning, where they are to facilitate learning sessions at their facilities so that practice sessions can happen or can continue at their health facilities. So we had planned to mentor these trained facilitators quarterly so that they can support other colleagues to learn from them. But like I said, the quarterly mentorship didn't happen. It came in a little bit later. And the practice sessions were happening at their health facilities from health workers. And then at the time when we assessed their skills, at different times, we observed that trend. And we anticipate that that trend was brought about by the practice sessions where health workers were helping each other to learn from the different trainings that they attended, as well as in addition to the mentorships that came in a little bit later to reinforce their capacity in supporting their colleagues. Thank you.
Yeah, we have moved to responding to Shifra's presentation. Any other questions, comments addressed to Shifra? Mike, start with the farthest at the back, and you keep on moving to the front.
Thank you so much, Shifra, for that very interesting presentation about the peer-to-peer learning. And I'm very sure it had a very big impact on the health workers' practices. I just want to know if you have gone back to see whether these practices are still going on, or do you have, maybe you presented it, I'm not sure, but do you have a sustainability plan of these practices? Because we know that they had a very big impact, especially on newborn survival. What is there? What if we went back 1 year from now? Would we find the same practices there? Or what plan do you have in that regard?
Okay. Next question. Shifra, did you get the question? Okay. There was a hand there. Okay.
Thank you so much. I'm Agatha Kevirunji, Principal Nursing Officer, Nyachibale Hospital, and we work with Sim for Life. I would like to really say that the team has done a commendable work. When we had the first training, was about helping babies breathe. And the team which trained came singing, helping babies breathe, and everyone was willing to know what they had trained about. We started disturbing Shifra, asking those things, but she assured us that there would be another training about helping mothers survive, and indeed it happened. And their mentorships also helped us as a hospital to know that the location of maternity department, where there is neonatal care unit, it was like in a swamp where there is always coldness that causes hypothermia and we would lose babies. But when they kept coming on, they made their resolutions and recommendations as a hospital. We bought room warmers and we have been able to save babies. And I'm sure in the facilities where they are working with, every midwife there knows Mama Natalie. And knowing Mama Natalie, it means knowing how to manage PPH. So I want to really thank them so much. And we pray for God's blessings upon them. And maybe, if possible, we reach every facility where delivery takes place. Thank you so much.
Thank you for that compliment. There are two hands on the right side.
Yeah, thank you so much, Shifra and Dr. Data. My name is Grace from Madara Development, Uganda. And I think I'm one of Shifra and Dr. Data's student. Yeah, this is a very good venture, but I'm wondering whether you've done some cost-based analysis of the intervention such that we can be able to uptake it. Sometimes we get excited when we see the venture, but when you go into implementation, sometimes we fail on our way. So I want to understand if we have that can help, especially the facilities, to be able to start a basic SIMS lab or to be able to support their facilities. Thank you.
Yeah, give the mic to your neighbor. I think that should be the last question or compliment on Shifra's presentation.
Thank you very much for the presentation. My question goes to Madam Shifra on the peer-to-peer learning. I'm kindly requesting to know how you know that the medical practitioners are teaching the right things to their fellow medical practitioners, because you can learn the wrong thing and then you pass it on and then cause more problems. Thank you.
Oh, I thought that was the last. Now this is the last one.
Thank you so much. My name is Nesima Rachel, and I'm a fifth-year student of medicine and surgery at Muni University of Science and Technology. So my question is to Ms. Shifra. Was there a criteria for knowing which health centers to teach these skills? Because say at the maternity ward or at the ward, pediatrics ward, there are these particular centers that keep sending referrals of situations we think they can handle from their centers. I bet most medical students or any practitioner can bear witness to me that most referrals come from, say, Nachi Valley. Yeah? So was there a criteria for knowing that we need to target centers that send in the most referrals to Bara Regional Referral, to train them so that we don't get mothers, first of all, delaying on the way to come to the hospital, but also knowing that they can manage them remotely so that maybe by the time they are referred, they have got the proper care they need. And my comment today is that simulation teaches you how to manage emergencies from the simulation lab without affecting the patients. Because most times when we are learning from the wards, we find when the senior house officers or the interns have already managed the emergencies, and so we learn from stable patients. So when you reach the simulation center, you appreciate how patients come in. Say how a malnourished patient comes in shock and how you can manage them vis-a-vis having to learn that skill or like from the wards, or having to just watch a senior house officer manage the patient, but having to use a simulation safe space to learn how they manage an emergency when it comes into the hospital. Thank you very much.
Thank you for that question. So Shifra, can you respond to those questions?
Thank you so much. I'll answer a few. We are going to share these questions because we've been working as a team. I'll start with the last person who asked about the referrals, the high referrals that are being sent by certain facilities, and about the selection criteria. Thank you so much. Regarding the selection criteria, we did a survey and we tried to identify health facilities that had that were high volume and had high challenges. And some of the facilities that you have cited out were actually some of our target points. But like I talked about it during our presentation, one of the sites that you talked about is in a refugee camp. And at that time, that was the at that time there was a lot of restrictions, especially due to COVID-related restrictions. But most of the facilities that we reached out, where there were challenges, most of those challenges have been tackled and handled. So regarding the selection was high volume, and then the challenges that we found in our survey to reach out. And then also someone else asked a question of how do we know that the health workers are teaching the right thing? It's one thing learning something and you transfer the right thing. So like I said, after the training, we trained them on how to pass on this knowledge they have acquired. And we have materials, standardized materials that we use, and then that we also provide to them that they go with to their facilities. So these materials have information or content from whatever course they will have learned. If it is helping babies survive or helping mothers survive, these materials have the content that has been provided, and they move with them to their facilities. And then they also have practice materials like mannequins where they can practice in a safe space so that there's no risk caused to the patient. And after certain times, would go to see if they are still doing the right thing. And where we find challenges, we come in to support. Thank you. I'll ask my co-presenter to answer the other two questions.
So one of the questions was on cost benefit of the intervention. And that was exactly why we developed peer-to-peer learning. So we know now, the statistic is that for you to train one health worker off-site in helping babies breathe, it costs slightly more than $200 per health provider. Now, if you have 10 health providers that you need to train, then you're looking at spending $2,000 to train 10 health workers. Now, if you use peer-to-peer learning, you will still spend maybe, you train 2 health workers, one in helping mothers survive, one in helping babies survive, and then you deploy them in their own health facility, and using this structured methodology, they are able to what? To transfer skills to the rest of their what? Their colleagues. And that is empowering the health workers from within and building a culture in the health facility of low dose, high frequency practice. So with your investment of $400, you could be able to achieve both maternal and newborn competencies in a facility where you will have spent $4,000 to what? To think. And then the issue of the retention. We know, and you will see in some of the presentations today, that the skill of newborn resuscitation that you learn very well in the training will disappear in about 3 months. So if you spend $200 to train one health worker, and that health worker is unskilled again in 3 months, that means you either invest $200 every 3 months, or You close your eyes knowing very well that they are not going to effectively resuscitate and turn your back to the babies, which is a brutal thing to do. But now with peer-to-peer learning, you know that you can stretch your what? The impact of your training for much longer. And the graphs you saw here, after training, when COVID hit, lockdown, 12 months assessment, the skills what? Went down. Almost there was no peer-to-peer practice happening in those what? Those 12 months. And then when lockdown was lifted, mentorship, peer-to-peer learning, skills what? Went up. Which means when skills are decayed, you probably may not need retraining, but use this methodology to help the health workers regain their skills. We've not done a formal costing, a cost-benefit analysis, but that is just to give you a hint from my own perspective that this has a lot of potential for cost-benefit.
As you can see, it is very interesting, but time is not on our side. So please join me to thank the two presenters for the good presentation and response to questions and queries. I now hand you over to Angela to take us in the next part. Thank you.
Thank you so much, Professor. Another round of applause for our dear Professor. Ladies and gentlemen, we are following online. And when you go to the YouTube channel, just type AYIT TV, and then you can share the link from the different persons who may wish to watch. AYIT as in E for elephant, Y for York, I for insect, T for tree. AYIT TV. Then you can share the link. And you guys have to give me commission. That announcement was serious. Ladies and gentlemen, once again I welcome you, and I'll take pride like a MUST alumnus to also invite the MUST alumni in the audience to stand up and you see the fruits of this university. I mean those working outside of MUST, but MUST alumnus. I see Dr. Lema, I see, oh yes, Mary. Oh, there they are. Yes. If it has no harm, just in a second, please, just come here in front as I'm announcing this. Ladies and gentlemen, and you know when I bring you in front here, that's money. Please hurry up. Yes, we're looking for a donation and we're looking for people to sponsor this. And we gave you knowledge, and we stand proud of you. Yes, we are building the Faculty of Medicine. Dean, this announcement, these people need to know. Yes, MUST alumni. Yes. Okay. These are products of Muni University of Science and Technology, and this is
Dr. Ik Bruno, the District Health Officer, Hueju District.
Agatha Nshabawurira, Assistant District Health Officer, Mbarara District.
I am Asusi Mildred Edna, Assistant Lecturer Nursing, Muni University.
My name is Allen Mary, Assistant Lecturer, Midwifery, Muni University.
Dr. Jerry Ishto, Advisor Programs with Doctors with Africa Kwam in Karamoja, Lango, and West Nile.
Mary Nyantaro, Pediatrician and also Deputy Hospital Director, Masaka Regional Referral Hospital.
Dr. Lema Felix Adrico, CEO, Medical Superintendent, Obs and Gyne, Nyachibale Hospital.
Dr. Kasima Mchunguzi, I was in MUST 1995, 2000. Currently, I work as the District Health Officer, Kunjiri.
Dr. Biamugisha Sadiq, Surgeon, at the same time, the DHO, Mitoma District Local Government.
Nicholas Mandela, Head of Department, Rehabilitation Department in Musana Community Development Organization, Iganga, and a physiotherapist.
Angela Nakato, I wish to be at Calgary University. So please go back and take your seats. Ladies and gentlemen, I would like to have a change in the program, and the breakout session that you see, activities, breakout session 1A and 1B is postponed to after lunch. That does not mean that we are going for lunch now. We are going for para session 3, which is going to be chaired by none other than Dr. Dora Nampija. Dr. Dora Nampija, yes. She's very fast. She doesn't want me to talk about her. Please have a seat up there as I'm introducing you. Yes, you pass the other side. Dr. Dora Nampija is a lecturer in the Department of Pediatrics at Mbarara University of Science and Technology, working with Mbarara Regional Referral Hospital. Dr. Dora deals with cardiac issues among children, and Dr. Dora is passionate about what she does. Before I hand over the microphone to her, ladies and gentlemen, we are in the land of milk and honey, and you took a lot of milk during break. Again, I'm back. Our guest of honor is called Sarah. Forget the titles. Can we stand up, ladies and gentlemen, and write her name with our bodies in capital letters? And that's why you're going to see who goes to the gym. Okay, we're starting with letter S. Go. S. Guys, can we write capital letters? S. Go. S. Okay. Letter A. Up. The middle thing. Choo. Okay. R. Down. The big stomach. And the leg. Are we there? A. Go back down. Down. Up. Down. The middle thing. And then letter H. Down. Up. Down. Up. The middle thing. Okay. Allow me to hand over to Dr. Dora Nampija, ladies and gentlemen.
Good afternoon, everyone. I'm glad to be here, and I'll be your chair for the next session. I would like to welcome Professor Sarah Chugli. I'm very glad to see you. Surprise, actually, I thought you were in Makerere, because yesterday I think they had exams. Glad to see you here. So today, we are the third plenary session. I'm going to call the speakers. So we're going to have Dr. Ndaboine Edgar from Catholic University of Health and Allied Sciences, COAS. Welcome, Doctor. You can take your seat up. Up. Then we are going to have Dr. Ochola Moses, the newest pediatrician on the block. You can also have your seat up. And then we shall have Mr. Mukama Martin, who's going to present a session. So our first presenter is going to be none other than Dr. Ndaboine Edgar from COAS, who's going to give us the experience of medical simulation at the Catholic University of Health and Allied Sciences. Thank you, sir.
Hello. Hello. Good afternoon, ladies and gentlemen. My name is Dr. Edgar Ndaboine.
I'm obstetrician and gynecologist by profession, but I also have subspecialty on gynecology oncology. But also I'm still working with obstetrics because I like a lot in obstetrics. I'll take through how Sim for Life started at KUAS, the Catholic University of Health and the Allied Sciences. We started with capacity building. This was in the year 2021. That was November. And we came here and we obtained a training of 5 days. We were 4 of them. And these people are from 4 departments. The one was from pediatric, another one from internal medicine, and the obstetric and gynecology, and also from nursing department. Later on, we went back to our area, and we started conducting a focus development course. And this was supported by the Sim for Life. And you can see from the photo, Dr. Data donated, Sim for Life donated mannequins, and the person at the middle is our DVC ARC. So the mannequin which we received for obstetrics and also for pediatrics. During the focus development course, we train about 50 faculty members, and at the same time during the course was going on, we celebrated Women's Day, and Dr. Data contributed to that. Congratulations to him. And the people who obtained the course, obtained the training, were from obstetrics and gynecology, pediatrics, surgery, and internal medicine. For School of Medicine, School of Nursing, there are diploma nurse lecturers and the Bachelor of Nursing. You can see from the diagram, we conducted 4 faculty development courses. The first one involved 4 faculty members, 14 faculty members. The second course involved 14. And then the third one involved 26. And the last one, this was only 10. And the 10 one was special one because we want to integrate the simulation training into our curriculum. So we involved the head of departments and the course coordinator. That's why there were 10. And the people who obtained that training, 29 were female and 21 were male. And these were percentage-wise from each department. There was high turn-up of female than male. I don't know why, because this was a volunteer. We didn't force people to come. We asked for people who want to participate in that training. And the results came like that. 29 were female and 21 were male. Then you need to investigate why there was low turn-up for male. We have special area in our sim lab. We don't use improvised rooms. So our sim lab consists of high fidelity rooms. These consist of the high fidelity. It has 3 areas. One is the briefing room, one control room, and one execution area. The high fidelity currently is run by anesthetic department because for us, we are not operating that machine. It's very expensive. And in the low fidelity, we have 2 debriefing rooms and 2 control rooms. And also we have 2 scenario execution rooms. And this photo was taken during our focus development course. You can see Albert there helped us during the course. So from there, we developed a master schedule for each department to bring students for training. You can see, for example, I'm coming from the Department of Static and Gynecology. I was allocated to bring students on Monday PM and on Friday PM. So Friday for senior special residents and Monday for senior undergraduate students. And the other departments as shown in the schedule. Apart from that, what we could have said on the achievement part, we were able to incorporate our simulation-based training into our curriculum, because at the time when we obtained the training, the university also established this called competence-based curriculum. So one of the competence-based curriculum involves simulation-based training, and we also went further by encouraging each department to bring students to the sim lab. This was sensitization, and we carried the sensitization activity to each department. This was through presentation and informing them what is going on at the sim lab. So when they want to bring students, they should know what is going on. So at each department, we have at least more than 4 facilitators, and one is a team lead. Also, we engage course coordinators. These course coordinators are supposed to make sure students are coming to the sim labs. Despite all this, we are still having challenges. One is financial constraint. Currently, all the activities were supported by Sim for Life Uganda and other stakeholders, especially on consumables and everything. There is also still low utilization of our sim lab. Other departments, they don't bring students as we expected. There is also shortage of personnel. We have not yet employed permanent people who are responsible for the lab. What are the future prospects? We are still thinking to continue collaborating. For example, one of the challenges we faced is the university management. So the hostel helped us on bringing some of the equipment, and also we are thinking on facilitation course for residents. This is an area where we think if we train residents to become facilitators, they will train students, and also they will pass the knowledge to area where they are going to work. Also, we are thinking to make this lab a center of research and innovation, and the utilization of SimLab in emergency care practice. And actually in our country, the government is building an emergency department in each district hospital. And the problem was these care providers were not capable of providing care to emergency patients. So the government talked to us. And later and last, we are thinking our lab to be a center for research and innovation. Thank you.
Thank you so much. We give him another round of applause to Dr. Edigar for the experience that he has shown us in Tanzania. They are making it, and we are going to take simulation further. I'm going to call Dr. Ochora Moses, who's going to give us a practical session of to teach us how to use the augmented infant resuscitator, the air device. A lot has been talked about this device, so now you're going to get at least a sneak look at what goes on in the air device and how it works. Dr. Moses, you're welcome.
Good afternoon, everyone. My name is Dr. Moses Ochora. I am a pediatrician and I work with Augmented Infant Resuscitator Project. So this afternoon, I'll be taking us through a session of learning how to use the air device. I will have both a demo, a presentation, and also a practical session. So every baby who is born should be able to breathe on their own. However, about 10% of the babies who are born are unable to breathe on their own, and they need extra help through a process called ventilation. Now, every 30-second delay in providing ventilation increases the risk of death by about 16%. This is going to contribute to very many long-term complications like cerebral palsy. We've conducted a lot of trainings. People have talked about helping babies breathe programs. And in Tanzania, after following an HPB course and health workers practicing how to bag the mannequin, they were able to reduce the early neonatal mortality by 47% within 24 hours. So the mortality within 24 hours reduced by 47%. And they also further reduced their fresh stillbirth by 24% when health workers practiced using the mannequin. Now, even after training, still about 20% of the healthcare providers fail to ventilate effectively. Now, those who ventilate effectively after training, the majority of them have a very, very pronounced skills decay. They lose their skills shortly after the training. This could be part of what is contributing to the high rate of stillbirth and newborn death from birth asphyxia. And we also know that if healthcare providers are better prepared to provide ventilation, then we can prevent very many of these deaths. And this is where the air device comes in. So air is the augmented infant resuscitator as an effective tool to enable birth attendants to attain ventilation sooner and maintain it longer. Now, for you to have an effective ventilation, you need to have a good seal between the face of the baby and the mask. And then as well, you need to be able to have a patent airway. And then you need to be able to ventilate at the right rate. So either you're neither ventilating too fast nor too slow, but then also you need to give the breath at the right pressure. So you're not giving very sharp and harsh ventilations. So the air device gives us real-time digital feedback on the air leak, the airway obstruction, the pressure at which you're ventilating, and the rate at which you're ventilating. So it is an add-on device to the existing bag and mask that we have already available in our facilities. And the air device goes between the air device, you attach the mask on the front end like this, rather the bag, and then you attach the mask at the back of the device like this. And if you're going to ventilate with the air device, we normally want you to turn it slightly to the side so that then you're able to visualize the chest rise. Okay? So when you're ventilating with the air device, there are different icons. I wish my presentation would get back on. So there are different icons that give you real-time feedback. The first icon gives you the integrity of your face mask. The second icon tells you if your airway is patent or if it is blocked. And also if you're ventilating too harshly, it will also light yellow. And then the third icon gives you your rate. So we know that green is good and red is bad. So your goal is to keep all the symbols green, signifying that you're having good quality ventilation. And we did a randomized control trial in Uganda and Boston, and health workers were randomized in two arms. There was one arm that was did a 2-minute ventilation without the air device, and another arm did a 2-minute ventilation with the air device. And what we found was that people who ventilated with the air device were able to achieve effective ventilation much sooner, and they maintained it longer than those who bagged without the air device. And this means that the air device will be able to boost the confidence of health workers who are providing ventilation. It will enable peer-to-peer learning, like we've discussed in the morning hours, and will also improve the quality, can work as a QI tool in our facilities. This work is made possible by the team of developers and our funders, and so I'm going to go to the live demonstration of the air device. I had earlier on shown you where the air device fits between the bag and the mask. So I switch on the air device, and as you see, the icons turn on, and then I'll come and get my face. I try to get a good seal, and I start to ventilate. Okay, let me get my seal. And as soon as I start ventilating, it gives me instant feedback. And what this shows is that, one, I'm having a good seal, but my airway is blocked. So when I correct it, both the airway, the seal, the rate, and the pressure are normal. So if I decide to create a significant air leak, as you can see, it turns red, and also I'm ventilating a bit too harshly, and it turns yellow, but my rate is right. So when I correct that, it will give me instant feedback. Okay. So it still shows I'm not ventilating the right way. So I reposition the head, come back, and I try to get a good seal, and then I ventilate. Okay. So it still shows I have areas to improve on my rate. So I try to. So I have attained effective ventilation. All the icons have stayed green, and my goal is to keep that longer. Now, this technology also has an application that will be able to give me my feedback in real time. So if I turn off the device, and then I try to go to the air application, this application is available on Google Play Store. If you type Augmented Infant Resuscitator, you will be able to see that. So I'm going to show you. So this is the air application. I already have an account with the air device and I've been practicing. So I start the session. So it is scanning to find the air device, which is by Bluetooth, and it's here. It's device 77. So it's going to connect, and it's now connected. And I'm going to start to ventilate, and then I will see what feedback it gives me. So I'm ventilating, and I've been able to simulate different areas, and then I try to improve my ventilation. So when I finish my ventilation, I then click End, and it's going to give me an analysis of, it's going to analyze my performance, and then give it to me in. So from this, it shows that I ventilated for 32 seconds, and it took me 7 seconds to achieve the first effective ventilation. So I took 7 seconds to get a good seal, to have a patent airway, and ventilate at the right rate and pressure. And then when I did that, I only kept in the longest effective ventilation for 5 seconds. And probably that is that streak that you see here in dark blue. So my total effective ventilation was 5 out of 32 seconds. And when I wasn't in effective ventilation, where was the problem? I had a leak for about 3 seconds. And then I had airway blockage for a very long time, this stretch in red here, for about 19 seconds. And then when it comes to the rate, I had a normal rate for about 17 seconds, these areas that you see in dark blue. And then I had areas where I had a very high rate for about 14 seconds in these areas in red. And then I also had areas where I was bugging so fast with a very harsh ventilation. So this is my performance as an individual. And however, I am registered under a facility, and for this demonstration, the facility is called Dalupe 1. So when I click that, please focus a bit here. So when I click that, it gives me the summary of Alupe 1. So in this facility called Alupe 1, there are 426 users who have practiced in the last 7 days of our practice. And we've had 62 practice sessions in the last 7 days. And this is our performance. So if you realize that this is my performance relative to that of the facility. So I have 0 seconds of fast effective ventilation, and probably I contributed that for the facility. So the other aspect about the air device is that I am then able to download this. I can download the summary and then be able to use it as a QI tool for the facility. And when you download this, eventually you can come and look for it where you normally keep. So I'll go to my files and let me look for, so, okay. So this is a summary for the facility that I've practiced in, and it's showing the number of practice sessions in the facility from 10th June to today of 16th June. It's showing us the different parameters of effect of ventilation. And so with this, you can be able to then know where the challenges are in your facility and how to improve. So I thank you very much. Again, I'll tell you the air device enables you to get real-time feedback on your ventilation. It improves the quality of your ventilation and fosters retention of skills of ventilation. And it is able to improve and also foster peer-to-peer learning. Thank you very much, and I'm very excited to meet you at the simulation marketplace in the evening for a more hands-on training on how to use the air device. Thank you.
Thank you so much, so much, Dr. Moses. We are glad when we get to know that we can invent technology and it works within our settings. And the feedback the air device gives is so exciting. Sometimes you need to look at the face of the students when they get all green. It's like they've won a lottery. So it's a good thing when we, in the evening, go to the marketplace, get your hands on, try this device out, and you'll be surprised how good you'll feel at the end of the day. I'm going to call upon Mr. Mukama to come and tell us about Prisms. Prisms is also one of the technologies that have been developed to help us where in places where you cannot get a doctor. How can you ask if you need to ask questions? Dr. Mukama, welcome. Tell us about Prisms.
All right. Thank you so much, Dr. Dora. I'm not Dr. Mukama. I'm actually an engineer. I'm a computer engineer. Dora called me Dr. Mukama. All right. Good afternoon, everyone. So my name is Martin once again, and I'll be presenting about protecting infants remotely by SMS, our Prisms ward. And what we are doing as Prisms, we are leveraging technology to save newborn lives. So I want to tell you a little bit about why we started this technology. So we discovered that globally 2.3 million babies were dying in the first month of life, with about 6,400 babies dying daily. And most of these deaths were actually happening in Africa, accounting for 90% of all global deaths. And Africa's neonatal mortality actually stands at 27 deaths per 1,000 live births, just like Uganda. And in Uganda, actually, neonatal mortality has not changed for over a decade. But what we know is that in Uganda, more than 90% of all newborn care is actually handled by midwives and nurses, instead of pediatricians and neonatologists. Yet we know that midwives are actually very good at assessment, but they lack in clinical decision making. And so we discovered the gap, we knew the gap. We knew the gap was in neonatal clinical care decision making and quality improvement that were a challenge for many health workers. And so the reason we developed technology, we developed Prisms was to bridge the gap by leveraging mobile platforms to generate management plans for sick newborns that guide nurses and midwives on what to do and how to do it. The second thing was to fuse Prisms with newborn clinical education. And those two things that we do are in line with specific national newborn guidelines that are specific to countries. So if we come to Uganda, we adapt the technology to Uganda. If we go to Tanzania, we adapt the technology to Tanzanian newborn national guidelines. So Prisms actually works offline. So when you're using the technology, you don't need any internet. But for as long as the devices connect to internet, all the data synchronizes to our server. And we leverage that data for quality improvement so that we can be in position to improve quality of care in those facilities. We also leverage the data for decision making and programmatic planning at facility, district, and national level. So this is a little bit of impact from two facilities. You can see from this first graph, this is the point where we deployed Prisms in this facility, and you can see how in facility neonatal mortality actually started dropping immediately after deploying the technology. This is another facility we deployed around this time, and neonatal mortality actually reduced. And for this facility, this data was picked from DHIS2. And you can see how Prisms actually enabled that reduction in neonatal mortality. But what we know now is that in Sim4Life facilities, there's a 20% reduction in facility neonatal mortality for facilities that were actually using the technology. So I'm presenting about Prisms Ward, but the technology that we have been deploying is called Prisms Premium. And the achievements that we have had with Prisms Premium is that we have been in position to conduct more than 111,000 assessments, and that is for a total of 42,000 babies. We have worked with 62 health facilities to date, and for all the facilities where we have deployed, neonatal mortality has been maintained below 10%. But there are some challenges that we experienced, and one of the biggest challenges was most of the health workers were complaining about workload, because of double data entry. And so we developed Prisms Ward to address those challenges. And now with Prisms Ward, we've tried to address all the challenges that we experienced with the health workers. We have also been positioned to make Prisms Ward an electronic medical record with decision support. And we have fused the QI aspects that were now at the server, we have brought them to the Prisms devices. So I acknowledge support from our different partners. I'm going to walk you through how Prisms Ward actually works in a few minutes.
Just be patient. We are trying to get the technology to cooperate with us. In a few, we shall be there. We are ready. They are going to show us how to use Prism.
Sorry about that delay. So in the next few minutes, I'm going to show you how Prism's Word actually works. So one of the changes that we've made is that for the previous technology, which is Prism's Premium, we were allowing people to just use, but now we authenticate all users of Prisms so that we can be in position to do audit trails. We know who did what at what time, okay? And this is my account. I've already signed in as Martin Mukama. So whatever I do when I'm in this account will be tied to my name. That's the audit trailing. And this is the landing page for this patient. If you look up there, so when you look up here, there is the patient ID. This patient is called him, okay? But where we start from, let me first go back. So we start from that page. So we first of all, when a patient comes, you enter their patient number. So I'll just enter test, maybe test 09. So test 09, and that patient will be in NICU. So when you look down here, it's telling me that this patient is actually, the patient ID is actually not found. So it means that this is a new patient in Prism's ward. So when I tap continue, it brings me to that page. So the information that I enter from this page is information that is not supposed to be repeated throughout the journey of that patient. So I'll enter the date of birth. I'll assume that the patient was born today. At that time, it automatically calculates the age of the patient, and then the gestational age of the mother was maybe 36 weeks. Then I tap continue. So when the patient is new, you have to first of all do an assessment on that patient before it takes you to the other page. So I'll request Dr. Dora to give me a hypothetical assessment for this child. So the weight? 2.4. The temperature? 34.5. The heart rate? 120. Respiratory rate? 46. The color? This baby is pink. Dehydration? There is no dehydration. Feeding? The feeding is poor. Capillary refill? So capillary refill is normal. It is less than or equal to 3 seconds. Noisy breathing? There's no noisy breathing. Chest indrawing? No chest indrawing. Convulsing now? The baby is not convulsing now. And then degree of jaundice? So there's no jaundice. And so once I'm done and I'm very comfortable with what I've input, I'll tap submit. And then I'll say yes, complete. In about 5 to 8 seconds, I'll have a management plan. So now, this is the primary message that the midwife will be in position to get. And this primary message will be in position to guide the midwife on what to do and how to do it, if you read through the message that has been generated. So Prisms knows that the heartbeat, respiration, and color and jaundice are actually normal. It knows that this is a preterm baby who is highly vulnerable to infections. The baby is underweight with a low temperature, so it says remove wet clothes, put skin to skin, cover with blankets and hat, and recheck in 1 hour. It detected poor feeding, it says check blood glucose or give IV 10% dextrose bolus. NG tube, if unable to cup feed. If oral feeding is not possible, give IV 10% dextrose infusion. Then detected infection signs. So it says consider complete blood count, blood cultures, give IM/IV antibiotics, consider labor puncture. Dr. Dora, do you agree? Do we all agree? Yeah, so this is the primary message. And then we have blue text has secondary messages, which is how we incorporated the clinical education components. So if I tapped on preterm baby, if I'm a midwife and I wanted to learn where preterm baby is, so Prisms knows that the preterm baby, there are babies that are born too soon and gives you additional information on how you can manage those kinds of babies. If I tapped on give IV dextrose, IV 10% dextrose, it will tell me what to do, how to mix the dosage, blah, blah, and all that information. So you just have all that information at a click. So we adapted this to the national newborn guidelines for Uganda. So any facility in Uganda, if it's using it, we know we are compliant with the national newborn guidelines. So once you're done with that, you can tap proceed, and then it takes you to that page which we first saw actually. So now we are under the account for that patient 09. But to be in position to explore all the features, I'm just going to go into an account of a patient that I've put in before so that we can see. Because if I'm to enter bit by bit, we might take a lot of time. Yet I'm standing between you and lunchtime. Okay, so my patient was him. All right, this is a patient that I've input previously. So these devices that we give are tagged or mapped to facilities, okay? So for us, we just create one account for the facility, and then the facility can be in position to add several other accounts for their users. And you can do that from register users. So you can be in position to input all your users who are going to be using the technology. Okay, and if you want to see who is registered to use the platform, you can see from that section. So these are the demo users that we have registered for this hospital, which is Camtech Uganda Hospital. And then we also capture demographics. We capture demographics for the baby, and that's the information that we capture under demographics. For this baby, I'd already entered all the demographic details. That's why you see them in. But for the previous baby, for her to enter will take a lot of time. But this is the information that we actually capture when we are registering demographics for the baby. And it is an extract from the forms that are currently used in the different health facilities in Uganda. So we also capture the demographics for the mother. And that's the information that we actually capture when we are looking at demographics for the mother. Okay, so we know that doctors enjoy writing clinical notes just to remind them of what they saw in the child. So we added the clinical notes. So you can write your clinical notes anytime if you're a doctor and you're using this technology. And that will actually be stored in the Prisms Word application. So you can also perform a systems exam on the child and input those findings in the Prisms Word application. So, and for systems exam, we examine for tone, for skin, for head, fontanelle, face, nose, eyes, fundal reflex, and those other details. And the systems exam can be done anytime. Each time you're doing an assessment, if you feel the child has changed, you can actually do another systems exam, and that will also be recorded. With Prisms Word now, you can be in position to prescribe drugs to give the child. So you can see from here that I can be in position to, if a drug is already prescribed, you can see up here, these are drugs that I had prescribed, and these are the ones that I actually canceled. And just like I said, because we do audit trailing, you can see I can tell who actually canceled this drug and when they canceled it. So I know IV gentamicin was actually canceled by a doctor called Jimmy. Okay, and I know that the other ones were described like ibuprofen was prescribed by a doctor called Martin, and IV gentamicin was prescribed by a doctor called Martin. So we know who is doing what now, as opposed to the previous one that we had. And you can decide to prescribe more drugs if you feel the child actually needs them. So you can tap the drug you want to prescribe, you put the duration, and then you can be in position to prescribe that drug. If there are instructions for taking that drug, maybe take with milk or with plenty of water, you can also put those instructions in there. Okay, and once the drugs are prescribed, you can be in position to actually give the drugs that are prescribed. And Prisms automatically knows when a particular drug is given and when the next dose should be. Yeah, so if you give this now, it knows that the next dose should be on that date at 9. Okay. With Word now, you can also order for investigations. Yeah, so you can input the investigations you want to order for. And once the results, if the investigation is done, you can just tap done. We are not capturing the results for now, but you can mark it as a done investigation or a not done investigation, and the doctor will know that those results are actually available. So what we've added in is also the vital trends. So we need to know how the baby is actually progressing. So we can see from here the temperature trends. If this child was 36, we can see the temperature dropped a little bit and then rose. Yeah, so we can be in position to see the trends of temperature. For this child, we can be in position to see the trends of weight, if the child is actually gaining. If they have been at the facility for so long, maybe 2 weeks, you can be in position to tell if the child is actually gaining weight. You can see their heart rate trends, and you can also see the respiratory rate trends now. So let me go to the patient report. So everything that you perform on the child will actually be captured on the patient report. And this patient report can actually be downloaded. So if you wanted to add this patient report to the patient file, you can just download it and have it actually printed, saving you the bits of double data entry that most of the health workers were actually telling us. So this is what I had captured on this patient. So everything that I performed on this patient is actually available. The assessments that I did, the generated management plan, and even the drugs that I prescribed and those that were given, and the requests, the investigation requests that I prescribed, and those that were done and those that were not done. You can tell from there. So each patient that you enter in Prisms can be discharged through Prisms. So if I wanted to discharge this patient, I can go under the discharge menu link and I can be in position to discharge the patient. So under settings, we wanted to create autonomy so that once we deploy this technology in the different health facilities, we don't have to go back to ask them what kind of drugs they have so they can enter them. So we just give them the account and they can be in position to input the kinds of drugs they have, under settings, the kind of investigations that they do, and they can also enter the different drug categories because different drugs are actually categorized. So let me go to facility indicators. So we added this facility indicator bit to help us understand the utilization of Prisms in the different health facilities. So what we do is we pick information from the different hospital registers, input it, and then compare it with what we have in the Prisms database to tell the utilization. And what we've discovered is that for hospitals that have high utilization of Prisms, mortality is actually very, very low. This is the second last feature where you can actually be in position to see how the hospital is performing. The QI indicators. Let me search from 1st of April. So for QI indicators, we can be in position to retrieve data on prevalence of thermal care indicators, thermal indicators. We can be in position to also tell about growth rate, which babies are growing well. And then we can be in position to report on total admissions, discharges, and death in a particular facility. And since we have all the data, we can add in the different quality improvement indicators that we may want as per requests from the different health facilities. But this is what we added for now. And the other thing that we know is that When a midwife goes to the ward, they are interested in knowing how many children are there and the kind of drugs, the drug requirement for the day. So we added this feature to ease the life of the midwife. So if you're searching for drugs, you don't have to keep picking one by one because you're seeing a patient at a time. You can arrange all your drugs and then you go and give the drugs for all your patients. So this shows the drug requirement for this ward for today. Thank you so much.
I'll call you Dr. Martin because if you save a life, you definitely become a doctor. Thank you so much, Martin. And thanks for this interesting presentation. Prism is really a very interesting thing. And I don't think it's only for the midwives, as you insist, it's for all of us health workers. And can ease all our work. It can reduce on the paper trails that we have to do and gives us really adequate information. For the purpose of being able to go for our lunch, I'll just take 2 questions, and the rest we shall discuss them during the lunch break and also during the sim market. Any questions? I'll take 2 questions. So I'll take 1 here and 1 at the back. Please, microphone.
Thank you very much for the presentation. My name is Derek Nyonshima, a medical student in 4th year at Muni University. I have seen that the Prism ward is an excellent tool for all of us. However, I would like to know if the Prism ward is able to automatically calculate the dosage. For example, if you're giving ampicillin 50 milligrams per kilogram, I noticed that there is an entry point for the weight of the baby. If you say you want to give ampicillin, will it calculate for you the total dosage that you're supposed to give?
Thank you so much, Niyoshima. Thanks. Let's take the next question, and Dr. Martin or anybody else will answer after that question.
Thank you so much for that question. I think we've not been in position to explore all the features because of time, but actually Prism's word calculates the dosage. Because when you're entering the drug, you enter the dosage per kg. So based on the kilograms of the child, Prisms will be in position to give you the appropriate dosage. Yeah.
Thank you so much. Good afternoon, everyone. My name is Lugaju Charles, and I'm a 4th year medical student at MUST. My question goes to the Augmented Infant Resuscitator team. I would like to find out if there's an option of highlighting if, let me say, a neonate or a newborn has, let me say, structure abnormalities with their lungs. An example of pulmonary hypoplasia. Is there a possibility of this tool, this new innovation, being able to measure the lung volumes and maybe give you an indication to show that we could be having such a case? Yes, thank you.
Thank you so much. This question goes to Moses. And it's our last question. The other questions will be discussed during the lunch break.
Thank you very much, Charles, for that thought-provoking question. What the air device is able to do is to tell you if your airway is either patent or blocked. And from that, you can infer what could be causing the blockage based on maybe your research or the clinical knowledge that you have then. We are still unable to find out if you have a structural abnormality or not, but if your airway is blocked, then you know there is something blocking it and you can find out. And the second part about measuring lung volumes, I would tell you that when I told you that the air device measures how harsh you ventilate, so that in medical terms is maybe what we'd call the PEEP, is your lung pressures. We will not be able to tell you that this is the exact, but what air has done is that it tells you that this is sufficient and this is way above. But the small, intricate details are not yet there. But that's a very thought-provoking question. And I think the team of developers, we shall take note and see what we can do next. But thanks a lot for the question.
Thank you so much. You've been a wonderful audience. Let's give a hand clap to our presenters. And I have the privilege to announce that lunch is ready outside, so we are free to go for lunch. Thank you so much. Thank you. You did well. I like Prisms. I want you to know now.
We agreed to talk about our mistakes.
Also known as MAST, acknowledge that skills and knowledge decline after a short period of training. Hence, they designed the peer-to-peer methodology where health workers can practice and learn from each other at their health facilities.
We received invitation from Mbarara University on Sims for Life, where we sent 4 midwives on 2 occasions. They were trained on help mothers survive and help babies breathe.
We traveled to different sites that the peer-to-peer learning methodology has been implemented. With this learning methodology, health workers are supported to facilitate practical sessions at their facilities. This is a life-changing situation as teams embark on saving babies and mothers.
As a peer lead at St. Daniel Combone Hospital, it has helped me to help my fellow midwives on learning how to help babies breathe and helping mothers survive.
We learn from one another. What one is not performing well, you pick from your fellow midwife when you are carrying the procedure.
At least every week or in 2 weeks' time, we make sure at least some midwives have to practice so that we really improve our resuscitation skills.
Due to peer-to-peer learning, even those midwives who are not trained and even with the doctors were able to learn through the peer-to-peer learning, and we have improved on management of our babies.
I did not attend any training in helping mothers survive and helping babies survive, but through the continuous practice sessions we've had at the facility, I've learned how to help babies survive through resuscitation, that is bagging, sucking, and helping those babies who don't score well to come up. Through helping mothers survive, I've also learned how to manage postpartum hemorrhage, managing third stage of labor, management of second stage of labor, and also managing the retained placenta and many others.
We had knowledge gap in management of newborns, more especially the sick. You'd find we had challenges with the dosage and what, but through peer-to-peer learning and with the EIC materials we are able to give drugs when we are conversant, knowing the dosage for the newborns according to their kilograms.
The number of deaths is decreasing. If I may say it, even so minimal now. It used to be mass, but because of peers to peers and learning from one another and taking control of that golden minute, it has helped us.
The peer-to-peer training has so far covered 54 sites in southwestern Uganda. Several organizations have partnered with Sim for Life project to extend this methodology in different parts of the country.
Peer-to-peer learning has not only stopped at our facility, this facility being a health sub-district for our constituency, Igara West, we have done the same training to all the facilities which are under our jurisdiction. Usually we invite midwives here on a quarterly basis, and we have been able to get our trained midwives on peer-to-peer learning in these sessions to train them, and even after they have these midwives who are invited to also also do the same kind of training on peer-to-peer. So this has helped not only our facility, but all our constituency, all the staff within our constituency to learn peer-to-peer sessions and to be able to manage babies who are born with some bit of distress.
In our reports, babies who score lower have improved greatly within a few minutes. Then also our referral numbers have reduced because we would refer almost every baby who would be born asphyxiated. But now we do resuscitation within a short period, the baby is gaining, and we continue with the management. It has also helped us to prevent wastage of drugs because you know what is needed for a particular child. Then also in management of our mothers, especially PPH, since it is one of the major causes of death among the mothers, pregnant women, and those who have delivered. But through peer-to-peer, we've also improved our skills of resuscitation and reactive management of third stage, and in case of PPH, the steps to follow so as to achieve a better health within a shortest period. Also, preeclampsia and eclampsia, most midwives had the challenge of giving out those drugs, injections, magnesium sulfate, hydralazine. Most of us would give, and instead of saving a life, maybe you cause a problem instead.
This methodology has also been adopted for implementation in different sites in Canada.
We thank Sim for Life, Mbaraya University, Science and Technology for bringing us peer-to-peer learning. And you have made us save life and life of our children and mother. Thank you very much. May God be the one to bless you and reward you. Thank you.
Special thanks go to our partners in the University of Calgary, Canada, under the leadership of Professor Narini Singal, who has worked tirelessly to see this project make headway. We acknowledge the support from the district leadership, the different health workers in different health facilities, mothers and their families, and the MUST Team Sim for Life project. Thank you all. I have been your narrator, Angela Nakato from the Public Relations Office. Succeed, we must.
We agree to talk about our mistakes, and all the mistakes are chances to learn.
In learning, we will teach, and in teaching, we will learn. Sim for Life project based at Muni University of Science and Technology, also known as MUST, acknowledged that skills and knowledge decline after a short period of training. Hence, they designed the peer-to-peer methodology where health workers can practice and learn from each other at their health facilities.
We received invitation from Mbarara University on Sims for Life, where we sent 4 midwives on 2 occasions. They were trained on help mothers survive and help babies breathe.
We traveled to different sites that the peer-to-peer learning methodology has been implemented. With this learning methodology, health workers are supported to facilitate practical sessions at their facilities. This is a life-changing situation as teams embark on saving babies and mothers.
As a peer lead at St. Daniel Combon Hospital, it has helped me to help my fellow midwives on learning how to help babies breathe and helping mothers survive.
We learn from one another. What one is not performing well, you pick from your fellow midwife when you are carrying the procedure.
At least every week or in 2 weeks' time, we make sure at least some midwives have to practice so that we really improve our resuscitation skills.
Due to peer-to-peer learning, even those midwives who are not trained and even with the doctors were able to learn through the peer-to-peer learning, and we have improved on management of our babies.
I did not attend any training in helping mothers survive and helping babies survive, but through the continuous practice sessions we've had at the facility, I've learned how to help babies survive through resuscitation, that is bagging, sucking, and helping those babies who don't score well to come up. Through helping mothers survive, I've also learned how to manage postpartum hemorrhage, managing third stage of labor, management of second stage of labor, and also managing the retained placenta and many others.
We had knowledge gap in management of newborns, more especially the sick. You'd find we had challenges with the dosage and what, but through peer-to-peer learning and with the EIC materials we have, we are able to give drugs when we are conversant, knowing the dosage for the newborns according to their kilograms.
The number of deaths is decreasing. If I may say it, even so minimal now. It used to be mass, but because of peers to peers and learning from one another and taking control of that golden minute, it has helped us.
The peer-to-peer training has so far covered 54 sites in southwestern Uganda. Several organizations have partnered with Sim for Life project to extend this methodology in different parts of the country.
Peer-to-peer learning has not only stopped at our facility, this facility being a health sub-district for our constituency, Igara West, we have done the same training to all the facilities which are under our jurisdiction. Usually we invite midwives here on a quarterly basis, and we have been able to get our trained midwives on peer-to-peer learning in these sessions to train them, and even after they have these midwives who are invited to also also do the same kind of training on peer-to-peer. So this has helped not only our facility, but all our constituency, all the staff within our constituency to learn peer-to-peer sessions and to be able to manage babies who are born with some bit of distress.
In our reports, babies who score lower have improved greatly within a few months. Then also our referral numbers have reduced because we would refer almost every baby who would be born asphyxiated. But now we do resuscitation within a short period, the baby is gaining and we continue with the management. It has also helped us to prevent wastage of drugs because you know what is needed for a particular child. Then also in management of our mothers, especially PPH, since it is one of the major causes of death among the mothers, pregnant women, and those who have delivered. But through peer-to-peer, we've also improved our skills of resuscitation and reactive management of third stage, and in case of PPH, the steps to follow so as to achieve a better health within a shortest period. Also, preeclampsia and eclampsia, most midwives had the challenge of giving out those drugs, injections, magnesium sulfate, hydralazine. Most of us would give, and instead of saving a life, maybe you cause a problem instead.
This methodology has also been adopted for implementation in different sites in Canada.
We thank Sim for Life, Muni University, Science and Technology for bringing us peer-to-peer learning. And you have made us save life and life of our children and mother. Thank you very much. May God be the one to bless you and reward you. Thank you.
Special thanks go to our partners in the University of Calgary, Canada, under the leadership of Professor Narini Singal, who has worked tirelessly to see this project make headway. We acknowledge the support from the district leadership, the different health workers in different health facilities, mothers and their families, and the MUST Team Sim for Life project. Thank you all. I have been your narrator, Angela Nakato, from the Public Relations Office. Succeed, we must.
We agree to talk about our mistakes, and all the mistakes are chances to learn.
In learning, we will teach, and in teaching, we will learn. Sim for Life project based at Muni University of Science and Technology, also known as MUST, acknowledge that skills and knowledge decline after a short period of training. Hence, they designed the peer-to-peer methodology where health workers can practice and learn from each other at their health facilities.
We received invitation from Muni University on Sims for Life, where we sent 4 midwives on 2 occasions. They were trained on help mothers survive and help babies breathe.
We traveled to different sites that the peer-to-peer learning methodology has been implemented. With this learning methodology, health workers are supported to facilitate practical sessions at their facilities. This is a life-changing situation as teams embark on saving babies and mothers.
As a peer lead at St. Daniel Combon Hospital, it has helped me to help my fellow midwives on learning how to help babies breathe and helping mothers survive.
We learn from one another. What one is not performing well, you pick from your fellow midwife when you are carrying the procedure.
At least every week or in 2 weeks' time, we make sure at least some midwives have to practice so that we really improve our resuscitation skill.
Due to peer-to-peer learning, even those midwives who are not trained, and even with the doctors, were able to learn through peer-to-peer learning, and we have improved on management of our babies.
I did not attend any training in helping mothers survive and helping babies survive, but through the continuous practice sessions we've had at the facility, I've learned how to help babies survive through resuscitation, that is bagging, sucking, and helping those babies who don't score well to come up. Through helping mothers survive, I've also learned how to manage postpartum hemorrhage, managing third stage of labor, management of second stage of labor, and also managing the retained placenta and many others.
We had knowledge gap in management of newborns, more especially the sick. You'd find we had challenges with the dosage and what, but through peer-to-peer learning and with the EIC materials we are able to give drugs when we are conversant, knowing the dosage for the newborns according to their kilograms.
The number of deaths is decreasing. If I may say it, even so minimal now. It used to be mass, but because of peers to peers and learning from one another and taking control of that golden minute, it has helped us.
The peer-to-peer training has so far covered 54 sites in southwestern Uganda. Several organizations have partnered with Sim for Life project to extend this methodology in different parts of the country.
Peer-to-peer learning has not only stopped at our facility, this facility being a health sub-district for our constituency, Igara West, we have done the same training to all the facilities which are under our jurisdiction. Usually we invite midwives here on a quarterly basis, and we have been able to get our trained midwives on peer-to-peer learning in these sessions to train them, and even after they have these midwives who are invited to also also do the same kind of training on peer-to-peer. So this has helped not only our facility, but all our constituency, all the staff within our constituency to learn peer-to-peer sessions and to be able to manage babies who are born with some bit of distress.
In our reports, babies who score lower have improved greatly within a few minutes. Then also our referral numbers have reduced because we would refer almost every baby who would be born asphyxiated. But now we do resuscitation within a short period, the baby is gaining, and we continue with the management. It has also helped us to prevent wastage of drugs because you know what is needed for a particular child. Then also in management of our mothers, especially PPH, since it is one of the major causes of death among the mothers, pregnant women, and those who have delivered. But through peer-to-peer, we've also improved our skills of resuscitation and reactive management of third stage, and in case of PPH, the steps to follow so as to achieve a better health within a shortest period. Also, preeclampsia and eclampsia, most midwives had the challenge of giving out those drugs, injections, magnesium sulfate, hydralazine. Most of us would give, and instead of saving a life, maybe you cause a problem instead.
This methodology has also been adopted for implementation in different sites in Canada.
We thank Sim for Life, Muni University, Science and Technology for bringing us peer-to-peer learning. And you have made us save life and life of our children and mother. Thank you very much. May God be the one to bless you and reward you. Thank you.
Special thanks go to our partners in the University of Calgary, Canada, under the leadership of Professor Narini Singhal, who has worked tirelessly to see this project make headway. We acknowledge the support from the district leadership, the different health workers in different health facilities, mothers and their families, and the MUST Team Sim for Life project. Thank you all. I have been your narrator, Angela Nakato, from the Public Relations Office. Succeed, we must.
We agree to talk about our mistakes, and all the mistakes are chances to learn.
In learning, we will teach, and in teaching, we will learn. Sim for Life project based at Muni University of Science and Technology, also known as MUST, acknowledged that skills and knowledge decline after a short period of training. Hence, they designed the peer-to-peer methodology where health workers can practice and learn from each other at their health facilities.
We received invitation from Barara University on Sims for Life, where we sent 4 midwives on 2 occasions. They were trained on help mothers survive and help babies breathe.
We traveled to different sites that the peer-to-peer learning methodology has been implemented. With this learning methodology, health workers are supported to facilitate practical sessions at their facilities. This is a life-changing situation as teams embark on saving babies and mothers.
As a peer lead at St. Daniel Combon Hospital, it has helped me to help my fellow midwives on learning how to help babies breathe and helping mothers survive.
We learn from one another. What one is not performing well, you pick from your fellow midwife when you are carrying the procedure.
At least every week or in 2 weeks' time, we make sure at least some midwives have to practice so that we really improve our resuscitation skills.
Due to peer-to-peer learning, even those midwives who are not trained and even with the doctors were able to learn through the peer-to-peer learning, and we have improved on management of our babies.
I did not attend any training in helping mothers survive and helping babies survive, but through the continuous practice sessions we've had at the facility, I've learned how to help babies survive through resuscitation, that is bagging, sucking, and helping those babies who don't score well to come up. Through helping mothers survive, I've also learned how to manage postpartum hemorrhage, managing third stage of labor, management of second stage of labor, and also managing the retained placenta and many others.
We had knowledge gap in management of newborns, more especially the sick. You'd find we had challenges with the dosage and what, but through peer-to-peer learning and with the EIC materials we are able to give drugs when we are conversant, knowing the dosage for the newborns according to their kilograms.
The number of deaths is decreasing. If I may say it, even so minimal now. It used to be mass, but because of peers to peers and learning from one another and taking control of that golden minute, it has helped us.
The peer-to-peer training has so far covered 54 sites in southwestern Uganda. Several organizations have partnered with Sim for Life project to extend this methodology in different parts of the country.
Peer-to-peer learning has not only stopped at our facility, this facility being a health sub-district for our constituency, Igara West, we have done the same training to all the facilities which are under our jurisdiction. Usually we invite midwives here on a quarterly basis, and we have been able to get our trained midwives on peer-to-peer learning in these sessions to train them, and even after they have these midwives who are invited to also also do the same kind of training on peer-to-peer. So this has helped not only our facility, but all our constituency, all the staff within our constituency to learn peer-to-peer sessions and to be able to manage babies who are born with some bit of distress.
In our reports, babies who score lower have improved greatly within a few minutes. Then also our referral numbers have reduced, because we would refer almost every baby who would be born asphyxiated. But now we do resuscitation within a short period, the baby is gaining, and we continue with the management. It has also helped us to prevent wastage of drugs, because you know what is needed for a particular child. Then also in management of our mothers, especially PPH, since it is one of the major causes of death among the mothers, pregnant women, and those who have delivered. But through peer-to-peer, we've also improved our skills of resuscitation and reactive management of third stage, and in case of PPH, the steps to follow so as to achieve a better health within a shortest period. Also, preeclampsia and eclampsia, most midwives had the challenge of giving out those drugs, injections, magnesium sulfate, hydralazine. Most of us would give, and instead of saving a life, maybe you cause a problem instead.
This methodology has also been adopted for implementation in different sites in Canada.
We thank Sim for Life, Muni University, Science and Technology for bringing us peer-to-peer learning. And you have made us save life and life of our children and mother. Thank you very much. May God be the one to bless you and reward you. Thank you.
Special thanks go to our partners in the University of Calgary, Canada, under the leadership of Professor Narini Singal, who has worked tirelessly to see this project make headway. We acknowledge the support from the district leadership, the different health workers in different health facilities, mothers and their families, and the MUST Team Sim for Life project. Thank you all. I have been your narrator, Angela Nakato, from the Public Relations Office. Succeed, we must.
We agree to talk about our mistakes, and all the mistakes are chances to learn.
In learning, we will teach, and in teaching, we will learn. Sim for Life project, based at Muni University of Science and Technology, also known as MUST, acknowledge that skills and knowledge decline after a short period of training. Hence, they designed the peer-to-peer methodology where health workers can practice and learn from each other at their health facilities.
We received invitation from Muni University on Sims for Life, where we sent 4 midwives on 2 occasions. They were trained on help mothers survive and help babies breathe.
We traveled to different sites that the peer-to-peer learning methodology has been implemented. With this learning methodology, health workers are supported to facilitate practical sessions at their facilities. This is a life-changing situation as teams embark on saving babies and mothers.
As a peer lead at St. Daniel Combon Hospital, it has helped me to help my fellow midwives on learning how to help babies breathe and helping mothers survive.
We learn from one another. What one is not performing well, you pick from your fellow midwife when you are carrying the procedure.
At least every week or in 2 weeks' time, we make sure at least some midwives have to practice so that we really improve our resuscitation skills.
Due to peer-to-peer learning, even those midwives who are not trained and even with the doctors were able to learn through the peer-to-peer learning, and we have improved on management of our babies.
I did not attend any training in helping mothers survive and helping babies survive, but through the continuous practice sessions we've had at the facility, I've learned how to help babies survive through resuscitation, that is bagging, sucking, and helping those babies who don't score well to come up. Through helping mothers survive, I've also learned how to manage postpartum hemorrhage, managing third stage of labor, management of second stage of labor, and also managing the retained placenta and many others.
We had knowledge gap in management of newborns, more especially the sick. You'd find we had challenges with the dosage and what, but through peer-to-peer learning and with the EIC materials we are able to give drugs when we are conversant, knowing the dosage for the newborns according to their kilograms.
The number of deaths is decreasing. If I may say it, even so minimal now. It used to be mass, but because of peers to peers and learning from one another and taking control of that golden minute, it has helped us.
The peer-to-peer training has so far covered 54 sites in southwestern Uganda. Several organizations have partnered with Sim for Life project to extend this methodology in different parts of the country.
Peer-to-peer learning has not only stopped at our facility, this facility being a health sub-district for our constituency, Igara West, we have done the same training to all the facilities which are under our jurisdiction. Usually we invite midwives here on a quarterly basis, and we have been able to get our trained midwives on peer-to-peer learning in these sessions to train them, and even after they have these midwives who are invited to also also do the same kind of training on peer-to-peer. So this has helped not only our facility, but all our constituency, all the staff within our constituency to learn peer-to-peer sessions and to be able to manage babies who are born with some bit of distress.
In our reports, babies who score lower have improved greatly within a few minutes. Then also our referral numbers have reduced because we would refer almost every baby who would be born asphyxiated. But now we do resuscitation within a short period, the baby is gaining, and we continue with the management. It has also helped us to prevent wastage of drugs because you know what is needed for a particular child. Then also in management of our mothers, especially PPH, since it is one of the major causes of death among the mothers, pregnant women, and those who have delivered. But through peer-to-peer, we've also improved our skills of resuscitation and reactive management of third stage, and in case of PPH, the steps to follow so as to achieve a better health within a shortest period. Also, preeclampsia and eclampsia, most midwives had the challenge of giving out those drugs, injections, magnesium sulfate, hydralazine. Most of us would give, and instead of saving a life, maybe you cause a problem instead.
This methodology has also been adopted for implementation in different sites in Canada.
We thank Sim for Life, Muni University, Science and Technology for bringing us peer-to-peer learning. And you have made us save life and life of our children and mother. Thank you very much. May God be the one to bless you and reward you. Thank you.
Special thanks go to our partners in the University of Calgary, Canada, under the leadership of Professor Narini Singhal, who has worked tirelessly to see this project make headway. We acknowledge the support from the district leadership, the different health workers in different health facilities, mothers and their families, and the MUST Team Sim for Life project. Thank you all. I have been your narrator, Angela Nakato, from the Public Relations Office. Succeed, we must.
We agree to talk about our mistakes, and all the mistakes are chances to learn.
In learning, we will teach, and in teaching, we will learn. Sim for Life project, based at Muni University of Science and Technology, also known as MUST, acknowledged that skills and knowledge decline after a short period of training. Hence, they designed the peer-to-peer methodology where health workers can practice and learn from each other at their health facilities.
We received invitation from Barara University on Sims for Life, where we sent 4 midwives on 2 occasions. They were trained on help mothers survive and help babies breathe.
We traveled to different sites that the peer-to-peer learning methodology has been implemented. With this learning methodology, health workers are supported to facilitate practical sessions at their facilities. This is a life-changing situation as teams embark on saving babies and mothers.
As a peer lead at St. Daniel Combon Hospital, it has helped me to help my fellow midwives on learning how to help babies breathe and helping mothers survive.
We learn from one another. What one is not performing well, you pick from your fellow midwife when you are carrying the procedure.
At least every week or in 2 weeks' time, we make sure at least some midwives have to practice so that we really improve our resuscitation skill.
Due to peer-to-peer learning, even those midwives who are not trained and even with the doctors were able to learn through the peer-to-peer learning, and we have improved on management of our babies.
I did not attend any training in helping mothers survive and helping babies survive, but through the continuous practice sessions we've had at the facility, I've learned how to help babies survive through resuscitation, that is bagging, sucking, and helping those babies who don't score well to come up. Through helping mothers survive, I've also learned how to manage postpartum hemorrhage, managing third stage of labor, management of second stage of labor, and also managing the retained placenta and many others.
We had knowledge gap in management of newborns, more especially the sick. You'd find we had challenges with the dosage and what, but through peer-to-peer learning and with the EIC materials we have, we are able to give drugs when we are conversant, knowing the dosage for the newborns according to their kilograms.
The number of deaths is decreasing. If I may say it, even so minimal now. It used to be mass, but because of peers to peers and learning from one another and taking control of that golden minute, it has helped us.
Have
The peer-to-peer training has so far covered 54 sites in southwestern Uganda. Several organizations have partnered with Sim for Life project to extend this methodology in different parts of the country.
Peer-to-peer learning has not only stopped at our facility, this facility being a health sub-district for our constituency, Igara West, we have done the same training to all the facilities which are under our jurisdiction. Usually we invite midwives here on a quarterly basis, and we have been able to get our trained midwives on peer-to-peer learning in these sessions to train them, and even after they have these midwives who are invited to also also do the same kind of training on peer-to-peer. So this has helped not only our facility, but all our constituency, all the staff within our constituency to learn peer-to-peer sessions and to be able to manage babies who are born with some bit of distress.
In our reports, babies who score lower have improved greatly within a few minutes. Then also our referral numbers have reduced because we would refer almost every baby who would be born asphyxiated. But now we do resuscitation within a short period, the baby is gaining and we continue with the management. It has also helped us to prevent wastage of drugs because you know what is needed for a particular child. Then also in management of our mothers, especially PPH, since it is one of the major causes of death among the mothers, pregnant women, and those who have delivered. But through peer-to-peer, we've also improved our skills of resuscitation and reactive management of third stage, and in case of PPH, the steps to follow so as to achieve a better health within a shortest period. Also, preeclampsia and eclampsia, most midwives had the challenge of giving out those drugs, injections, magnesium sulfate, hydralazine. Most of us would give, and instead of saving a life, maybe you cause a problem instead.
This methodology has also been adopted for implementation in different sites in Canada.
We thank Sim for Life, Muni University, Science and Technology for bringing us peer-to-peer learning. And you have made us save life and life of our children and mother. Thank you very much. May God be the one to bless you and reward you. Thank you.
Special thanks go to our partners in the University of Calgary, Canada, under the leadership of Professor Narini Singal, who has worked tirelessly to see this project make headway. We acknowledge the support from the district leadership, the different health workers in different health facilities, mothers and their families, and the MUST Team Sim for Life project. Thank you all. I have been your narrator, Angela Nakato, from the Public Relations Office. Succeed, we must.
We agree to talk about our mistakes, and all the mistakes are chances to learn.
In learning, we will teach, and in teaching, we will learn. Sim for Life project based at Muni University of Science and Technology, also known as MUST, acknowledged that skills and knowledge decline after a short period of training. Hence, they designed the peer-to-peer methodology where health workers can practice and learn from each other at their health facilities.
We received invitation from Muni University on Sims for Life, where we sent 4 midwives on 2 occasions. They were trained on help mothers survive and help babies breathe.
We traveled to different sites that the peer-to-peer learning methodology has been implemented. With this learning methodology, health workers are supported to facilitate practical sessions at their facilities. This is a life-changing situation as teams embark on saving babies and mothers.
As a peer lead at St. Daniel Combon Hospital, it has helped me to help my fellow midwives on learning how to help babies breathe and helping mothers survive.
We learn from one another. What one is not performing well, you pick from your fellow midwife when you are carrying the procedure.
At least every week or in 2 weeks' time, we make sure at least some midwives have to practice so that we really improve our resuscitation skill.
Due to peer-to-peer learning, even those midwives who are not trained and even with the doctors were able to learn through peer-to-peer learning, and we have improved on management of our babies.
I did not attend any training in helping mothers survive and helping babies survive, but through the continuous practice sessions we've had at the facility, I've learned how to help babies survive through resuscitation, that is bagging, sucking, and helping those babies who don't score well to come up. Through helping mothers survive, I've also learned how to manage postpartum hemorrhage, managing third stage of labor, management of second stage of labor, and also managing the retained placenta and many others.
We had knowledge gap in management of newborns, more especially the sick. You'd find we had challenges with the dosage and what, but through peer-to-peer learning and with the EIC materials we have, we are able to give drugs when we are conversant, knowing the dosage for the newborns according to their kilograms.
The number of deaths is decreasing. If I may say it, even so minimal now. It used to be mass, but because of peers to peers and learning from one another and taking control of that golden minute, it has helped us.
The peer-to-peer training has so far covered 54 sites in southwestern Uganda. Several organizations have partnered with Sim4Life project to extend this methodology in different parts of the country.
Peer-to-peer learning has not only stopped at our facility, this facility being a health sub-district for our constituency, Igara West, we have done the same training to all the facilities which are under our jurisdiction. Usually we invite midwives here on a quarterly basis, and we have been able to get our trained midwives on peer-to-peer learning in these sessions to train them, and even after they have these midwives who are invited to also also do the same kind of training on peer-to-peer. So this has helped not only our facility, but all our constituency, all the staff within our constituency to learn peer-to-peer sessions and to be able to manage babies who are born with some bit of distress.
In our reports, babies who score lower have improved greatly within a few minutes. Then also our referral numbers have reduced because we would refer almost every baby who would be born asphyxiated. But now we do resuscitation within a short period, the baby is gaining, and we continue with the management. It has also helped us to prevent wastage of drugs because you know what is needed for a particular child. Then also in management of our mothers, especially PPH, since it is one of the major causes of death among the mothers, pregnant women. and those who have delivered, but through peer-to-peer, we've also improved our skills of resuscitation and reactive management of third stage, and in case of PPH, the steps to follow so as to achieve a better health within a shortest period. Also, preeclampsia and eclampsia, most midwives had the challenge of giving out those drugs, injections, magnesium sulfate, hydralazine. Most of us would give, and instead of saving a life, maybe you cause a problem instead.
This methodology has also been adopted for implementation in different sites in Canada.
We thank Sim for Life, Muni University, Science and Technology for bringing us peer-to-peer learning. And you have made us save life and life of our children and mother. Thank you very much. May God be the one to bless you and reward you. Thank you.
Special thanks go to our partners in the University of Calgary, Canada, under the leadership of Professor Narini Singhal, who has worked tirelessly to see this project make headway. We acknowledge the support from the district leadership, the different health workers in different health facilities, mothers and their families, and the MUST Team Sim for Life project. Thank you all. I have been your narrator, Angela Nakato, from the Public Relations Office. Succeed, we must.
We agree to talk about our mistakes, and all the mistakes are chances to learn.
In learning, we will teach, and in teaching, we will learn. Sim for Life project based at Muni University of Science and Technology, also known as MUST, acknowledged that skills and knowledge decline after a short period of training. Hence, they designed the peer-to-peer methodology where health workers can practice and learn from each other at their health facilities.
We received invitation from Barara University on Sims for Life, where we sent 4 midwives on 2 occasions. They were trained on help mothers survive and help babies breathe.
We traveled to different sites that the peer-to-peer learning methodology has been implemented. With this learning methodology, health workers are supported to facilitate practical sessions at their facilities. This is a life-changing situation as teams embark on saving babies and mothers.
As a peer lead at St. Daniel Combon Hospital, it has helped me to help my fellow midwives on learning how to help babies breathe and helping mothers survive.
We learn from one another. What one is not performing well, you pick from your fellow midwife when you are carrying the procedure.
At least every week or in 2 weeks' time, we make sure at least some midwives have to practice so that we really improve our resuscitation skill.
Due to peer-to-peer learning, even those midwives who are not trained and even with the doctors were able to learn through the peer-to-peer learning, and we have improved on management of our babies.
I did not attend any training in helping mothers survive and helping babies survive, but through the continuous practice sessions we've had at the facility, I've learned how to help babies survive through resuscitation, that is bagging, sucking, and helping those babies who don't score well to come up. Through helping mothers survive, I've also learned how to manage postpartum hemorrhage, managing third stage of labor, management of second stage of labor, and also managing the retained placenta and many others.
We had knowledge gap in management of newborns, more especially the sick, you'd find we had challenges with the dosage and what, but through peer-to-peer learning and with the EIC materials we are able to give drugs when we are conversant, knowing the dosage for the newborns according to their kilograms.
The number of death is decreasing. If I may say it, even so minimal now. It used to be mass, but because of peers to peers and learning from one another and taking control of that golden minute, it has helped us.
The peer-to-peer training has so far covered 54 sites in southwestern Uganda. Several organizations have partnered with Sim for Life project to extend this methodology in different parts of the country.
Peer-to-peer learning has not only stopped at our facility, this facility being a health sub-district for our constituency, Igara West, we have done the same training to all the facilities which are under our jurisdiction. Usually we invite midwives here on a quarterly basis, and we have been able to get our trained midwives on peer-to-peer learning in these sessions to train them, and even after there have these midwives who are invited to also also do the same kind of training on peer-to-peer. So this has helped not only our facility, but all our constituency, all the staff within our constituency to learn peer-to-peer sessions and to be able to manage babies who are born with some bit of distress.
In our reports, babies who score lower have improved greatly within a few minutes. Then also our referral numbers have reduced because we would refer almost every baby who would be born asphyxiated. But now we do resuscitation within a short period, the baby is gaining and we continue with the management. It has also helped us to prevent wastage of drugs because you know what is needed for a particular child. Then also in management of our mothers, especially PPH, since it is one of the major causes of death among the mothers, pregnant women, and those who have delivered. But through peer-to-peer, we've also improved our skills of resuscitation and reactive management of third stage, and in case of PPH, the steps to follow so as to achieve a better health within a shortest period. Also, preeclampsia and eclampsia, most midwives had the challenge of giving out those drugs, injections, magnesium sulfate, hydralazine. Most of us would give, and instead of saving a life, maybe you cause a problem instead.
This methodology has also been adopted for implementation in different sites in Canada.
We thank Sim for Life, Muni University, Science and Technology for bringing us peer-to-peer learning. And you have made us save life and life of our children and mother. Thank you very much. May God be the one to bless you and reward you. Thank you.
Special thanks go to our partners in the University of Calgary, Canada, under the leadership of Professor Narini Singal, who has worked tirelessly to see this project make headway. We acknowledge the support from the district leadership, the different health workers in different health facilities, mothers and their families, and the MUST Team Sim for Life project. Thank you all. I have been your narrator, Angela Nakato, from the Public Relations Office. Succeed, we must.
We agree to talk about our mistakes, and all the mistakes are chances to learn.
In learning, we will teach, and in teaching, we will learn. Sim for Life project based at Muni University of Science and Technology, also known as MUST, acknowledged that skills and knowledge decline after a short period of training. Hence, they designed the peer-to-peer methodology where health workers can practice and learn from each other at their health facilities.
We received invitation from Mbarara University on Sims for Life, where we sent 4 midwives on 2 occasions. They were trained on help mothers survive and help babies breathe.
We traveled to different sites that the peer-to-peer learning methodology has been implemented. With this learning methodology, health workers are supported to facilitate practical sessions at their facilities. This is a life-changing situation as teams embark on saving babies and mothers.
As a peer lead at St. Daniel Combon Hospital, it has helped me to help my fellow midwives on learning how to help babies breathe and helping mothers survive.
We learn from one another. What one is not performing well, you pick from your fellow midwife when you are carrying the procedure.
At least every week or in 2 weeks' time, we make sure at least some midwives have to practice so that we really improve our resuscitation skill.
Due to peer-to-peer learning, even those midwives who are not trained and even with the doctors were able to learn through the peer-to-peer learning, and we have improved on management of our babies.
I did not attend any training in helping mothers survive and helping babies survive, but through the continuous practice sessions we've had at the facility, I've learned how to help babies survive through resuscitation, that is bagging, sucking, and helping those babies who don't score well to come up. Through helping mothers survive, I've also learned how to manage postpartum hemorrhage, managing third stage of labor, management of second stage of labor, and also managing the retained placenta and many others.
We had knowledge gap in management of newborns, more especially the sick. You'd find we had challenges with the dosage and what, but through peer-to-peer learning and with the EIC materials we have, we are able to give drugs when we are conversant, knowing the dosage for the newborns according to their kilograms.
The number of deaths is decreasing. If I may say it, even so minimal now. It used to be mass, but because of peers to peers and learning from one another and taking control of that golden minute, it has helped us.
The peer-to-peer training has so far covered 54 sites in southwestern Uganda. Several organizations have partnered with Sim for Life project to extend this methodology in different parts of the country.
Peer-to-peer learning has not only stopped at our facility, this facility being a health sub-district for our constituency, Igara West, we have done the same training to all the facilities which are under our jurisdiction. Usually we invite midwives here on a quarterly basis, and we have been able to get our trained midwives on peer-to-peer learning in these sessions to train them, and even after they have these midwives who are invited to also also do the same kind of training on peer-to-peer. So this has helped not only our facility, but all our constituency, all the staff within our constituency to learn peer-to-peer sessions and to be able to manage babies who are born with some bit of distress.
In our reports, babies who score lower have improved greatly within a few minutes. Then also our referral numbers have reduced because we would refer almost every baby who would be born asphyxiated. But now we do resuscitation within a short period, the baby is gaining and we continue with the management. It has also helped us to prevent wastage of drugs because you know what is needed for a particular child. Then also in management of our mothers, especially PPH, since it is one of the major causes of death among the mothers, pregnant women, and those who have delivered. But through peer-to-peer, we've also improved our skills of resuscitation and reactive management of third stage, and in case of PPH, the steps to follow so as to achieve a better health within a shortest period. Also, preeclampsia and eclampsia, most midwives had the challenge of giving out those drugs, injections, magnesium sulfate, hydralazine. Most of us would give, and instead of saving a life, maybe you cause a problem instead.
This methodology has also been adopted for implementation in different sites in Canada.
We thank Sim for Life, Muni University, Science and Technology for bringing us peer-to-peer learning. And you have made us save life and life of our children and mother. Thank you very much. May God be the one to bless you and reward you. Thank you.
Special thanks go to our partners in the University of Calgary, Canada, under the leadership of Professor Narini Singal, who has worked tirelessly to see this project make headway. We acknowledge the support from the district leadership, the different health workers in different health facilities, mothers and their families, and the MUST Team Sim for Life project. Thank you all. I have been your narrator, Angela Nakato, from the Public Relations Office. Succeed, we must.
We agree to talk about our mistakes, and all the mistakes are chances to learn.
In learning, we will teach, and in teaching, we will learn. Sim for Life project based at Muni University of Science and Technology, also known as MUST, acknowledged that skills and knowledge decline after a short period of training. Hence, they designed the peer-to-peer methodology where health workers can practice and learn from each other at their health facilities.
I work here at the Simulation Center in Muni University, and I work with a vibrant team to grow the simulation method in Uganda, Tanzania, and Nigeria. And what we're doing in Muni University is that we're extending this methodology to the postgraduates so that we can address the limited number of people that are trained in this method, and also to be able to have a continuity of this method being used even outside the simulation center, like on the wards and in the other learning places. And what we are having with the other universities is really to introduce simulation to their faculty by training them and also enabling them to be able to train their own students. All these people from Nigeria, Tanzania, Uganda, from all these institutions we've been collaborating with will be at the Simulation Symposium on 16th June. You can't afford to miss.
We agree to talk about our mistakes, and all the mistakes are chances to learn.
In learning, we will teach, and in teaching, we will learn. Sim for Life project based at Muni University of Science and Technology, also known as MUST, acknowledged that skills and knowledge decline after a short period of training. Hence, they designed the peer-to-peer methodology where health workers can practice and learn from each other at their health facilities.
We received invitation from Muni University on Sims for Life, where we sent 4 midwives on 2 occasions. They were trained on help mothers survive and help babies breathe.
We traveled to different sites that the peer-to-peer learning methodology has been implemented. With this learning methodology, health workers are supported to facilitate practical sessions at their facilities.
Back home, it's almost the same. And my Nigerian friends, how did you find the rice? Yes? It was okay. So we are going to have a small change in the program. We are going to have a small change in the program. So we are going to do plenary session 4. We'll be doing plenary session 4 from this time. But just before we begin, allow me to recognize Dr. Jessica Nsungwa, the Commissioner of Maternal Child Health under the Ugandan Ministry of Health. You're most welcome. We are very, very happy to have you here today. All right, so the next chair for our plenary session is Miss Grace Daniels Omalade. Miss Grace holds a bachelor's degree in nursing from Abzaria University in Nigeria and a master's degree in maternal and child health from University of Ibadan. She's currently doing her PhD in nursing and she currently lectures at the University of Jos, Department of Nursing. Join me to welcome Miss Daniels. Thank you.
Okay, good afternoon all. You're welcome back to plenary session 4. I'll be calling out the next presenter. Okay, I'll be calling out Miss Aleni Mary. She's to present on experience of simulation-based education at Muni University Department of Nursing and Midwifery. Miss Aleni Mary. Is she here? Okay. So let's welcome Miss Aleni Mary, presenting on experience of simulation-based education at Muni University, Muni University Department of Nursing and Midwifery. You're welcome.
Good afternoon, ladies and gentlemen. Yeah, my name is Aleni Mary from Muni University. I'm presenting experience of simulation based education at the Department of Nursing and Midwifery at Muni University. So I would like to just share a little about Muni University. It's a public university located in northern Uganda in the West Nile sub-region, and it was established in 2013. As you can see, it is still a very young university, and the Department of Nursing and Midwifery falls under the Faculty of Health Sciences. So the first, the pioneer nurses were admitted in 2016. So about simulation at Muni University, as we all know that as a small introduction, that simulation supplements and enhances clinical education of medical students, but still this methodology of teaching is not actually well established in many African countries, including Uganda as well. So the background at Muni University is that actually it has not been long since we embraced this methodology of teaching and learning. The idea was introduced in 2019 when we had a small chat with some of the members of Sim for Life, Mbarara. Then when we took the idea back to Muni University, the idea was actually warmly embraced by Muni University administration, and it was also strongly supported by the faculty. So immediately, Muni University and Sim for Life developed a partnership to introduce simulation-based learning in the Department of Nursing and Midwifery. So we set out straight away to start implementing activities where we started, first of all, by training clinical faculty, because we knew that without training the clinical faculty, we could not go forward. So we communicated with Sim for Life, who actually willingly took us in, and our first training, which was Train of Trainers course, actually happened here at Must Sim for Life. Then afterwards, when that first training took place, we continued partnering with Sim for Life, where on several occasions we invited them at Muni University. They came back for mentorships on several occasions. Then also the faculty at Muni University, we continued with peer drills. Then there were other activities which also took place. We embarked on, lucky enough, we had some mannequins before that, but they were not actually adequate. So we embarked on other activities like setting up the skills lab and acquiring more equipment for simulation. Then we also went actually ahead to orient the students as well. Usually it's the third-year students who are in the clinical area full-time. So we had to orient them. And then our first session with the students were in 2021, because the COVID lockdown also delayed everything. And then since then, in September 2021, simulation sessions have now been fixed on our timetable, and we are conducting simulations at least once every week. So we have some successes, and we have also learned some lessons that now our success is that simulation-based learning is now being successfully implemented at Muni University. Why? Because the stakeholders are there to support us, and also they are committed. And we also actually attribute it so much to the willingness of training partner, which is Sim for Life, with their expertise in simulation-based education. And also we have a partner called Seed Global Health, which supports us a lot in these issues of equipment and other logistical issues. We also attribute it to faculty commitment and acceptance of this method of teaching, and the students are so much engaged. They actually even prefer that instead of once a week, we should have simulation at least twice a week. And we also have now full integration of simulation into undergraduate nursing curriculum. So we learned that it is important to have longitudinal partnerships if we are supposed to be successful in these kinds of methods of learning. Then also it's important to orient students first so that they can understand these methods and embrace it better. And also eliciting feedback from students, because we cannot just be teaching when we are not eliciting feedback, so that we can actually improve. And then, most importantly, integrating simulation into the teaching timetable is very important. So we also have a number of challenges, like how other people had already mentioned earlier, their financial infrastructure support and staffing. So for like financial, the one before? Yeah, so as earlier mentioned, also we have issues with space, but we have just partitioned some empty space which we are using right now, and then hoping that when we get actually a permanent space, we are going to have our permanently established simulation lab. Then we also have staffing and personnel shortages, which we hope to also overcome by recruiting one or more staff who should be entirely coordinating simulation. So our next steps are that actually Muni University should continue partnering with Sim for Life to expand simulation, and we should continue to advocate for more funding. And we are actually intending to expand our partnership to include a rural regional referral hospital, because that is where our students practice, so that the staff should also be oriented in this methodology. Then we hope to improve the infrastructure, staffing, and systematic program evaluation. Thank you very much.
Thank you very much, Miss Muni, Miss Aleni Mary. Please come and sit down for some questions. So we give room for just 2 questions for want of time. Are there questions for her? She has presented on the experience of simulation-based education in Muni University and how far they have gone, challenges, and what are their expectations even for the future. Are there questions for her? Just 2 questions. Nobody from Muni University here? Okay. Mic. There's somebody there. Is there mic for somebody? Okay, so is there any other person so that we take the questions at the same time?
Thank you so much for the presentation, Muni University. My name is Lilian Tumuhaire. I come from Japaigo, which is also supporting the AIR project, partnering with Mbara University of Science and Technology. My question is about the experiences of Muni University, especially the teaching staff who are using this simulation-based learning with assessment of the students. How how do you compare the cohort that has been now using the simulation-based learning with the cohorts that have not used this? How is it as to you as teachers who are passing on knowledge? How do you compare those two cohorts, or what is your experience as the teaching staff? Thank you.
Okay, thank you. Thank you very much. Yeah, actually, the students who have been taught via this method, they are now about 3 cohorts right now. Actually, through this method, they learn more, better than the traditional method, because as we all know that during simulation sessions, the students have enough time to concentrate maybe on one scenario, and then they are also given feedback. It is like a thorough method of teaching. So we have assessed that actually via simulation, they acquire more skills and knowledge compared to the other traditional method of teaching and learning. Thank you.
Okay, thank you very much. Is there any other question? Okay. It seems there's no question. So thank you very much for your presentation. Thank you. So we'll be moving. I'll call Martins for the next session. Thank you.
Thank you so much, Ms. Daniels Grace. Another loud applause for her. So we've been join me to welcome our dear Vice Chancellor, Professor Celestine Obua, the Vice Chancellor of Mbarara University. We are more than happy to have you here today, Prof. Just before I welcome you to give us some opening remarks, the theme for today's symposium is Understanding the Dynamics of Medical Simulation Methodology, Introduction and Institutionalization in Africa. And we have listened to the different experiences from 3 different countries, from University of Jos in Nigeria, what they have experienced, the challenges and the different prospects. We've also listened from the Catholic University of Allied Sciences in Tanzania, and we have also listened from MAST. And the discussion from MAST was led by Dr. Data, who was talking about adopting medical simulation-based learning in low and middle-income countries and what needs to be changed. We had a really engaging morning session. The entire audience was very engaged, and we have learned so much. So I would like to take this honor and privilege to invite you to give us opening remarks. Thank you.
Thank you, Martin. Good afternoon, ladies and gentlemen. In Uganda, we have this saying that bosses or leaders have this tendency of coming late. Although I have come late, I should have been here in the morning to officially open this symposium. But as they say, other institutional responsibilities cropped up, and I could not be able to first of all enjoy the seminar, because that is what I think I've missed more than giving you opening remarks. Secondly, the opening remarks I'm giving is not going to be very useful because you already heard a lot from the presentations. Nonetheless, I would like to thank Dr. Data and colleagues for organizing this wonderful symposium, bringing together a huge delegation of a community of practice. All of you are probably interested in practicing medical simulation as not only a mechanism or a method of teaching, but also a mechanism of enhancing skills already of people who are practicing. And so I thank Dr. Data and his colleagues for that. I also like to welcome all invited guests, and I think I was responsible for inviting all of you who have turned up and responded to this. Thank you so much for honoring our invitation and appearing today. We know that there's a lot you have sacrificed from the different places and responsibilities that you have left in order to come to be part of this symposium. I could go recognizing everybody by name, but I'll commit one crime of omitting somebody whom I should have mentioned their name for being here. But allow me to mention a few. I have my OGs. I have two OGs. In Uganda, OGs mean old girls, whom we have been together with Dr. Jessica Sabiti Nsungwa, with whom we did our PhD together in Karolinska Institute. And now she's a commissioner in the Ministry of Health. And I was just chatting with her that the little money they have given you from the Ministry of Health, can you pass it on to us so that we can fully establish a center of excellence for medical simulation in Uganda and in the region for that matter. I have several. I also have Professor Sarah Chiguli, whom we have been in Makerere together with. We developed academic programs in Makerere together, and we have risen through the ranks together with her. I'm very happy that she's also been doing well in Makerere, just like I was able to come to Mbarara and be part of this great institution. My son Bonaventure, who is standing, he's balding, and yet I'm not balding. I just cut my hair. For him, he's balding. And he's my son. Thank you so much for supporting us in various ways. I would like to welcome the delegation from the University of Jos. I think the first time we went to Jos, we went together with Dr. Data. I can't remember which year. Was it 2017 or 2019 that we went together to? Yes. Yes, Prof. You see, that's why I said if I start mentioning names, I'm going to land in trouble. But thank you so much for coming all the way from, it is almost northern Nigeria, is it? Central, yes. From Nigeria all the way to southwestern part of Uganda. You're really most welcome, and thank you so much for bringing and coming to share with us your experiences from University of Jos. And then our colleagues, our neighbors from, is it Mwanza? Yes, thank you so much for coming. Of course, Tanzania has been part of my home and here. Kwa hivyo ningeweza kuongea Kiswahili lakini watu wengine hawataelewa naongea nini. But what I've said is that you Ugandans, you don't know many languages, so I have offered to speak to you in English because you don't know other languages. Simulation is beginning to take root in Africa. For those who have traveled far and wide and gone to other universities across the globe, particularly our Western, Northern and Western partners, you realize that simulation is a big component of learning facilities in these institutions, particularly for health. It's difficult for you to handle some of the situations that you'll encounter in practice as you sit and wait in emergency, because you may never get an opportunity to study and understand the presentation of some of these conditions. Simulation makes it possible for us to sit and take time to understand how to handle some of these conditions. So for those of us who are seated here today, it's an opportunity for us to share the different practices. We know there are challenges of infrastructure. Just like I had my sister from Muni University bemoaning the fact that they still have no space and they don't have sufficient facilities. It is a problem to all. Even in Bara, where you think that we are slightly better off, we can still be a lot better than what we have today, because there are still many facilities that we are missing, which we could acquire and continue to improve on the ability of the learners that come into our facilities. The other thing is the demand for learning space for simulation. We have a lot more students than we can accommodate in the space that we have. And so the issue of space is not only for you, but it's also the same thing for an institution even like Mbara University of Science and Technology. So it is a common problem which together we can work towards achieving. The good thing is that we have partners and collaborators who are willing to hold our hands and work with us to see that in some measure, in some ways, they are able to support us, acquire either the dummies or the mannequins or some of the very highly specialized dummies that can mimic even me speaking to you now, can mimic me sweating, can mimic me developing a cardiac arrest, can mimic me all kinds of emergency situations. We may not yet be able to have those on the ground, but they are there, and we hope that we struggle towards acquiring those infrastructure. These facilities will also offer us opportunity to do research. While it is possible that we have actual patients on whom we can use for purposes of conducting research, emergency situations where this training that you're getting takes you may not give you the opportunity to carry out the kind of research that you would want, because you are dealing with a real life-threatening situation. It may not give you opportunity to sit, study, research, come and experiment and experiment and experiment. But simulation can allow us to do that. And I hope that as we build capacity for this, we put in mind the fact that it is an important opportunity for us to conduct. It gives us a good opportunity to conduct research in a situation which is not exactly life-threatening. It's like you're able to set up an experiment in a lab and see it happen. Whereas if you are handling a real patient, you are struggling with trying to keep this person alive, even though you would want to study a little more what can happen. And so I think we need to create opportunity for you, the practitioners, to be able to utilize the infrastructure available to carry out research in certain critical situations. The other thing is that simulation would also allow us opportunity to innovate. Now, I think Professor Chiguli will remember our small simulation lab in the what we was it called the Dean's building upstairs there. we needed to be creative in order to bring things that we need for simulation. And I remember we used to have plastic things put on containers and pretend that the skins you can cut and stitch and things like that. So the opportunity to innovate is there because we need to create facilities that can allow for practice. Finally, no, in terms of what we can do with these facilities, not that finally I have finished, but in terms of what we can do with these facilities is the clinical skills that can be imparted. I had the opportunity to visit one of the partner institutions in the West. I went to Michigan, and they took us to their hospital and where they have a simulation lab. And I saw people who are learning around within the facility. And I asked who they were. And they said, no, these are our clinicians who come to practice in order to gain CME. That you needed to go through this in order to get credit for you to have your license updated. Because if you provide the number of hours you've spent in the simulation lab, that would be sufficient for you to be given a license. And that is something I think we need to bring on the ground here. How do our clinicians acquire additional skills without the actual presence of patients? In other words, how many actual patients do present with some of these life-threatening situations when you're available to review them and study them? The situation might happen when you're up country and the patient is being handled by somebody else. So you may take 2, 3, 4 years without seeing some of these conditions. But the simulation lab gives you opportunity to do this practice and build additional skills. Now, the theme of the symposium is understanding dynamics of medical simulation, and what else? What was towards the end? No, not that one. Where is the theme? You read a long sentence. Institutionalization in? Institutionalization. Does it surprise you that it is not Mbara Regional Referral Hospital that has championed the establishment of a simulation lab? Rather, it was the university. And when I say the university, I know there was participation from the nursing department, there was participation from the clinicians where Dr. Data is coming from. I think, Dr. Data, are you still practicing pediatrics? Something like that, right? So they are clinicians in a way, but you realize that academia or academic institutions have the responsibility of ensuring that new knowledge is generated. Besides providing service, yes, you teach. Besides teaching, you're supposed to do research. Besides that, you're supposed to provide service. So I look at simulation, medical simulation, as an opportunity for you to fulfill the 3 core responsibilities of a university. You are able to teach, you are able to do research, and you are able to provide community service. And service is not only provided because you walked in the village Because whenever we talk of community service, people have the impression that you must have gone into the village. We can actually bring the community into the university setting. You don't have to go into the community for you to say you're providing community service. And so these mandates of the university are fulfilled using this one infrastructure that we can provide for our institutions. So institutions should be able to embrace medical simulation as a mechanism, a method for teaching, an opportunity to conduct research and innovations, and an opportunity to provide service to the community as well. So it is incumbent on us as managers of universities to ensure that medical simulation takes root in our institutions. I would like to congratulate Dr. Data and his team for having gone through universities within Uganda. I don't know whether Busitema University is here, because I thought one time you are also trying to establish a center in Busitema University. Am I right? Where's Dr. Data gone? Yes, Busitema University? They're around, yes. So I'm glad that you have our mother university in the nation, Makerere, because we are all products. Makerere was building for the future. Yes, and we are the future. So Makerere University, Mbara University, Muni University, one of our youngest universities, Busitema, and now we have the youngest public university is Mountains of the Moon. And I was with them about 2 weeks or so ago. And they were crying for mentorship and support from Bara University. They also have, if it is not a faculty, at least they have a department of nursing as well. So meaning, these skills we are talking about here also needs to be shared with them. Because when they train and graduate from there, they will be handling us, you and me, who is talking here. You cannot choose tomorrow and say, I only want to be handled by graduates from Bara University. You never choose where and when you're going to fall sick. And so it is important for us to ensure that we expand and share these skills and knowledge that we have. Involve as many of our sister universities as possible in Uganda. Spread around the region as much as possible. And then eventually, Africa will be conquering the world and not the other way around. There will be reverse colonialism in what we do. There are many things that our friends from the north and the west have been learning from us. I can share with you that there are things we do here which we take for granted, but which is picked up from our colleagues and say, wait a minute, this could be a different way of doing things cheaply, more efficiently, and effectively. Everything seems to revolve around how much money do you have. And that's where sometimes we get stuck, because we are worrying about how much money do we have. Yes, I agree. Some of the infrastructure we need. I'm told this other mannequin I was talking about, the one that can simulate everything sick in a human being, costs nearly $1 million or $2 million or something like that. It's the kind of money we may not have immediately at hand. But we can look around for alternatives and be sure that we have innovated a way of training our people. I'm happy that Dr. Jessica is here. And this is a conversation I want to have publicly with you, but in public now. The Ministry of Health have been picking out Mbara University to champion certain things. Is Dr. Grace Nambozi here? No. Dr. Grace Nambozi has been training all nurses. You assigned her that task from the ministry to train all nurses in Uganda on critical care. The next thing you should do, Jessica, when you meet my brother Henry Mebase, first of all, he's my council member, so I can, but now I'm asking you to talk to him, that this development needs a strong champion. And Bara University can champion the development of simulation in Uganda and within the region. I also know that in the interministerial meeting within East Africa, there have been occasions when one country or one unit is selected to spearhead certain developments within the East African region. You can also advocate for this in Arusha, to have Bara University lead East Africa in the development of medical simulation. Before I go to my grave, I hope I will be able to hear that the ministerial meeting in Arusha has singled out Bara University to lead that. The way they did for Dar es Salaam, Nairobi, and Makerere. When they were singling out, where do we have center of excellence for certain problems? Makerere was singled out for cancer. Nairobi was singled out for renal, something like that. And Dar es Salaam was singled out for something, cardiac. And why not Bara University for medical simulation? Ladies and gentlemen, I came to meet you, to welcome you to Mbarara, University of Science and Technology, and to wish you a very fruitful symposium. Thank you very much.
Thank you so much, Professor. That was quite informative. Another loud applause for Professor. For those that listened very carefully, there's so much to learn from the remarks of Prof. He said that simulation can help you perform the 3 cores of the university: teaching, research, and community service. So it means that the lecturers that are here and are involved in simulation can perform the 3 cores with ease in one place. Yeah? And simulation gives you an opportunity to experiment so many times. Okay? Also, simulation allows you an opportunity to innovate. You facilitate, you create facilities to enable practice. So thank you so much, Prof. There is so much that we have learned from your remarks. Another loud applause for Prof. just before we go to for the next session. So our next session is a fireside chat on introducing medical simulation on teaching timetables, experiences from East Africa and West Africa. And that's going to be led by Miss Heather McIntosh. Ms. Heather is the Director of Global Health Projects from University of Calgary. Ms. Heather, you're welcome to take up the floor. Thank you.
Hello, Webere and Agandi to everybody here. As we say in Canada, bonjour. Delightful to be here. As the panelists are coming up to the front, I'd ask if everyone could just stand up. We'll do a quick energizer while we're setting up at the front. So please, Mary Eleni, Dr. Edgar Ndeboine, and Prof. Simon Yiltok, please make your way. Okay. So we're going to take turns seeing who sits down first. So stretch a little bit. When I call out the month of your birthday, take a seat. January. February, March, November, July, April, September, October, August, December. Now, did I miss a month? Which one? May. Thank you, May. All right. Oops. Now we're just up here on top, right? So come on up to the front here, the panelists that are joining me. So Edgar, Simon, Mary, I see you there. Thank you. I think we've got Mary at the back making her way up. Prof. Simon, are you joining us? Come on up. Thanks. So this is a fireside chat format. It's meant to be a bit of an informal discussion, and the theme of our fireside chat is on timetabling and simulation. So I'll just briefly introduce the people at the front. You've heard from them before. We have Mary Eleni from Muni University, and I actually had several questions after your presentation, but I was waiting. And then Dr. Edgar Ndabwene from the Simulation Center at KUHAS, Tanzania, Uganda Hospital, and Prof. Simon Yiltok, who's led development of simulation at University of Jos, Nigeria. So thanks for coming. Now, timetabling has tended to be an enormous challenge in simulation. When you've intended to introduce simulation-based learning into an existing program, how do you fit it in? So we'll go through and ask one question each, then we'll have people do a written question from the audience if you'd like to present, just so we can speed up a little bit for time. So as you think of a question, write it down, and then we'll have a point where you just wave your hand in the air and someone will come and pick up your question. So Mary, let's start with Muni University. We heard about your experience and the interest of your students in having frequent simulation. And we heard about that from MUST as well, from the Student Voices study this morning. Now, you have successfully scheduled weekly simulation sessions for your students. Can you tell us about how you manage that?
Yeah, thank you very much. So, as I said earlier, we only have a Bachelor of Nursing course at the Faculty of Health Sciences, and we do simulation with Year 3 students. So we have actually allocated Wednesday afternoons from 2 p.m. up to 5 p.m. for simulation. So it is actually quite simple because we have on average, a total of about 34 students right now. So it's quite easy. We divide them into groups of, say, 5 or 6. So we take them in shifts, so it's quite easy to fix it. Thank you.
Thanks very much. So the class size is a factor. Yes. So maybe I'll turn to Prof. Yiltok. You have a fairly large program at your university with large class sizes. So how do you manage the scheduling with a larger class size?
Thank you very much. Currently, is not an adopted schedule in our program. We're still trying to get a buy-in. But I think currently the way we run our program, apart from the lectures, the students are usually shared into, like, let me give an example, pediatrics, ONG, and community medicine. They have a period that currently we have a set there, and they are divided into 3 groups. So it makes it quite easy. And I recall just recently, Professor Amaka, we were able to organize a session for the entire set doing OBGYN. So the way our curriculum is structured, even with the large class, you'll be able to do that conveniently because you'll be able to have them in batches that you could be able to run. And a way to overcome this is, which is the plan we have, is to develop a large faculty base. So it makes it very easy for you to run a scenario when you have facilitators that are on ground. So, and that's how we've been able to run that. And some few weeks back in anesthesiology, Henry, they were able to, run simulation for over 100 students. So once you have them in the way we rotate them in batches, that's what has enabled us to overcome that challenge.
Great, thanks so much. And now we'll turn to you, Dr. Edgar from Tanzania. You talked a little bit about the fact that you have a low fidelity and a high fidelity mannequin setup in your simulation center. And you showed us the timetable where you had the color coding of your micro timetable schedule. I'm wondering, when you've got students and faculty, instructors coming in, and you've got them scheduled, how do you split between, how do you decide between low and high fidelity? And I guess, how do you build interest in attending a low fidelity program?
At course, we have divided our sim lab into two groups. One is low fidelity, and the other part is high fidelity. Because the high fidelity is very expensive mannequin, not everybody is allowed to be participating in that area. Only anesthetist, students who are training on anesthesiology are the one who are using the high fidelity mannequin. And they are usually coming to the sim lab on every Wednesday evening from evening hours, at least 3 hours. And they are usually divided into two groups. One group will be in the sim lab and another group in the debriefing. So those ones who are in debriefing, they will be observing the one who are participating in the actual sim lab. And then they come back and they get their feedback, what was going on and so forth. For low fidelity, this one has been divided into departments. We know at our course we have two schools, School of Nursing and School of Medicine. For School of Medicine, we have 4 departments. That is pediatrics, surgery, internal medicine, and obstetrics. And for School of Nursing, they have their own schedule. My colleague James usually coordinates the School of Nursing. So in order to minimize confusion, and we have done a master time schedule where each department knows at what time they can use their sim lab. But we are still having challenges because we don't have a person who is dedicated full-time as an employee who works in the sim lab. So they usually contact us, but also we have decided each department there will be a team lead, and that one has to coordinate the sessions. For our obstetrics and gynecology, we usually allow only senior MD students, that is MD5. And when they come to our department, there are 44 students. So we usually divide them on a weekly basis because they will stay with us for 4 to 6 weeks. So you can take 7 students per week, and then after 5 weeks, all students will have passed through. But sometimes when we have enough time, we use other facilitators, because in my department we have a course coordinator and 6 facilitators who are already been trained. If they have sufficient time, then they can participate on arranging the simulation training for students. What students they say about it, they like a lot because they have an opportunity to share what they experience, and they have an opportunity of getting feedback compared to going straight to the clinical ward.
Great, thank you. And then if you've got a question down that you've written, please put your hand up, and then we'll have someone come and pick up a question from you. Okay, I think that's our rapporteurs at the back. Are you able to pick up the questions from anyone? I have a question I wanted to ask all of you. Each of you in the presentation so far has touched on your next steps and what you hope to go forward with in simulation in your settings. If you had to choose one priority from among your next steps, what would it be?
For us, course, we have decided, because we are still having challenges with specialists coming to our sim lab. I think the most important step for us, we have decided residents, especially senior residents, should receive a facilitation course so that they can be our teachers and help us on teaching students. But also this will be like a pioneer for them to, once they're finished, they'll be the ones to spread the information of simulation to their center where they are coming from.
Okay, so medical residents both as facilitators and champions. Okay.
Okay. For us, because of the space constraint, that takes priority. We've been given an area which we need to secure and demarcate the area so that we'll be able to, run simulation for a large group of students within a short time. That's our top priority, and maybe the rest things will be like certain equipment that will be able to help. But top on the list is securing a space so that we'll be able to have a functional schedule.
And for long-term sustainability of the program. Okay, Mary.
Thank you very much. For us, I would choose securing a permanent simulation lab, because right now we are using nursing skills lab. Then also we are using part of anatomy lab. So if we could secure a permanent simulation lab, that would be our first priority. Thank you.
Thanks. So also the ongoing sustainability of the program with a fixed space. Okay, great. Thank you. Any questions from the audience? I'm seeing a question in the center there. Tay and Treva, would you mind picking up the questions? I'm putting the UCalgary students to work. We have two interns here, undergraduate, who are fortunate to be able to be placed in the Sim Center for 3 months. This is a great question. The timetables for nurses and medicine usually differ. How do you ensure a multidisciplinary team during the simulation experience?
For us, we run both the MBBS or medicine program and nursing. I think usually each section has a central timetable where I think both groups can sit and harmonize and be able to get an agreeable time for it. And since we intend to add the dentistry students in future and other programs, we think sitting down and arranging and harmonizing our timetable so that we'll be able to have a schedule where you have a multidisciplinary scenario playing so that they will be able to interact and know each individual's rules. So the key center is actually meeting, sitting down, look at all the schedule and agree on a particular one that will be able to address the different professions.
For us, course, we divided the timetable according to schools. We have two schools, School of Nursing and School of Medicine. So at the last faculty development course, we involved the course coordinators on both schools, plus head of departments. So when we were formulating the master schedule, we participated, and everybody has to tell us which time they think they may be able to bring students. So currently, we know each department and each school when they are supposed to use their sim lab. Then it is their duty to make sure sim lab is well utilized. What is we are lacking is a lab manager, which we have talked to the management, and they have promised us to employ a permanent person who will be communicating with the heads of department and course coordinator from both schools, and then make everything running smoothly. And we thank Calgary University who help us on formulating this master time schedule.
Okay, well, that's all the time we have. Thanks everyone for your fireside chat contributions. In Canada, we would have an actual fire because it's cold, but here it's just we had. Who is expecting the fire? Next time when you come to Canada, we'll have to have a fireside chat with a fire. Thanks so much.
Thank you. Right. Thank you. Thank you so much. Let's applaud them. Yeah, thank you, Ms. McIntosh Heather, for leading this session. So our next fireside chat is on health facility experiences with quality improvement, Prisms, peer-to-peer learning in maternal and newborn care. It's going to be led by Dr. Jerry Aitiko. Dr. Jerry is an alumnus of MUST. His name is actually difficult to pronounce. I don't know how many people can pronounce his second name. He's an alumnus of MUST and a public health specialist. And he also works with Doctors with Africa, QAM, as the health advisor. Join me to welcome Dr. Jerry.
Okay. Thank you, Martin. My name is Jerry Ishto. Yeah, I come from Pakwach district, so that's the name from Pakwach in West Nile. So, but anyway, thank you so much. Yes, thank you for introducing me already. And I think for this afternoon, my role is to lead the panel that will be exploring experiences with quality improvement, Prisms, and peer-to-peer learning. Of course, during the morning sessions, we heard a lot about these interventions, especially for in-service training and learning. The other trainings we're talking about students, but these are now mostly concerning people already deployed at health facilities, working in both government and non-governmental health units to deliver services. But we also saw earlier on that after trainings, the problem of skill decay is very evident. But these approaches have shown that, yes, they can actually improve the skills even after training. So we shall hear experiences from a team of health workers and also health managers who are engaged in day-to-day running of health services and offering service delivery to our patients and communities. So with this, I'll call the panelists. Kyomuhangi Christine is Assistant Ediation Maternal Child Health from Rukungiri District. You're most welcome, Christine. You can walk up to the stage here. And then we have Katoshabes Livia. Katoshabes Livia, who's a midwife at Robare Health Center 4. You're welcome, Katoshabe. We also have Rosemary Ngabirano. Is a midwife also from Nyamohanga Health Center 4. Rosemary, you're welcome. And then finally, we have Kebirunji Agatha, who's a principal nursing officer for Nyakebala Hospital. So let us welcome Agatha. Okay, so we wait for Agatha to come. you could get the micro. So in the interest of time, I'll go straight away to the questions, because fireplace, although the fire is not there, but yes, let's say that there is. Yeah, so straight away, let's start with Sylvia. What really has been your experience with the Prisms, this device application protecting infants remotely by SMS? So briefly tell us your experience with Prisms.
Thank you so much. I'm Kat Chavez Livia, and I'm a mother plus a midwife. You know those things, they go together. Prism, I may call it like evaluator. Actually, it is evaluating our work. It has eased our work as midwives from Rural Health Center for, anyway, some things are unbelievable, but they were there. Now, if I've delivered a baby and I'm scoring it, we know how to examine the baby, you know the normal findings, the abnormal ones also you know. But when you use that prism, it will direct you. You will never meander with what to do. Like you have put there, it will alert you. You have to remove the wet clothes. And tomorrow you have done it again. It is telling you remove the what? The wet clothes. So next, on the next baby, the first thing you will do, you will have to make sure that you have dried the baby thoroughly in order not to get to face another problem. So it has helped us. It has helped us in directing us to give the right antibiotics. It will also tell you when to recheck your baby. And what I like on the Prism, if they tell you reassess after 1 hour, even though you are very busy, starting from helping babies breathe, the stimulation for life, it really helped us. Even I know how to engage the attendant. I may be one on duty. My Prism has told me I reassess after 1 hour. I identify the attendant. I may be busy in the labor suit, but when teachers at 1, please come and remind me. Definitely you'll be there. The attendant will come and call you because the Prism has told you that reassess after 1 hour. So when she comes, you will go and reassess your what? Your baby, and the Prism will tell you where you have reached. You people, even 10% dextrose, it will tell you to nothing, even you don't need it to bother. So actually when these people were here, they were talking the university, the stimulation will be in the university. I was there burning. How about the community? You people, the community, we are the pillars. I'm telling you, better consider them. Because we are saving these babies, like from Rural Health Center 4. Last time I was in Safe Motherhood, they were saying we should create emergency on they are losing in units very much. But when we are having Prism and we have everything, we have our capabilities built, I'm telling you, no more losing the babies. Okay. So let us use the Prism. Thank you.
So very good. Thank you so much. This is a very beautiful experience. Really, we see that Prism is helping a lot. Maybe to Sylvia. Yes. Sylvia?
Yes, I'm Sylvia.
Still, on this Prism, there was a challenge earlier of that it increasing workload. Is that still part of the challenge, or that is not there?
Before, that's what we thought.
Yeah.
When they bought those phones, first of all, we were worried of safety, that they will steal them. Secondly, we used it to ask ourselves, now, you have, after delivering the baby, you have thanked the mother, she has gone. By the way, even for us, we didn't know that a baby whom we have discharged from the labor suit very well can change the condition. But now, before we discharge the baby, you have to reassess. You may think that we have all normal findings, but when you go to reassess, you find that the story is different. So, the baby who was breastfeeding very well, now is unable to what? To breastfeed. You were there, the mother is putting on you pressure. Nurse, may you discharge me? I want to go home. To go and to reassess the baby. The baby is unable to do what? To breastfeed. And you will know through the what? The prism. Because it will tell you, have you discharged the baby in good condition? Has it died? In which condition have you discharged the mother?
Okay, good. Thank you so much, Livia. Obviously, we see a lot of benefits from using Prisms. But to Agatha, from the quality improvement perspective, in relation to the quality of care that the mothers, that you provide to these mothers and the children, the neonates, for example, do you think Prism has been of any benefit in that way?
Thank you so much. I think, actually, you've asked, do I think? I know it has done great. Like earlier I said, Prism goes with quality improvement. And these people do mentorship. They have to come on site. I had already narrated how we didn't know that our maternity ward is located in a place where there is always coldness. But through these QI reports, we realized that babies were suffering from hypothermia and we were losing babies. So, through the reports, recommendations were done and we bought room warmers. Currently, I want to tell you, we no longer lose babies because of hypothermia.
A round of applause for that. So,
then I wanted to add on something. You've not asked me. Here we are talking about universities. We are the people in labor suit, nurses and midwives. And believe me or not, nurses and midwives train. The big numbers are in the nursing schools. So I'm kindly recommending that we also go down from universities to the nursing schools so that we can get it all.
Okay,
thank you.
I think this is taken. Thank you. So thank you so much, Slivia and Agatha, for really, deepening this experience on Prism. Let us move to the other aspect of this skills retention, and that is peer-to-peer learning. And this goes to Rosemary. What has been your experience really with the peer-to-peer learning at the health facility?
Okay, thank you so much. With peer-to-peer learning, it has helped us in our facility to improve in managing the obstetric emergencies. Like before the training with peer-to-peer, some midwives had knowledge gap in managing obstetric emergencies. For example, the preeclampsia and eclampsia, especially in giving the magnesium sulfate. But with peer-to-peer learning, it helped the midwives in giving and mixing the magnesium sulfate, and on the other hand, in the managing of the postpartum hemorrhage, which is the major cause of maternal mortality and morbidity. And it also helped in managing in resuscitation, because before that, the introduction of peer-to-peer, also some midwives were not well conversant with the resuscitation. So after they all got the skills on how to help babies breathe for the first golden minute. Thank you.
Yes, maybe just a follow on to this. How often have you been doing these peer-to-peer learning sessions at your facility?
At least 2 times in a month.
Okay, very good. And then you vary the skill set that is taught across. So
Yes.
thank you very much for that. And then still back to Agatha. On this peer-to-peer for your facility, has it caused any change that maybe you can be proud of?
Thank you so much once again. Peer-to-peer has caused a great change in our hospital. I said, I will repeat my words in the morning. I said, when people finished this training of HBB, they came singing, helping babies breathe. Well, they were singing, and these other midwives who had not gone for the training, they got interested. They gave us a CME. After some time, we came for a training on peer-to-peer. And we have the guidelines. Everyone now can teach others, even those ones who do not attend the training. And we keep reminding each other. Do you remember what they told us when we were doing peer-to-peer? You do peer-to-peer when others are there seeing. So it has really created a very good impact. But I had challenges. We have challenges of attitude. The attitude is a challenge, but we can keep addressing it at different levels.
What is the challenge, the attitude?
Someone will think this one who went for a training, got money, now wants to give us knowledge, we have not eaten meat.
They also want the money.
Those things, eh? So, if it could be possible, addressing this issue, we can have on-site training so that every midwife sees the outside face and will listen more and get more. Thank you.
All right, so the way we organize the training, a round of applause for the team here, really. Very nice experience in the field. But of course, we know that all this is done when there is clear leadership, management, and governance of the health system at the district level. And to this, because without clear leadership, you get lost, so that guidance is not appreciated. So from the perspective of leadership, I want to ask Christine, the DSO, really, what is your view on all these site-based capacity building efforts, Prisms, peer-to-peer learning? What has been your experience, especially for your district, Ruchunjiri?
Thank you so much, Moderator. In addition to the rest of my panelists, from Rukunjiri district, we started having this in the peer-to-peer and prisms for the last 2.5 years. Drastically, the maternal and perinatal deaths have reduced. Why? Because as PNO Nyashibari mentioned, when these people were trained, they trained health center 4 and the hospital. Those are 5 facilities. And they trained almost more than 3 people per site. And when they came, they tried to do the peer-to-peer, they tried to do the prisms, and for prisms it was exciting each and every one to click as if you are clicking on what? On, what can I say? You click, is it an encyclopedia? You click there and everything comes. People are saying, we have got it. So it has reduced on what they have called knowledge and skills decay. Midwives stand alone in the whether absence or the presence of a medical doctor, especially when they are not closer to them. It has built confidence in them that with or without, at least I can click here, I have where to, to consult. So it has really helped us, and we have seen the health center force and hospitals implementing reduced maternal and perinatal deaths. And we have got, even if it is time for referral, smart referrals. You first try your luck, try your best, give the right treatment, the right dose, and where you feel, then you refer smartly and timely when at least you have done something. Unlike before, you could just, fidget, give what you think. In terms of kilogram per body weight, you find you have given what is not right. But with Prisms, you can't go wrong. So midwives are very happy in those facilities, and we have seen results. So we want to thank the proprietors of the SIMS and the peer-to-peer. I wish in the recommendation we could roll down from the health center for level and hospital level, even where doctors are, where we have gynecologists and what. But pity and pray for the health center 3s, where there is no doctor and there is that midwife who has not got even what a peer-to-peer, even what Prisms mean. On the other hand, I wish if we could have support these people from health center 4s and the hospital, support them lower down to the health center 3s, who could reduce drastically the maternal and perinatal deaths.
Okay, good. Thank you. Another round of applause. This is very good. Really, from the leadership perspective, we see that Prism is helping to reduce bad outcomes for mothers and neonates. I wanted to ask something, but I don't know. It might be a bit outside this, but I'm being tempted to ask. Also we've been grappling with motivation of staff and retention at health facilities. Do you think Prisms and these peer-peer things could have a role in that regard as well, as a health manager? Motivate and retain them at the site.
On the other hand, when you have on the maybe knowledge, capacity building with the skills, it motivates someone to feel self-sustained. You feel you are confident to do something, and it motivates on the other hand. When you remain at the health facility, you feel you are stranded, you are not supported, you have that so-called knowledge and skills decayed in you, you feel demotivated. I wish if the Mbarara University, if you can, support us more with more regular mentorship, and then you support these mentors already to continue and mentor the lower facilities, it can motivate us in our profession and we feel proud. And when you are proud of your profession, you get self-motivation and self-satisfaction in your job, hence client satisfaction and quality improvement in service delivery.
Okay, good. Thank you so much. I think, Dr. Data, this is another point maybe to explore going forward to get evidence. There could be that angle of the benefit of Prisms and the peer-to-peer learning that maybe need to explore as well about retention of staff and ensuring that people attend duty very well. So let's open it up a bit to the audience if there are some burning remarks or questions. You could take one or two. Yes, I'm seeing a hand up there. So can we get this to... And I've written, okay. So he wants the mic, okay.
Thank you so much. Mine is just a simple addition on what they've said. I'm also a midwife, and I want to give you experience of what we used to do before the Sim for Life training. So whenever we would have babies with birth asphyxia, so most midwives would want to refer for oxygen, and even those facilities would, with oxygen would just put on oxygen even when before you've help the baby to establish breathing. So after the training, we are able to know that even without oxygen, the oxygen we give through ventilation is enough to make the baby breathe. Then for skills, really it has helped us a lot. Because when you get an emergency, if you've not practiced, you start panicking. But because of the peer-to-peer peer-to-peer learning sessions. So we've been able to build our confidence, and we can really handle emergencies because you still remember what you've practiced. Then we are also able, like for us, me and Material Center, for when we identify, we get maybe a mother had had a stillbirth and we identify it is a referral, or we receive referrals of babies who are born from lower health facilities. So we try to go deep and find what really happened. And mostly whenever we used to go to facilities, we would find the midwives really had a skills gap, mostly in resuscitation. And I can tell you, Sim for Life has really done it all. And our perinatal death has completely decreased almost by 80%. Thank you.
Okay, good. Thank you very much. That's another evidence that Prism works. I also have some two questions here. One is that is the Prism app integrated into national HIMS, that is Open MRIS, or does it work parallel to existing HIMS? I think this question is not for my panelists. This question is for Mukama Martin. You will help us to answer this one. And then the second one is that how can all health workers across the country access the Prism technology? I think this is still for you, Martin. So these two questions will help answer for us. Whether it is integrated with HIMS, and then to the issues of access, making it go large scale, not few facilities. Okay, so I think for my panelists, maybe just as we conclude, okay, there is. There's another one here. Prism has done a lot of wonderful things, but don't you think it is going to create a lot of dependence in the healthcare workers who use it and reduce their capacity to critically think in the line of management of patients? I think this one we give to Rosemary.
Okay, thank you so much. I think the use of prisms, the way it is said, it is to help us. Previously, we used to say, like in health centers, that there is no doctor that facilitates to ask that let me refer to a higher what? At a higher level. I think that's why they brought prisms to help us on the management of these sick babies. Thank you.
Okay, good. So as we conclude, we see that yes, really it's a decision support tool. That is what we know about Prism. At that level, when you need to decide, we could get the microphone to her. Oh, okay, go ahead.
Thank you, sir. Mine is like, it may not go to the panelists as well, but according to how you've talked about prisms, and the previous speak about prisms was like giving new information, not previously what we've been using. So my worry is, are they coming to our facilities again to give us the full information? Because it's like most of us never picked very well what we are supposed to do. And our phones are like, some of the phones are giving us out, the information is outdated. So I don't know, what shall we do? And when we go back, what should we tell our fellow midwives on how to manage using those phones? Thank you.
Okay, good. That's another good one. I'm realizing that I think the two questions we had for the session before lunch could have been a bit limited. So some of these are really questions for the presentation that Mr. Martin, you gave on Prism. So maybe you note that. That is the third one for you to look into.
Thank you very much, the presenters. I also want to appreciate the Prisms, because we midwives and other health workers, it has helped us change our attitude, the negative attitude, especially when it comes to preterm babies. Because whenever we would deliver preterm babies, you would not even have where to start from. You only think of referring to the hospitals. But because of the Prisms, it has brought a change in we, the midwives and nurses. At least we first try our level best and we succeed. And where we don't succeed, we always refer. And also want to side with one of the presenters that some of the midwives down in the other health facilities, they have not yet adapted to these new systems. So I call upon the implementing partners to support us because we are already equipped. We can go down there and train them so that we can keep saving our babies and mothers. Thank you very much.
Okay, good. All right, so thank you. I think before we go to the last comments, Mr. Martin, I'll give you some 1 minute to respond to those 3 questions that came to you.
Thank you so much to the people that asked these questions. They are quite interesting. One asked about integration of Prisms with Open MRS and HMIS. Currently, the Prisms app collects data that is similar to what could be in HMIS, but the integration has not yet happened. So they are parallel systems. So the integration hasn't happened, but if given an opportunity, we can write the API that can link to HMIS, because the information that we pick from Prism is similar to what is in the HMIS. Then there is someone who asked about deploying Prisms at a large scale. Why are we working in a few health facilities? Yes, we are in the journey to do that. It might not happen in one day, but we are really in a journey to do that. We started working with different health implementing partners. Of course, we need to go back to the ministry. I'm happy Dr. Jessica is here and present, and maybe if they can give us additional muscle, we can be in position to deploy in more and more facilities. But right now we've been working with different health implementing partners, but the journey is still ongoing. The other question was on, someone needed more time to interact with Prisms. We have a simulation marketplace after today's session. It will be outside. You can come and get a more feel, especially of the Prisms ward. And you also mentioned that is information outdated? No, information in Prisms Premium, which is currently being used in the different facilities, is not outdated. It's all up to date. We just created Prisms Premium, Prisms Word, which integrated what was in Prisms Premium and additional information to make a holistic experience for users. Thank you.
Okay, thank you very much, Martin. Of course, the understanding is that also Prism is evolving, and maybe those new additions to we need to take the users through a bit deeper into all those. So for me, from my experience a bit with Prism, where I work with Quam, we have supported some facilities in Karamoja and in Lango to also use Prism. But the experience, Mr. Martin, is that at some point the health workers tell you that the options become limited. You know, when you come to gentamicin and ampicillin, then you had stopped there. But I know that you kind of cured this with the Prism Ward. So I think really rolling out again Prism Ward to all the other facilities will be very much in order. Of course, our rollout in Karamoja and Lango has been with the help of our friends, the Elma. Thank you so much. Yeah, we appreciate that work that we did together for Karamoja and Lango. So just one word to conclude this session from each of our panelists, and then we set it. One word about Prism, peer learning, and what?
About Prism, I will never forget. I think I'd fall in love with incubators. Whenever I would deliver a asphyxiated baby, I would rush to the what? To the incubator. Until when the Prism told me, put the baby skin to skin. And I was so challenged. My babies were picking. So I'm requesting for my fellow midwives, as the way we are doing it in Ilubale, in Intungamo. Let us use Prism. For those who don't have, let us pray for it. It comes to our facilities. Thanks so much.
Okay, thank you so much. With use of Prisms, really it has helped us so much because we use it to refer each and every baby who is sick. But nowadays, at least we are able to manage until discharge and we follow up. Thank you.
Thank you so much. I want to talk about the quality improvement of the reports. Normally, when we are analyzing or evaluating, we ask ourselves the 5 whys. If the babies are dying, why? If they are dying of this, why? If this why is doing what, why? So the 5 whys will give you what to do. Because you completely feel very uncomfortable. Because when you reach at the last why, it will be a solvable issue. If it is carelessness, you just solve that. It is not always big. So those who are implementing Prisms, the quality improvement reports, let us encourage our colleagues to get serious, because at times we ignore. We make reports, but we don't interpret or analyze them. Thank you so much.
Thank you so much. Finally, what I can comment on, administratively, if we are to do it better, I encourage or urge all the administrators at your hospital level, health center force, wherever we are implementing the peer-to-peer or Prisms. When I was interacting with my staff, they said we would have loved to mentor or do CME or call it CPD, but then the nature of our work, you find you are alone. Sometimes you are two. One is an outreach, one is here. So it becomes difficult to get your peer so that you pass on the intended knowledge or the skill. So the workload still becomes a challenge. That one is administrative at higher level. That is staffing. Then on another hand, management of the duty rest and location of staff is also very important. I wish if we could find on a duty roster every day someone allocated to handle the Prisms. And then for peer-to-peer, at least weekly. And then when it is scheduled there, you know that on every Thursday, if we are around, let's gather and have that sharing and having our knowledge shared. If it is not like that, you will never find all the health workers at the facility so that they have that peer-to-peer. For Prisms, I think it is a matter of having that self-motivation in you and know that I have to do it. At first, initially, you do it, you review, and then before discharge. Sometimes before the initiation or the adoption of this, you could find the baby in the cot dead, bleeding from the cord. The baby is pale. The jaundice started the other day, you don't know, and you discharge something which you don't know. But with the Prisms, with the peer-to-peer, we have improved the conditions of the baby during and even at discharge and follow-up. Want to thank you so much for giving us this opportunity. And finally, I wish it could roll to the lower facilities.
So, yes, thank you very much. You've been a very engaging audience and a very powerful team here. So it has been a nice fireplace. So thank you very much, team. I think that is it.
Thank you so much, Dr. Jerry Ishto. I hope I've pronounced your name right. Yes, another loud applause for the team. I really enjoyed listening to the experiences from Prisms. Being a developer, it's always nice listening to such stories, especially if you're involved in the development. But we can assure you that we are doing all we can to improve the experience. Prisms will keep evolving. The developers are all in-house. We don't outsource our development. So we shall keep evolving and getting feedback and making sure that the feedback that we get from all of you is actually integrated in the different versions that we'll be developing. So allow me invite Josephine, who will be briefing us on the next sessions.
Good afternoon, ladies and gentlemen. I'm just here to pass an announcement about the change of the program. From your agendas in the folders, you see that we are supposed to be going for 2 breakout sessions. That has changed. We now have 3 breakout sessions. One is going to be in this room, in Bushenyi, and in Intungamo. So in Bushenyi, we are going to have these presentations. We've added the effect of advocacy inquiry to this room. Before it wasn't there. It was in a different room, sorry. In Intungamo, next slide please. In Intungamo, we still have the 3 presentations that were there before, but we've also added the simulation training in residents on conducting medical simulation in healthcare, the experience from KUHAS. So those are going to be in Intungamo. And in this room, we are going to have the first 3 presentations that we are supposed to be in Intungamo earlier, and one other presentation that is titled Determining the Frequency of Newborn Ventilation Skills Practice Using the Air Device and Instant Feedback Tool. So we are going to divide depending on where your interest is, but we hope that we can have equal numbers in all rooms. On different doors of the rooms, this schedule, the presentations that are in the different rooms is there, and I think we are good to go. So you choose your room of your choice, you go to the other room. We hope we can spend about 45 minutes in the other rooms, in the breakout sessions, and we'll be back here. Thank you so much. There'll be ushers to help you, show you where the rooms are. Thank you. People going to Bushenyi, you're going to follow Dr. Talamoy, Bushenyi Hall. People going to Ntungamo, you could just use either this door or the other door and go to the room on this side. Don't leave us. It's with Talamoy. We are going to use about 2 minutes to move. If you're staying in this room, then you could move a little in front. Please move to the next room. If you're moving to the next room. Just go to the main door, main gate. You're here. People going to Bushenyi, there's another bus leaving. It is here with Joan. Just follow Joan. People going to Ntungamo. Albert has a bus. Oh. You could just follow Albert to Ntungamo. Ntungamo Express is leaving. You can just go a little in front.
Sure. Oh, yeah, I guess so. Okay. Since we're a smaller group for this session, maybe people can move a little bit more to the front. Otherwise, it's an awfully big room for a smaller number of people. So as people are moving, perhaps I could ask the first presenter to come forward. Miss Asusi Mildred Edna. Great. And we're going to start with a couple presentations on student perceptions on simulation. So we'll look forward to hearing what you have to say.
Good evening, ladies and gentlemen. My name is Asusi Mildred Edna. I'm proud to be a nurse and proud to be among the team of people who are training the next generation of nurses. And today, I have the privilege to present to you findings from a research study that was done in Muni University by one of our very own undergraduate Bachelor of Nursing Science students. He was interested in this topic after having a number of sessions of simulation, and that touched his mind to think of understanding what his fellow students experienced as regarding simulation. And the topic is on the benefits and barriers of clinical simulation. These are perceptions of the undergraduate nursing students at Muni University. And so I am privileged to represent Ochen Moses and one of our other faculty, Miss Andrew Monica. I would like to begin my presentation on one important aspect, that is competence. I believe each and every one of us who is engaged in the teaching of health professionals, whether you are in the universities or at the health facility levels, one of our goals or outcomes we want to achieve is competence in these students. And the core of clinical competence is the ability to appropriately and timely intervene and manage those different clinical situations or clinical conditions that you encounter. And as a trainer or a teacher or a mentor, that is one of the core outcomes we want to achieve. However, the literature shows us that we are not there as far as achieving the minimal or basic competences in our nursing professions. A number of studies have shown that many of the nursing students, globally or locally, are having low levels of clinical competence by the time they are graduating. And the question is why? And partly we attribute this to challenges in their ability to translate the theoretical knowledge into practice. This has been a big challenge that has hindered our students from effectively attaining the clinical competencies after we give them the theory. And a lot has been done to address these gaps in clinical competencies, mainly shifts in the paradigm in the teaching methodologies. We are shifting away from the traditional didactic approach to teaching to the use of competency-based approaches. to the use of approaches that focus on exposing the learners to repeated opportunities for practice of different skills in order to enable them learn these skills and refine them throughout their clinical exposure. And similarly, many institutions we have had have been able to adopt the simulation methodology. This is to support the acquisition of clinical competencies. Now, we already know much about simulation. And simulation, from the literature, we are told it's not a technology, but it is an approach or an educational methodology that we use to replace the complex and real-life environments we encounter in the clinical settings with guided, interactive, and immersive experiences, okay, that help us to imitate those aspects in the real world. And we do this through the use of different expertise, different technology, and equipment available. Now, this increased adoption of simulation we have learned in previous sessions and even in today's sessions is largely driven by the need, the increased focus to ensure safety of the patients as the students learn. It's also been driven by the need to ensure that our clinical programs or our students have more hands-on learning. It's also driven by the need or the desire to ensure that the teaching programs or the educational opportunities are standardized so that a student in a university in northern Uganda as well as one in southern Uganda would receive the same kind of information as far as standards of practice. And we have also seen that the adoption of simulation has been driven by the need to ensure that our students practice and refine their skills in a controlled environment. Now, research has also shown us, and we have experienced it real life, that simulation facilitates application of theory and also helps to build the long-term memory of our students. However, when we look at available literature on simulation, we realize that it is lacking. And most of this literature is from high-resourced countries. We have limited information in our low or middle-income countries to refer to as we implement and go through the experience of simulation, partly because of the challenge of documentation and dissemination of a number of these experiences. Now, the problem, we see simulation has been adopted everywhere, globally, locally, but it is being done in a fragmented or sporadic manner. The implementation of simulation in different institutions is varied. We've learned in some institutions they are able to have weekly sessions. In others, they will have once, 2 weekly. And that brings a variation in how we are actually going about implementing simulation. And when we look at the prevalence of use or application of simulation, it is also varied. And we see prevalences ranging from 82 and above to 68 and even lower. And it is even much lower in our low-income countries. And like I said, the literature is not readily available for us to refer to in terms of prevalence, to refer to in terms of the practical approaches to the use of simulation. And so, as Muni University, seeing that we had just introduced simulation in our teaching program, we thought that it would be good to evaluate or review what we have so far done. And this study came in to help us do that. Now, the broad objective of our study was to determine the perceived benefits and barriers of clinical simulation among the undergraduate nursing students at Muni University. How did we do it? We used a qualitative exploratory design to gather in-depth information about the experiences of the students, and we targeted, or the study population focused on all the undergraduate nursing students who met the inclusion criteria. Now, the inclusion criteria was that the undergraduate nursing student should have had prior exposure to clinical simulation and that they were in their 3rd or 4th year of study. So in terms of the sample we worked with the 3rd and 4th year nursing students who had had some exposure to clinical simulation. And the rest, we used purposive sampling method, and we used a semi-structured interview guide, and we were able to have 3 focus group discussions held with groups of between 5 to 7 participants. The qualitative data analysis used the thematic content analysis approach. Now, allow me go to the results. We had a total of 17 participants who were 3rd and 4th year BNS students. And in terms of the gender, we had 13 males and 4 females. There was a bit of difference or variation, or we can see that the females were few and more males, because one of the cohort of students had a reversed composition. They had more males than females for that particular year. And so this also resulted in having more males than females in the study population. Now let's look at the results. In the analysis of the perceived barriers of the students, several themes were developed. Theme number 1, the students perceived that simulation allowed them to have a friendly error reduction opportunity. And from one of the quotes of the participants who noted that they had errors, or they were performing errors in their clinical practice. However, when they were exposed to simulation, it gave them time or room to improve on those errors that they had. Then the students also perceived that simulation promotes a culture of team-based care. And from one of the participants who was able to play a leadership role, we can see the quote that is there. This participant became a leader and realized the importance of leadership as they were doing the simulation sessions. Then thirdly, the students perceived that simulation promotes learner-centered clinical teaching. And in one of the quotes, the student appreciated or mentioned that simulation gave them a background where they could interact and have discussions with students, but also interact amongst themselves as peers and interact with the clinical staff in the hospital. The students also noted that simulation improved their confidence. I think I don't need to dwell much on this. This has been shared, an experience shared by the different members of this symposium. And one of the students here, who was even smiling, said that initially they were nervous, but over time they gained the confidence. Then in theme 5, they noted that simulation built their clinical competency. And one of the students who had not had an opportunity to encounter a child with neonatal sepsis was able to learn about how to manage neonatal sepsis through the simulation sessions held. And then they noted that simulation builds their clinical decision making skills. And this is a quote from one of the participants who say that, first of all, it taught me how to make clinical judgment within a group in the shortest time possible, showing that simulation is beneficial because it empowers us to make clinical decisions. And then the last theme under the perceived benefits was the theme of nurturing professional behavior. And this mainly focused on the accountability aspect of care of patients. And one of the students noted that because in simulation we go through and also empower them in the area of documentation as an aspect of accountability, they were able to appreciate that. And this accountability nurtures the professional behavior expected of us as nurses. And next, we are going to look at the perceived barriers. Similarly, a number of themes were generated from the students' responses. As barriers, time limitation was a major barrier mentioned by the students, and the time limitation was in the number of simulation sessions scheduled. They thought that one session was not enough for them and would have loved to have more sessions per week. Some of the quotes of the students mentioned that the time was limited because they felt the 10 or 20 minutes allocated per simulation session was not enough. Then secondly, they thought that our simulation had limited realism. Much as we are saying that simulation is supposed to, as much as possible, imitate or mimic reality, but they thought that our simulation had limited realism. And here, one of the participants who expected a patient's voice and did not receive it, thought that that was a limitation in the terms of realism. And that is one of the examples. Thirdly, resource limitations. And the major limitation here was in the area of limited equipment, as well as limited number of faculty to run these simulation sessions. And we can see this participant noted that sometimes during debriefing, they may want to demonstrate something, that is, the faculty may want to demonstrate something, but the things or items needed are not there. Another theme that came about was the limited instructor debriefing. In this, the students expect that as we debrief, the lecturer is able to go ahead and demonstrate to the students and correct what was done wrong, as one of the examples of the limited instructor debriefing. Then theme number 6 was on limited learner motivation. Now, because the simulation sessions we are having are not tagged to a mark, but may be tagged to a mark for attendance, but not a mark like you would assign for a test or quiz done, they thought that because this simulation doesn't earn the marks, it may not motivate them to attend the sessions. And then lastly, the large learner group sizes were also a perceived barrier in our case. Okay, and this participant mentioned that another negative experience is that simulation is always done in groups, and sometimes, though the task may be done very well generally, but at a personal level, they may not have done much. So the large learner group sizes was a perceived barrier. So in conclusion, The students we involved perceived clinical simulation as being beneficial because it gave them a safe learning environment. It provided a learner-centered environment that nurtured their confidence, that built their clinical competency, clinical decision-making skills, as well as professional behavior. On the downside, the simulation was limited in terms of time, human resource, large learner groups, which hindered effective implementation of the clinical simulation. Lastly, these findings from this study are very beneficial. These findings can be used to mobilize for resources, to guide the design of learner-centered simulation teaching strategies, to make use of the existing personnel to support the delivery or the implementation of the simulation sessions, and also to support the faculty in the review of the curriculum in order to incorporate strategies that can help us implement simulation in the most appropriate way while addressing the students' perceived barriers. And that was all from me. Thank you very much for listening.
Thank you very much, Mrs. Susi. That was a beautifully well done qualitative study based on your perspectives, student perspectives. I think we're going to take all the questions at the end. So I'm just going to have you sit maybe at the front and we'll have everyone join you as they do their presentation. I'd like to call up the next speaker, Ms. Tasiwe Dos, also doing a study from Muni University, I believe, also on the student perspectives of the nursing students. Sorry, Mr.
Good evening, everyone. My name is Twes Jedeus. I'm a teaching assistant in the Department of Nursing and Midwifery at Muni University, and I'm the coordinator for simulation-based learning at Muni University. And we conducted a study with my colleagues who are around on nursing students' perception of simulation-based teaching and learning methodologies at Muni University.
Oh, he can change the slides and he pushes this one? Yeah. This one? Yes. No, this one. This one. Okay.
Okay. This is the picture of one of our simulation session for our third year nursing students. So simulation-based learning is becoming very popular in middle and low-income countries, and which includes Uganda. And simulation has been found to provide an ideal background for learning, which improves teamwork and behavior skills. And since the delivery of medical care is a multidisciplinary approach, we really need teamwork and behavior skills among the team members. Globally, nursing education faces many challenges, and this includes bigger number of students. We have fewer number of preceptors in hospitals. We have short patient stays within the hospital, and in some cases, we have patients who have conditions that are not common. And these challenges may need simulation approach, simulation-based learning approach, where we can simulate some conditions that may not be commonly seen by nursing students in their training. And some studies have found out that simulation improves confidence and makes the students to practice safely when they reach in their clinical areas without making errors. So many studies have been done on the perceptions of nursing students on simulation-based learning in many areas. However, internationally, but locally, there are few studies which have been done, and specifically wanted to do this study at Muni University to find out, yes, we have enrolled simulation-based learning, but what are the students' perception towards this teaching methodology? Okay, our objectives, we wanted to determine the nursing students' perception, the pre-simulation perceptions, and we also wanted to determine the post-simulation nursing students' perceptions towards simulation-based learning. And we used a one group pre and post test course experimental design, where we followed students who were in their third year, and the study site was Muni University Department of Nursing. And the study population, we considered all the third year nursing students in the 3 academic years. The academic year 2020, 2021, 2021, 2022, and 2022, 2023. And in this study, we had a sample size of 60 students who consented to participate in the study. And the sampling procedure, we used a convenience sampling. Since we had fewer number of students in each academic year, so we wanted to at least consider all the students to participate in the study. On the quality management, we did a pre-testing among 3 students, so as we can come out with a very clear questionnaire. And the data collection, we used a self-administered questionnaire, and we analyzed the data using SPSS, version 23. So in this study, we are looking at the perceptions, and we adopted a questionnaire from the study by Naga, which was done in 2020. And this study was looking at also at perceptions of simulation-based learning among medical students. And it had so many parameters to assess the perception. But specifically in our study, we were able to capture some of these parameters. And one of the parameters was looking at whether students perceive that simulation-based learning is an ideal learning strategy. And 80.5% of the students were able to say that simulation-based learning is a very ideal strategy. And 64% were able to say that simulation-based learning helps them to apply theoretical knowledge in their practice. Because in this study, we gave the questionnaire before they are introduced to stimulation. Then we gave the questionnaire after their second semester, after the 2 semesters of simulation. And 69.3% were able to say that simulation has helped them to retain knowledge which they acquire in their training. However, 22.4% of the students were able to clearly single out that there is inadequate mannequins in the simulation room. So some of the mannequins we were using were more of improvisation. So some of the students were able to notice that. So in this study, the overall perception of simulation was positive, and students were interested in utilizing simulation-based learning as a teaching methodology. However, simulation-based learning is still a challenge in a resource-limited setting, and there is a need to have adequate mannequins. And the study limitation that we had, the post-survey for some classes was not done in time. Because of so many activities in the department, we were able to do a post-hoc test for some class when they had entered their 4C. That was one of the limitations. Thank you so much.
Thank you, Mr. Tsegwe. I'll also have you have a seat at the front, and we'll take all the questions at the end. Two very nice studies from the nursing department at Muni University. I thank you for them. I'd like to call Dr. Dada Santorino, or is it Nalini? Oh, together, okay. A collective presentation. Let's randomized control trial and looking at knowledge retention with a framework, a clinical assessment framework.
Good afternoon. We're going to try and wake you up and do things a little differently. The two of us are going to do this jointly, and we are both at a kind of a similar level, working in a health center, and we're both healthcare providers. Yes. And we've been doing some peer-to-peer learning, and we're on in the middle of the night together. And a mother brings in a baby and gives it to me. And I see that the baby is having these movements. And I call, Dada, can you help? It looks like this baby doesn't look well. Can you see what might be wrong with this baby?
Can you please sit down? Okay. So I noticed that this baby is convulsing.
Isn't it? Maybe it's just jittery.
Well, let me hold the hand.
Oh, okay.
And I see it continuous convulsing. And you know, when we were doing helping babies survive,
yeah,
they told us that if you see a baby's hand moving like that, and you hold and it continues, that's not jitteriness.
Oh, yeah,
that's a convulsion.
You're right. Maybe we should assess the baby with prisms. Should we do that?
Yes, I think so, because I last managed a baby like this about...
Because I'm scared. This mother
about
is scared.
3 weeks, 6 months ago. I don't remember actually how to effectively manage such a baby.
Well, they kind of said if it's a seizure, we need to give some injections. I think they said phenobarb. I haven't seen a baby like this for 6 months. Have you seen one lately?
No, that's why I wanted us to really be able to show how to manage this with prisms.
It's not showing up. Let's talk about it.
Okay. So, okay. So you're going to keep assessing the baby, and I'm going to use my prisms to do this.
Okay.
And
yeah, it's showing up now.
Yeah. So do you remember the patient's ID number?
15.
468. 468. Okay.
That's what the mother gave me.
Okay. So
it's still
date of
seizing.
birth?
Hurry up.
Yes, we need to do this quickly.
She told me he was born on the 7th.
On the 7th, okay.
Of June this year.
Okay.
And told me it was a term baby.
Okay.
And the weight, the mother didn't really know, said was normal. So she kind of said like 6-7 pounds.
Yes,
So
but I see that it was weighed.
Okay.
Okay, so it's 3 kilograms.
Okay.
Yes. And the temperature when you assessed him?
Temperature was okay. It was
Okay.
36.8.
36.8. And the heart rate, let me feel it. Okay. See, 150. Okay. And I see he's breathing a bit fast.
Just a little fast. I counted it. It was about 45.
45.
Yeah.
Okay. And I see he's pink.
Yeah.
He's clearly not dehydrated.
No.
And
He was feeding well before he started having this seizure like 24 hours ago. And for 24 hours, she said he hasn't fed well.
so he's not really fed well.
No.
So he's poor. And let me do the capillary refill time. That's normal. That's fast. So, and then he's not having any noisy breathing. Chest is not having indrawing,
No.
but is convulsing now. And
Should we call the doctor?
let's just, we can call him shortly, but let's first complete the management.
Okay.
So that by the time the doctor comes, we can be able to see what happens.
That's a good idea.
Mm.
So what does it say we do?
Okay. So we're going to give Prisms a few seconds as
Okay.
it understands what needs to be done.
Okay.
So it says the baby is having poor feeding. We need to check blood glucose or give him IV 10% dextrose.
Let's give the dextrose because
Okay.
with the machine is not working for the glucose.
All right. So let's give him the dextrose. We've given him the dextrose already, but it says we should NG tube feed him if he's unable to cup feed. But he's
still
convulsing
seizing.
now.
He's
Let's
still
see. Let's
convulsing.
do that later. So now, IV antibiotics. For convulsions, we need to give him 10% dextrose, which we have given.
Yeah.
And it says we should consider phenobarbital.
Let's give the phenobarb. I don't remember the dose.
I don't remember the dose either, but I think Prisms can help us. Let's click on this. So, okay, this is it.
Oh,
So
there we go.
Prisms is telling us to give 20 milligrams IV slowly
Okay.
over 5 minutes.
Okay, let's do that. Can you go
So
pull
let
it
me
up
do
while
that quickly.
I keep the baby, I'll keep holding the baby.
All right. So let me get my phenobarbital. I've mixed it. So let me give it in. Okay. So we're going to wait a little bit. Sometimes this phenobarbital takes some time too.
Oh, it's settling down.
Yeah.
Starting to settle.
Okay. All
So
right.
what are we going to do now?
So let's see what Prisms tells us. Yeah. Says the common causes of convulsions could be birth asphyxia, some infections of the brain,
Okay.
hypoglycemia, and hypocalcemia.
So we treated the glucose,
we've
right?
treated
We gave
the
the
glucose.
dextrose and it didn't stop.
Mm.
Should we give the antibiotics and then wait for the doctor to decide? It doesn't
So
seem to.
let's go back to the management. It says, yes, it has infection signs, so we
Yeah.
should consider a complete blood count.
Yeah.
Blood culture, give IM or IV antibiotics.
Okay,
So I think you're right. We should give the antibiotics.
and then find out, and then we'll have to find out what the doctor thinks we should do because
Okay.
Prisms doesn't.
You remember what the guidelines say about giving antibiotics?
No.
Well, in Prisms, let's look again. Prisms, so say antibiotics is in blue, so which means it has additional information.
Okay.
And we click on there. So it says the treatment of neonatal sepsis. Always give a combination therapy. So IM or IV ampicillin, 50 milligrams per kilogram every 12 hourly, and IM or IV gentamicin, 5 milligrams per kilogram twice a day.
Okay.
I think that's what we should do.
So we can do that, but we still don't know what to do. I'm a little worried. Prisms is not complete.
So
They
what-
don't
what
tell us
I-
what to do after that.
Yeah. So we've stopped the convulsion.
Yeah, and we'll give the antibiotics.
We've given the antibiotics.
And the glucose.
We've given the glucose.
Now what?
Okay. So when we
What I
review
should
the
tell the
message
mother.
again, say If oral feeding is not possible, give dextrosaline. But I think we can NG tube feed the baby.
For now.
For now. But I understand, yes, there may be some things that Prisms does not really tell us.
Right.
Well, why can't we report to Martin some of our concerns about
Let's do
Prisms?
that. So next
and then,
time we know.
If we think there's something that is missing, we can be able to talk to him and then see how the technology can grow.
Sounds like a good idea. So let's give the antibiotics.
Okay.
We're going to stop here, guys. Thank you very much. She wants us to sit here, so sit with the baby. Oh, let me turn this off.
Great. We have one more presentation. I'll ask Dr. Flavia Tuambazi to come forward. And it's talking about the frequency of ventilation skills, newborn ventilation skills practice using the air device.
Good afternoon, ladies and gentlemen. I'm Dr. Flavia Tumwebaze. I'm a medical officer. I work at the Simulation Center, Mbara University. This is one of the studies, the many studies at the Simulation Center. And in this study, we aimed at establishing whether frequent practice improves newborn ventilation skills retention among medical, nursing, and midwifery students. So the names you see over there are of the team with whom I worked on this. Studies have shown that almost 2 million newborns die annually from breathing problems. However, the good news is that majority of them can be saved by birth attendants, can be saved if birth attendants had the right skills and equipment to give newborns timely and effective ventilation. Helping babies breathe reduces early neonatal mortality by up to 47% and fresh stillbirths by up to 27%. The Augmented infant resuscitator, which we had seen from the previous presenters, one of the previous presenters, Dr. Ochora, demonstrated the air device, provides feedback during bag and mask resuscitation. So like we already saw, this device is added to the bag and mask and used to resuscitate a newborn, and it monitors ventilation quality and provides real-time feedback to users. However, it's not known whether the device can be used to support knowledge and skills retention among students. So our participants for this study were undergraduate medical, nursing, and midwifery students at Mbara University. And these were the students in the clinical rotations. So for Mbara University, those are third and fourth years for nursing students, and medical students, third and fifth years. So we randomized these participants into two arms. Some were to practice ventilation with feedback from the air device, and others were to practice without feedback. We further randomized them into practice frequencies of 2 weeks, 4 weeks, and 8 weeks. We assessed these participants before a training in Essential Newborn Care 1, and after the training, immediately after the training, and again 3 months later in helping babies breathe OSCE scenario settings. So those two are some of the feedback that we get from the air device while practicing. So our results were analyzed in regard to these two outcomes: time to effective ventilation and duration of effective ventilation However, like we already saw, there's more feedback that we can get from the air device during practice, like the integrity of the airway, the ventilation rate, the pressure of ventilation. Yes. So these were some of the results for fast effective ventilation in seconds. So the less the time to achieve the fast effective ventilation, the better. So from these results, we can see that we had here 2 weeks practice frequency. The participants who are practicing every 2 weeks with feedback, receiving feedback from the air device, had less time to fast effective ventilation compared to the ones of the same frequency but with no feedback. However, all the p-values for this analysis were not statistically significant. So when we looked at the duration of effective ventilation per 120 seconds, the participants were practicing ventilation uninterrupted for 120 seconds, which are 2 minutes. We found that those who practiced every 2 weeks with feedback had higher duration of effective ventilation compared to the ones without feedback, as you can see. And the longer the duration of effective ventilation, the better. However, there was no difference in the other practice frequencies, the 4 weeks and the 8 weeks. There was no difference observed. So when we compared the 2 weeks, those who are practicing every 2 weeks, to the ones that were practicing every 4 weeks, when we look at the 3 months assessments here, we see that the duration, the ones who are receiving feedback from the air device, the duration to effective ventilation is clearly higher than the ones who are practicing every 4 weeks. And also here, when we look at the ones practicing every 2 weeks compared to the ones practicing every 8 weeks, the ones of 2 weeks frequency have a higher duration in effective ventilation compared to their counterparts who are practicing every 8 weeks. So from these results, we concluded that neither frequency of practice nor feedback affected the time to achieve effective ventilation, like we saw. The p-values were not statistically significant. And we also concluded that the duration of effective ventilation improves after the training and significantly improves at 3 months with more frequent practice. The 2 weeks, those who are practicing every 2 weeks had significantly higher duration of effective ventilation compared to the rest. We also concluded that feedback with 2 weeks practice frequency improved duration of effective ventilation, but not with less frequent practice. And we await results from other analyses of effective ventilation, like I already told you, the mask leak, airway blockage, ventilation rate, and excess ventilation pressure. I thank you for listening.
Thank you, Dr. Flavia. We'll have you join them at the front there. I invite you to start thinking about questions, and if anyone has a question to start with, yes. While we're waiting for them to come up, Miss Susie, I wanted to know, was there anything in your qualitative data from benefits and barriers or that surprised you? Was there anything in your data that you were kind of not anticipating?
Thank you. Yes, I didn't anticipate them to perceive that the debriefing was not adequate or as expected. So that was kind of a surprise for me. Yes.
And one question I had for you, Mr. Swigwe. 64% of the students felt that they could apply the knowledge after. To me, that seems a little surprisingly. I thought it might be higher than that. Any reason why you think that students' perception was that, because it often allows people to kind of take the theory to practice, and that there's still a fair percent of students who didn't felt they quite got there with their simulation? Were you surprised with that value, or did that seem what you were kind of expecting?
Thank you so much. So the 60% perceive that they can apply simulation into, they can apply the theoretical knowledge into practice. And I anticipated that we should have gotten a higher percentage, but from our assessment, in the pre-assessment, the percentage was very low, at around 20%. But when we did the post-assessment, the percentage had increased up to 60%. Yeah, it was a big change of 40%. So we assume that if we continue with simulation, we may be able to have a higher percentage. Yes.
Thank you very much. Was there a question from the audience?
Thank you. My name is Monica Andrew, a lecturer from Muni University. I think my question is going to Dr. Datta's team. It was a very interesting scenario, and I think I've really gotten in love with the Prism. However, when you're consulting the Prism and the child is constantly convulsing, are you not worried that it's going to delay and maybe the condition worsens and we get a different result from what we are expecting the Prism to do for us? Thank you.
I think the key there is that you quickly need to assess the baby. Now, what we could do, as you pointed out, have a different assessment tag, which does the primary assessment, and then you can complete the assessment later. Right now in Prisms, we just have a comprehensive assessment, but you do have to make sure that it's not jittery. You do have to make sure the blood pressure or perfusion's okay. So some of the things you just have to do before you can do the treatment. And if you really look at it, I don't think it took him more than a minute to really, it was two of us. If he was doing it alone, he might have even done it a little faster. But I'd let him comment on that.
Right. So there is another section of Prisms that can give you quick access. So the thing was, we wanted to know the management of a convulsion. And so in Prisms, there is something called, oh, I'm supposed to say a screen first. Okay, so if you can, sorry.
There it is.
All right. So when I opened my app, this is the welcome screen. And during the skit, where I went first was to go and enter the patient number. But there is an option in Prisms not to do that, because I wanted to do the management of a convulsion. So what I do is I go up here and I go to history. When I click history, I will go to any case that has convulsion, okay? So convulsing now, check airway, breathing, give 10% dextrose, consider IV phenobarbital. So in the history, what it does is that all the management plans generated from when Prisms was used in the what? In the ward, all are there. So then all I need to do is to go to any management plan that has convulsions, and I'll see there, I'll click on convulsions, and it will take me to the management of what? Convulsions. So it has that quick access that will not require you to do the complete what? Assessment, so that you can manage the emergency first and then go later to do the complete assessment of the baby.
And that's especially important when the baby is having breathing problems. So the reason it was designed that way was less for convulsions, but more for breathing problems where you don't want to spend the time trying to do a complete assessment.
Hi, I have a question for Ms. Edna. Thank you for the presentation. So I noticed one of the perceived benefits from the students was the fact that they could feel like they had a positive environment where they could fail and they could learn from their failures. But at the same time, one of the perceived barriers was the fact that maybe this isn't being tested the same way a test or an exam is tested. So I guess my question is are there any ideas about how we can balance that that testing ability and give those students the motivation to perform to their highest ability while still creating an environment where they feel like they can fail and they're not super pressured, they're not pressured by their marks, but they're just in a purely learning environment?
Okay. Well, the idea would be to organize or to develop a package that would require the students to probably self-assess and self-score their abilities after each session. And then at the end, and that would be done over a series of simulation sessions, and then have a final assessment that would be done by the faculty to gauge the total, knowledge or skills acquisition or competency levels after a certain period of time. So I think if we involve them in individually evaluating themselves or having their peers evaluate themselves, that should be able to motivate them. However, we would not necessarily tag a mark for the self or peer evaluations, but then tag a mark for the final assessments that would be done. Thank you.
I just want to make a quick comment to tell you what the Helping Babies Breathe, how we learned. That what you pointed out is very real. So what we did was, and that's where peer-to-peer comes from, that the two students would practice on their own without the facilitator, but they would have a checkbox where they could pick up on their own what they were not doing. And then when the two students were ready, then the facilitator would go through with them. So they were in a safe environment with their colleague, learning from each other.
Thank you.
Thank you so much, presenters. My comment goes to Mildred. The participants you used, they gave good responses, and I appreciate. But my concern is, do you have any plans of following these students, maybe in the clinical setting, see that the knowledge and the skills you have impacted from the skills lab, from simulation lab, they are translated to clinical setting on real patients? That is my question. Thank you.
Thank you. I'm Lois Charikunda, postgraduate, critical care nursing. My question goes to Dr. Tumwebaze on the AR device. Has it been taken toward used on real babies, or it's still in the lab? And if yes, how is it infection control, since it's an electronic device? How are you handling the infection control part of the device? Thank you.
We'll have maybe Ms. Edna first.
Okay. Thank you for the question. Now, the way we do our simulation is that we run them concurrently as the students go for their clinical practice. And yes, once we have done a number of sessions with them, and these sessions are done weekly in different disciplines. So when they are in the clinical settings, we do follow up on the actual implementation in the real life setting, in the clinical setting. So yes, we follow them up, and we do include a number of those scenarios or situations in their final practical exams. So I believe at the end of it all, we are able to gauge whether they have mastered the skills over time.
Thank you for the question. So the AR device has not been used on ward on babies. It is still under investigation as an education tool to medical students and nursing students and midwifery students to see whether it enhances skills retention. Yes, it has not yet been used on ward on babies.
Maybe I'll supplement what she has done, she has said. So the AR device now is I'll say it's a commercial product now for resuscitation practice on babies, on mannequins, okay? So neonatally. It's used in Uganda now, so for the study that we have doing for in-service is in Mbarara, Lira, and Busitema. It's going to Kuhas and Nigeria next. But in Kenya and India, the AR device is being used in health facilities now for low dose, high frequency practice. In Kenya, they have used it. This is the 4th month now, and the data is very good on their skills retention. It's amazing. The Indian sites have used it. This is their 2nd month. And we've seen significant improvements in skills post-training already. And the skills seem to be continuing just to improve and improve. So I just wanted to add that to what
I was also asking about the infection control. Yes.
So the version of the AR device here is not for human use only. It's for practicing your skills on mannequins. And as it's proven now in this Tanzania study, when you practice your skills on mannequins and you're good on mannequins, you actually save real babies when you ventilate without at the AR device. That's proven. So that's for the training device. The clinical device is work in progress. And the way we are thinking through the clinical device is that, you know, the venturicle that communicates with the bag and mask and the airway. So the way the clinical device is being developed is that you can be able to rip it apart. So you detach the electronic components that give you real-time feedback from the venturicle that is in line with the airway.
So the venturicle, you can autoclave, you can sterilize. And then the electronic component, you can wipe it clean with hand sanitizer, so, okay? But when you're preparing for a delivery, then you can bring the sterile venturicle, attach it to the clean electronics, so that when you're ventilating, your airway is still sterile. That is how it's being designed, but that is a few months down the road. Thank you.
Thank you so much, Dr. Data and team. My name is Lugaju Charles, and I'm a fourth-year medical student at MUST. Whenever I talk about simulation for life, I see opportunities of growth, not only in my medical knowledge, but in providing solutions to community challenges. My question goes to the Prisms team. We are in an era where information is the new gold, and I'm looking at the fact that information that we collect from patients is going to become ambiguous, is going to accumulate over time. And I was thinking, is there a plan of maybe utilizing this information to create an artificial intelligence-based platform that can provide a better way to assess patients that could be a faster option than what we're having currently? And the other question is that, how safe is the information that we've created, that we obtained from the patients? Thank you.
So Prisms uses artificial intelligence. Now, and as you know, artificial intelligence algorithms can grow with time and can become more and more complex with time. And that's what Prisms is positioned to be able to do. So Prisms now has more than 50,000 babies assessed with it. And the learnings we have had from that has improved the algorithm a lot more. And so there is room to be able to grow the algorithm even to the management of more and more complex what? Babies. So that room is there, and that's what the Prisms team is positioned to what? To do, and has already been doing. So in regards to safety of patient data, now every country has its rules for patient data, and Prisms follows the rules of that country, where patient data should be stored, how patient data is accessed, and we make sure that when we are deploying Prisms to a new country, we follow those rules by the book. Because if you mess up, even in a small way, you will be delayed in the deployment of Prisms for a long time. So we make sure that we do that due diligence to make sure patient confidentiality and the data laws around patient data are followed to the dot. Thank you.
Thank you very much, Dr. Data and everyone for the presentation. I have 3 questions. One is, from all the presenters from the different universities, one of the major challenges is inadequate resources. For example, mannequins. So I'm wondering, in case we do not have the mannequins to use, if we use our fellows for simulation, isn't it still simulation? Then my other question is to Miss Mildred. You talked about debriefing being inadequate from the feedback you got in the research. I, as a student, I can't say I agree or I disagree, but
I'm requesting to know whether we've thought about the methods of debriefing. Then immediately after debriefing, we go back to practice the right things we've taught. Because if you debrief and then we are probably tired, we shall come back when we do not remember or may not get time to practice. Or even debrief while we try to do the right thing. Then the other question is about the Prisms application. Is there a way for us to access the patient's information in case that patient has come back for another visit or they visit another facility that has Prisms as well, but to access that information for that specific patient? And also, for the cases of patient autonomy, in case the patient refuses the modality that is suggested by Prisms, are there plan Bs? Thank you.
So I'll do the first one very quickly. Simulation is a methodology. We didn't have mannequins, and we would practice with just usual dolls. Sometimes we would even take a blanket and make a doll and pretend, and I still do that in different environments. So the methodology is just as important, if not more important, than the mannequins.
Okay, about debriefing. In this study, the students' expectation was that the debriefing session would be followed by a session of, replaying the actual steps expected in the right approach. Now, from my understanding of debriefing in simulation, it deviates a bit from that expectation. It's an opportunity for us to help the students identify the challenges or the things that were not done right and use that as an opportunity to let them understand the right steps or protocols that would have been followed. And so I think, this calls for probably more sessions on what the debriefing approach really should follow, and then try to incorporate those in our debriefing sessions. Though from my understanding, I don't think it would be feasible, I can be corrected on that, to go through, for instance, if a session requires or involved intervening and demonstrating several clinical skills. My understanding is that those clinical skills would be covered in a different session, and then this simulation session is an opportunity to help them integrate different sets of knowledge that they have obtained through their training. So, I would need more guidance probably on that from the team from Massim's lab. Thank you.
So what you are suggesting, that if you make an error, maybe you debrief and then go back and then try and do this. There is a methodology called rapid cycle debriefing. So during the scenario, when the participants are doing the scenario and they do something grossly wrong, you stop the scenario, you quickly debrief, discuss, restart, and continue. Okay? So you tell them the right thing to do, and then restart and continue from there. Okay? So that's a methodology that already exists in simulation called rapid cycle debriefing. And then in some centers, they believe in also, after debriefing fully, the way it's done now, you put the students back to run the same the scenario. But that's all dependent on how much time you have. And for the Prisms question you said, when patients come back, as long as they have their patient number, you will be able to follow them longitudinally. Yes.
Thanks to all the presenters and for the excellent presentations and sharing your research and studies with us. And thank you to the audience as well for all your very good questions. Thank you.
Good evening, ladies and gentlemen. How are you? Yes, you are very fine after a long, beautiful day. I believe we have learned a lot. It's been fruitful and very informative. Do we all remember the slogan for Simulation for Life? Do we? Okay, I will say Simulation for Life, and I want to hear a big, loud voice of that, how you will respond. Simulation for Life. Is that the way you save lives? Simulation for Life. I am Sheila Ninye Tuinamasko, the International Relations Officer of Bara University of Science and Technology, and I congratulate you upon reaching the closing ceremony of today's symposium. As we prepare for the last session, kindly stand up. You know fruits are very important to eat, so I request each of us to stand up. All right, fruits are very important. We will pick using the right hand, and we are getting guava fruits that are from very high. So let's see how you pick guavas. How you used to do it 20 years ago with the right hand. Now pick them and put them in a basket down on the left hand. On the left, pick again, pick more mangoes. Thank you very much. You can have your seats. I will invite Engineer Martin to first take us through a fire chat session, and then we will continue. You're welcome, Engineer Martin.
Thank you so much, Shira. Can we clap for her? All right, we are coming towards the end. I know there's been a lot of learning today. I've learned so much from simulation. As an engineer, I now have a lot of knowledge about simulation from the different panelists and the different presenters that we've had today. And I hope you also learned so much from the different breakaway sessions that we had. So we are having the last fireside chat, which is going to be moderated by Mr. Peter from Elma. Yeah. So Mr. Peter, you're most welcome. Let's clap for Mr. Peter as he comes to take the floor.
Thank you so much, Martin. Good evening, ladies and gentlemen. It's an honor for me to stand here and speak in front of you. So for the last session, we'll be discussing lived experiences from implementing partners. So we've had the health workers share. We've also had the student share. But now there are partners that are being helped by Muni University, and this is part of scaling to also have simulation as part of the programs. So I'll invite the first person on the panelists, Grace, the program manager for Madara. Grace supports the work of Adara in Chiwoko Hospital, Luero, Nakasongola, and Nakaseke. The next panelist is from Quam, Dr. Jerry. He's a senior technical advisor of programs at Quam. Dr. Jerry supports the work of of Quam in Karamoja, Lango, as well as West Nile regions. And then the last panelist is Dr. Bonventure from Seed Global. Dr. Bonventure is the Regional Director of Innovations and Strategy at Seed Global. He leads the work in Uganda, Malawi, Sierra Leone, and Zambia. Thank you to have you here. Okay. So I'll start with the last person to join the panel, Dr. Bonventure. How has mass simulation team and the linkage working with them impacted your programs as Seed Global, as well as your goals, mainly with the work in Muni University?
Thank you so much. Bonaventure, again, is my name. I work with Seed Global Health. I think just before I speak about Seed Global Health, just to appreciate Dr. Data and his team on the progress made against simulation, not just at MUST, but sort of like planting the seed across the entire country. I have a personal story with simulation. I joined medical school at a time when they were transitioning curricula. So it so happened that elective placements, which used to happen, I think, after you've done your first clinical rotation, happened before you do that. So clinical rotations were starting in 4th year rather than 3rd year. So I show up at Jinja Regional Referral Hospital, and the obstetrician introduces me to the midwives on the maternity ward and says, the Musao who was here left yesterday, we have another one. So Musao in Uganda loosely means health workers. So it applies to doctors, nurses, clinical officers. And the person who had left was an intern, and I was a 3rd year medical student. And he lives. And the midwife tells me, doctor, we actually have a mother with eclampsia. So we enter, and there was a very pregnant adult female smeared with sugar from head to toe, screaming at the top of their voice, the whole emotion. Even the courage to say, I don't know what to do, I couldn't get it. We had a small book, I think it was called Integrated Management of Pregnancy and Childbirth. The first step used to be shout for help, but I couldn't even shout for help. So knowing the skills and being able to confront the overwhelming moment of emotions, of everything, is a very different thing. Getting the chance to go through that in a controlled environment that is safe for you gives you the courage to even say, I don't know what to do here, because you've gone through the communication. So I just wanted to give the personal story. So I envy the people who have had the chance to go through simulation. I think it creates a much safer space for health workers as well as for patients. So coming back to Seed Global Health and Sim for Life. So I think Seed Global Health works across different countries. We primarily partner with training institutions to try and collaborate on building the quality of training for midwives, nurses, and physicians. The biggest lesson we've learned is that when you have a center of excellence that you can leverage in scaling a skill or a methodology, it makes life a lot easier. For example, work with Sistema University, Lira University, Muni University, Mbara University, and Makerere University. But because Sim for Life has been doing simulation over and over, they know the process of startup, they know the typical barriers, they know the opportunities and how to sort of like scale that up gradually. It has become very easy for us, for example, to foster linkages between Muni University and MUST and not have to necessarily start that from scratch or even have to relearn the process of building it up. So I think for me that has been the most powerful lesson, that we don't have to have centers of excellence everywhere. I think if we have one powerful center of excellence that we can leverage, it can help us scale up across the board if we create mechanisms for fostering collaboration. Thank you.
Thank you so much, Dr. Bonaventure. So I'll hand over to Grace. So building off the experience from Adara, I know most of your work over the last years has been at your facility, and it's really excellent. You have a center of excellence, Chiwoko Hospital. And now you're scaling your program to other districts like Luero, Nakaseke, and Nakasongola, and you have a community piece to it. So tell us more about the train the trainer model that you've adopted from the Sim for Life team.
Yeah, thank you so much, Peter. My name has already been said, and what we've realized out of this is that knowledge is power. I think all of you can attest to that. And SIMS gives us an opportunity to build our confidence through the different trainings. I so much enjoy the free space. Most people run away from doing these practices simply because they have those inadequacies. When you go to the ward and you find a doctor who dodges work, most of the time they have some kind of incompetence. Go to the midwives, the same thing. Go to the nurses, the same thing. But somebody who has the skills will always be available to save life. Now, for us as Chiwoko and in Adara, one thing we've believed that each person, irrespective of where they were, they should have access to essential services. And these are, we are looking at education, we are looking at health, we are looking at all. However, we also have a philosophy or some saying of saying we should bridge worlds. And we do this by improving health. And today I'm glad that we are here to build the worlds, bridging the worlds, but enlightening ourselves and also empowering ourselves to go and build other people. Back to SIMS, we've been partakers of this, and at Chiwoko we've been able to build a strong team, but one thing we realize that we cannot have everybody at the same pace unless if you are so intentional. So through SIMS, simulation sessions, we've been able to train most of our health workers, and that has built their confidence. When they got the confidence, they are also able to replicate themselves into other people. And this has helped us to have kind of a multiplier effect in reaching out as many staff as possible. As an organization, you may not be having enough staff. We are all lamenting about human resource. It's everywhere. I don't think there is anybody in this room who can say for us we have enough. Any? Hello? So I think SIMS is one area where we'll be able to replicate ourselves through other people, but also be able to have a multiplier effect to the rest of the people. At Adara, we started by supporting Chiwoko Hospital, and like Peter has said, we have a center of excellence for newborn care. However, we realized that as we built that, many people continued referring to our facility. And this, at the end of the day, brought kind of burnout in staff. And the healthcare that we thought was a center of excellence, we're actually losing it because most of the staff were overwhelmed. We're seeing burnouts and people were not even able to deliver. And we thought of now scaling out to other areas. And we are going to use the approach of SIMS to reach out to the other areas. Currently, we are in a Kaseke hospital. And this has helped us because we have a maternal trainer who goes to that place once in a week to train the mothers, to train the health workers. And those health workers, among the health workers, we are able to identify champions who are able to do the peer-to-peer even when we are not there. I think if we can do that, this kind of information can be scaled out to the different health facilities. And at the end of the day, you find yourself operating in Muni, but when you are in Mbarara, simply because of what you've done. I want to give an applause still to join the rest of the team to thank Dr. Data and team. You've really done a great job. We can't thank you enough. Guys, when we are talking about life, it's like a joke. But it becomes serious when you are in their need of life and you can't pick it. When somebody is dying and it's not you, you think it's a joke. But if it's your baby, those of us who are mothers, we know how it feels to lose a baby. Those of us who are fathers in this house, you have sisters. That person who is losing a baby might be your sister, might be your wife, might be. So every other time we understand that, for me, that even increases our passion for saving their lives. And I think this is the way to go. We'll be able to reach out to even a broader population to make sure that we can save as many lives as possible. When you look at the data that we have currently, you realize that our country is almost not on track to achieve the target that we had set for the Sustainable Development Goal, and everybody is panicking. I think this is one area that we can use to ensure that we can achieve this by 2030. Thank you.
Thank you so much, Grace. And it's important to note that Grace is and the DARA team are providing solutions in terms of the human resource gap, because she says that this won't be sufficient at any point soon. So some of these approaches are important to help us scale, but also be able to support the mothers and babies to survive. So thank you so much, Grace. So I'll go to Dr. Jerry. You've been with the Sim for Life team for 6 years. That's quite some time. And in these 6 years, you've been able to do a lot in terms of training your staff. But we just want to check in with you. What are some of the challenges you've been able to address in terms of maternal and newborn health in some of the remote areas you're working in of parts of Karamoja?
Okay, thank you very much. It is true that Kwam has worked with the Sim for Life team for quite some time. Of course, let me start from the point of the data. You know, when you got the results of UDHS, you know, the indicators for neonates, you know, that 27 per, is it 1,000, has stagnated for so many years. And then sometime we've been discussing with Dr. Data and the team that what can be our contribution to, you know, this figure here. And of course, the Ministry of Health team also have been emphasizing that, yes, focus on the neonates is something that we need to all look into, especially partners who are intervening in this space of mothers and children. So of course, we've had this kind of brainstorming session multiple times with the team and Dr. Data and the team. And then we say, yes, technology has a role in doing this, because in some of the areas we've been doing things in the other analog way. And yet there could be the role of technology in improving outcomes. Especially our interest was the neonates. Because for mothers, even in Karamoja, deliveries in facilities had improved, maternal mortality were also impacted, but the neonates, we were struggling with them seriously. So of course, our immediate intervention was really to try to see whether we can create some neonatal centers of excellence, even in the remotest part of the country, that is Karamoja. That, for example, when you go to Moroto, there should be a center where you can comfortably, you know, take care of a sick neonate. When you go to Matany, for example, in a park district, there should be something like that. And then also we are going to Kabong Hospital, where we're also putting some intervention there. also thinking of Amodat, but we've not yet gotten the necessary resources. So when this intervention came, I remember the team from Quam, we had to first of all visit the simulation center to come and first be converted ourselves that these things work. And I must thank Dr. Data and the team. They took us through the simulation scenarios. Some of us who had left clinical practice for some time, you know, we are now into more programming. Then you start scratching your head now, this is, what kind of clinical scenario is this? So, but you saw that, we could see that, yes, the purpose for which some of the things were, you know, designed was very, very, very useful. For example, Prism as a decision support tool for a frontline health worker who might not have the next, you know, reference person to guide. We saw the usefulness, and that was why we had to support the deployment of Prisms in Moderator Regional Referral Hospital, in Matanya Hospital, and also those are in Karamoja, and then Bear Hospital in Lango, Yam District, and the Nyeka Health Center falls in the Yam District. But also at that time, it was really for us to also learn a bit, what is the health workers' perception? Is it going to impact on those indicators? And then we also started having like monthly brief meeting, which later on turned into quarterly, to kind of get the field experience and also with the team of developers to get update about what could be possible to improve outcomes for our sick children and neonates more especially. So I must say that the experience, the feedback from those sites is that yes, Prisms make decision making at that point very easy. Of course, initially when they started and when they used it over a period of time, they got to know. They now started predicting Prism, that Prism will get me this. But for us, we knew that that was itself a capacity building, because somebody now could know that if I'm sepsis, most likely I'm going to give ampicillin at this dose. Okay, so it went into up to that level. And but of course now they are saying, is there more? You know, that they are asking now, is there more that this thing can do? So that because if maybe you don't have ampicillin, what other options can you, you know? And yet the recommendation from Prism Premium was that give either ampicillin or gentamicin. But in terms of really, you know, that this is neonatal sepsis, this is hypothermia, this is, that guidance was coming clearly. So it was really serving very well its function as a decision support tool for the health workers at the front level. Of course, with this, we also started seeing the quality, the outcomes for neonates in those sites actually improving. Our challenge has also been that we needed to mobilize the additional resources to ensure that this is scaled up to much more than the sites that we are currently supporting. We've been also, of course, talking to our other donors, and in this case, at some point, we've been talking to UNICEF, also our friends from ELMA, and then also the Embassy of Ireland to see whether we can get additional resources. Because really, Prisms has demonstrated impact in terms of improvement of quality for our newborn, quality of care for our newborn. And we think that if it is scaled up, and at a bigger level, then we could dent a bit that 27 to actually come to much lower figures, even to less than 15. Commissioner, just thank you so much.
Thank you so much, Dr. Jerry, for sharing the experience from the service delivery side. I think that's really impressive. I think for me, the one thing that I pick up is across the board is the partnership. I think it's amazing. Hearing from Grace, talking about the amazing things that the partnership has caused. And then coming back to Dr. Bonventure, from your side, I know Grace and Dr. Jerry on the service delivery side, and you're more into the pre-service training. We just wanted to find out from you, what are you most proud of in terms of the partnership with the Sim for Life team, and what are some of the learnings that you think we can take away as we think about scaling the program to other areas as well?
Thank you. I think for me, as first say what I'm proud of at a personal level, and then at an organization level. At a personal level, I think there's something about when you go to Sim for Life, they don't tell you about simulation. They make you do the simulation. And I think that's a very powerful thing, experiential learning, walking the talk on what you say. Many times we go around and say, this is how you're supposed to manage eclampsia, this is how you're supposed to manage PPH. But the approach that Sim for Life brings to a table is do it and get comfortable with it, rather than us telling you about doing it. At an organizational level, I think the openness and the ease of collaboration with Sim for Life is profound. Not just the skills and the methodology, but at like the operational approach. They will seamlessly integrate in these institutions without planting flags or territories and So it becomes very easy if you're collaborating with other entities to foster collaborations, and they run kind of like in autopilot without necessarily having to accompany them. Thank you.
Thank you so much, Dr. Bonaventure. So I'll just open up to the audience in case anyone has any question. We'll take maybe in batches of 3s and then they'll respond. Any questions or comments from the audience? Okay. So as the audience thinks about the potential questions, I'll come back to the panelists. For many of you, you've worked with the Sim for Life team. And I think across the board today, there's been a theme of sustainability from all the people that were speaking here. From the service side, so I'll start with Grace. What are your plans for sustainability?
Yeah, thank you so much. For us at Adara, we've looking at all the 5 arms of health service delivery, right from antenatal. We are looking at maternity, we are looking at postnatal, we are looking at the neonatal care unit, because all those centers of delivery, if you miss out on anything, at the end of the day, you will not achieve. But we are also looking at bringing in the issue of leadership and governance, because we know that when you go to the facilities, even if you have very good innovations and you don't have leaders and governance on board, sometimes you can fail. So we are trying to incorporate in a lot of stakeholder engagement such that we can have all the leaders buying this idea of simulation, such that at the end of the day, we can work together and have results at the end of the day.
Thank you so much, Grace. Dr. Jerry, from your side?
Usually sustainability is a very big elephant usually to eat, no? So, but of course, for our experience was that the initial investment is the one which is very expensive for Prism, because you require initial deployment of gadgets, initial training of teams to become users of the system. But once that happens, the continuous meeting that usually should be taking place at the departmental level is actually good enough to allow continuous reorientation of the teams, but also the peer-to-peer approach allows you you can learn on Prism, the person who knows from the side to teach the colleagues. So if there can be a mechanism of doing this initial deployment, because it requires hardware and the software is deployed at the site, and then the site teams are taken through, then the continuation of the use can be sustained, especially through peer-to-peer approaches. This is possible. Because we are aware that today you have one health worker, tomorrow he has left, another one has come from school, has not heard about the technology at all. But if there is a team at the side that can teach, and then maybe also through continuous mentorships, that could also be one approach. But that initial investment has to happen for the other things to take place. Thank you.
Thank you so much, Dr. Jerry. So coming back to Dr. Bonaventure, still with the same question. I know through the day, I think, and also hearing from the institution sharing, for many, they stated that the space has been provided for some. And then the equipment is now there. For some, I think there's a gap in terms of having the staffing. So what are your thoughts in terms of sustainability at institutional level, where the training is actually happening?
Thank you. I think I come back to the previous panel about simulation as a methodology rather than you can apply simulation in very different contexts. So I think for us who work with pre-service training institutions, naturally this is their day-to-day bread and butter, because it's a proven modality of training. There's a temptation to think that, especially if we do benchmarking, that if I don't do high fidelity, I don't have high fidelity mannequins, I may not be able to do simulation. So I think being able to unpack and disentangle those two and get people to appreciate that they can take the methodology and apply it in their very different contexts, I think it takes away the pressure. So I feel like without the investment in the high-end equipment, then you're not able to do simulation. And I think also leveraging on existing resources. Someone talked about simulating using like standardized patients or colleagues. So there are different resources we can use within our environment. And that, I think, the biggest challenge around sustainability comes from investment, like Jerry said. Thank you.
Thank you so much, Dr. Bonvecha. I think in terms, and as you're hearing, I think the common theme here is the leadership is critical for it to work at institutional level, but also just being flexible in terms of using the available resources. So I think that's something we'll definitely look at, but also as we look at scale, I think this would be critical. And for those that are doing it, would be good to document this because that really helps to inform people about experiences that have been had in different places. So I'll come back to the audience just to check in case anyone has a question. There's someone at the back.
Thank you so much, the panelists. My name is Lillian from Japaigo. My question goes to the partners. I would like to know if you have done like a cost analysis and what it means to scale out or to carry and implement Prisms simulation in facilities. And if you could share with us what it means in terms of costing, would appreciate. Thank you.
We'll take all the questions in one go and then the panelists can respond. Any other questions or comments? There's one at the front as well.
Thank you very much. My question goes through the partners to the Ministry of Health, because the issue of workload added additional work in addition to the existing, as far as pre-existing work which was done before the peer learning and these Prisms. There is a rigid old existing staffing norm where they say that at least health center 4, with the high volume health center 4s you could talk about and think about 3 midwives stated by the structure, and then maybe at health center 3, 2 midwives. And when you think about the having annual leave, having maternity leave, I'm in sick leave, I've gone for outreach, I have gone for ANC, I'm doing family planning, and here there is a Prism. You know, sometimes there is a theater emergency and there is that one midwife. So what I'm trying to put across is much as we are trying to embrace the innovation which has done great to us, we should think about the inputs in order to enhance or strengthen that system coming in. Otherwise, quality is compromised in terms of staffing structure norms. Thank you.
Thank you so much. Any other comments or questions? Okay. So I think the issue of workload, we'll park that, and then maybe at some point the ministry can respond to. And in terms of cost analysis, I don't know what the partners have to say. I'll pass on to maybe Grace starting.
Well, I cannot say that we've done a cost analysis. However, like one of us presented about how they started, sometimes it's important to start in a phased manner. Sometimes you can start with a training, a TOT, for for the trainers of trainers, then you scale up slowly, because when you wait for the funds, if you want to calculate it comprehensively, sometimes the cost is really big and you may not be able even to start. So for us, what we did is to start in a phased manner, and at the end of the day, we see ourselves move on slowly but sure. There is always an elephant in the house. How do we do? What do we do to eat it? We eat it in bits. Start with a small finger, eat it. Go to the next, eat it. Go until at the end of the day we'll eat the elephant. Thank you.
Thank you so much. Dr. Jerry, any thoughts on that?
Okay. Of course, I could say that really the major cost driver, of course, the initial investment for the few phones, Prism phones that we installed, was not really that a lot, because you buy these tablets, unless maybe, of course, the developers then give another specification, maybe a larger tablet. But the ones that we are getting were really less than $1 million shillings for a phone. And then they were gracious enough to upload all the IT things inside there. And then, of course, and then organizing for the team to train our health facility teams that will be using the app. And after that, we are good to start. But what became a recurrent cost, and I think this is one area that maybe we need to discuss again with the team of developers, that annual subscription. Is it necessary? Do you have to be doing annual price subscription? I mean, if that is some area, of course, if that is eliminated or is taken care of, then actually that means after initial deployment, it becomes now infinity use. It will be there for you to use, and as long as you take good care of the phones. And the phone can take over 5-6 years if it is being used well for only that particular purpose. So this is really what I could say. Thank you.
Thank you so much, Dr. Jerry, and thank you, panelists. Lydia, this is noted. I think it's something that the Sim for Life team also will take up, because I think costing is critical if we want to scale. So definitely this is something that will be taken up as we look at scaling simulation across the board, both at facility level as well as the institutions. So I'll just get back to the panelists, just one parting shot in terms of something you admired about your relationship with the Sim for Life team. Just one thing.
Thank you so much. I think one thing I admired in the Sims for Life is the teamwork. And unless there is that teamwork, sometimes it's hard. And teamwork, not just in the implementing team, but right from top up to that smallest person in the department. If that is there, then at the end of the day, work is so simple. Because what we've seen, this is kind of multidisciplinary. Currently, we have Prisms, and we have other people in play. So if we don't have the IT in play, if we don't have the procurement, if we don't have the leaders, if we don't have the implementers, at the end of the day, it can really be tough. Just like most of us have noted, the biggest challenge that we have, especially in our health facilities, is when somebody goes for a training and he wants to do everything. Honestly, sometimes it's hard, but you are the focal person for HIV, you are the focal person for SIMS, you are the focal person for name it. And at the end of the day, the thing dies with you. So let us have teamwork. If there is teamwork, if every person is playing part in this, at the end of the day, we actually win.
Thank you so much, Grace. Dr. Jerry, in 30 seconds, what do you admire about the Sim for Life team?
Okay, no, of course, it is always good to see a team that is committed to address this question of very high neonatal mortality for this country. And I think Dr. Data and the team, you are really very committed for this. And as QAM, we are very happy to associate with you, because also that is at the heart of what QAM does. We want to contribute to the Ministry of Health effort, of course, drawing inspiration from those plans, the sharpened plan, the investment cases that we have. So thank you very much, Dr. Data and the team, and let us continue contributing to better health for the newborn. Thank you.
Thank you. Dr. Bonventure?
I think for me, it's using simulation as an opportunity to provide standardization across the level of exposure for trainees in a pre-service setting, where you don't have to. One may be lucky and they were able to do resuscitation on the ward, and then the other one wasn't. But with simulation, you're able to know that at least everyone has gotten the same level of exposure. And as someone who is training, you feel confident that at least everyone getting out of the way, notwithstanding what they encountered on the ward, has the same level of proficiency. Thank you.
Thank you so much, panelists. At least across the board, we are seeing the teamwork is critical and people admire the Sim for Life team. So keep it up. Shared vision. Everyone wants to improve outcomes for mothers and babies. So that's good. And then most importantly, as we think about scale, standardization. And that's really important as we look at larger numbers and far-off institutions adopting this. Thank you all for listening to the panel. And thank you, panel members, for making the time to share your experience. Really appreciate it. Thank you so much.
Thank you so much, panelists and the chair. A loud applause for them. Let me invite Angela to take us through the last session for today.
Ladies and gentlemen, I was in the kitchen, they got me. Yes, thank you so much. Tushabe Ruth is in the audience, and in just a minute, she'd like to share something. Tushabe Ruth, wherever you are. Ruth? Yes. As she's coming, I'll invite the ICT team leader, Dr. Ronald Tushabe. Hey, everything is Tushabe. To show you that people have been following online and some of the comments they have given. Ronald is going to give us the different comments that have come through that gives us good feedback about it. Ruth, please come and share in just a minute. I've hijacked you and that's me, I'm sorry.
Thank you. I'm sorry, I didn't want to stand here, but as she has said, she has hijacked me. But I would like to share my experience. For us in Intungamo, at Itojo Hospital, after the training, when we went for the training concerning SIMS, my God. Okay, after the training, we had a meeting with our PNO, and as midwives, we came up with a solution to have an issue which wasn't there before. And we attribute that to the SIMS and the training we had with Prisms. So after a niche was put in place, we started working and seeing babies in our NICU. And from that time, we saved so many babies. I can't tell you how we were, and it was very, very different from the way it was. So after the training, presently, we serve babies 70 at an average of 75%, no, 75 babies are saved in our niche. That means at times we get 90 babies in a month, at times 70, at times 60. So at an average, we are having 75 babies saved in our niche, and we refer an average of 3 and at least an average of 4, which was not that like that before. So we thank, and I request everyone to clap for this training that we went to that changed our lives. So we request that in Sims, this phone, we only load in the observations and then they give us the management. But you find that we miss out some things like when the babies are asphyxiated, we wish if also that low birth asphyxia, like a score of 5, 4, 3, 2 could be captured, and we know how to do about it with our phone. And then there are conditions like neonatal ophthalm, that one. And then other babies come from the community with other conditions like pemphigus, who are below 18 and they are not captured by the observations. Thank you very much.
You see, I couldn't say your things. Give me my paper. Yes, Ronald Tushave.
Thank you so much, Angela. Yes, my name is Tushave Ronald. Angela called me doctor, but I'm a doctor in the making. Just like Martin, I did computer engineering at the university, so I'm not a doctor, but who knows. So I am from Public Relations Office, but also heading this team, AIT TV, that is broadcasting this event. And it is only important for us to recognize people who are watching online. So we have people who actually followed the event the whole day. I just mentioned a few, okay? So we have Bajen's Brenda. Brenda is appreciating ventilation with new breathing device is going to make life easier during resuscitation. So that's Bajen's Brenda. So we have Sarah Achen. Air device could be a game changer in capacity building and skills retention. Well done, Sim for Life. So we have Rachel Chichoncho saying thanks presenters. Rachel is also saying it would benefit a lot if some videos are uploaded so that we continue learning from them. Thanks very much. I think the ICT team will do that. So we have Raymond Otim. What inspiration can be shared with visionaries on simulation in northern Uganda like Guru University? So thanks, Raymond. So we have Bajen's Brenda again. Thank you, our lecturer and acting head of department, Madam Allen Mary. It was worth sharing our experience in simulation at Muni University. We have benefited a lot from it. Okay. So Bajen's again, especially, okay, this one I think. Okay. He's also saying, as a third year student, as a third year nursing student of Muni University, we acknowledge that simulation has improved our skills in patient management. Thanks, Mrs. Asusi and Mr. Twesje for the wonderful presentations. Okay. So someone is asking, what is the name of this software used by presenters for managing conversion? I hope that's the right word. Okay. So there was a response as well. Okay. It's called Prisms software. And Prisms in 4, someone asked, what is Prisms in 4? It's protecting infants remotely by SMS. Okay. So we have someone appreciating Dr. Ochora Moses. I think we can stop here for now. That's the audience we had online. So thank you so much for following. If you can display our Twitter hashtag, if you really want your photos and follow the discussions online, just follow the hashtag Sim for Life Symposium 2023, as in Sim, then for not for, but for. Then you can as well follow Must Twitter, it's Mbarara at Mbarara UST. Also check on Camtech Uganda. So you'll see the conversation, get your photos, but also retweet and share so that we shine. This is our day. Thank you so much.
Thank you so much. They may call you whatever they say, but I'll call you teachers. Whether you're mentors or lecturers, you're teachers. It's not easy to teach. There was this other teacher, those who are Christians know that I believe prayer is such a long prayer. And this catechist looked for a way to break it down to help the kids learn. So he put them in a line and asked them to everyone take a line to help them remember. So the first kid was seated here where Martin is seated. So he would say, I believe in God. The second kid, the Father Almighty, creator of heaven and till the end, till they say amen. So they would go, what is your part? I believe in God. Till the end. So one day they were going through it. Number one started, number two, number three. There was silence. And then the catechist looked up. And this boy said, the guy who believes in the Holy Spirit is absent, so I cannot say my part. So when you're teaching people, you devise means of helping them learn, and you did not even see the gaps, but people are appreciating and showing results. Ruth has given us a testimony from Tungamo. People are appreciating you. May we stand up and give a big hand clap to our mentors. Let's rise. Standing ovation for our mentors. Clap, 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 stop. Thank you. I would like to invite the International Relations Officer to handle the award ceremony. These things of award I'm not used to, so the international people know this better. Sheila Ninye.
Thank you very much, Angela. A big round of applause for Angela. You're such a good MC. Ladies and gentlemen, Simulation for Life appreciates all of you for the hard work, for the selfless time you've put in, for the efforts. They are grateful. In a very special way, this evening, they would like to recognize and appreciate some institutions and personalities. Allow me to invite Dr. Data Santarino to come here in front. Mr. Peter Ola, please come in front. You'll help us to give out and recognize and appreciate different people. And Dr. Jessica Sungwa Sabit, you're welcome. Dr. Jessica, you can stand right at the end and you'll be the one to give out to the different people. We have had many partners and we are grateful for the support that they've given, not only financially, but also technically and giving in a lot of their time. At this time, we would like to appreciate Elma Foundation. A big round of applause to Elma Foundation. Thank you very much.
This accolade is presented to Elma Foundation in recognition of the support to the Sim for Life program. We want to say thank you. Simulation for Life, hands-on practice to save lives.
Thank you very much. Smile for the photo moment. Thank you so much, Elma Foundation. The next is Ladell. They are not around, but we will definitely have the present reach them. And then IDRC Canada, we appreciate you for your support, not only for Sim for Life, but over the years, supporting Bara University of Science and Technology in the different grants that they have implemented. The next two personalities are very special to Sim for Life and to MUST, and I request Dr. Data to invite them over for their appreciation tokens. Thank you.
So there are some people that we consider very special in Sim for Life because of their selflessness and also their nature, the nature by which we collaborate with them. And these people are champions in believing that global health is not a one-way street. And in no particular order, we would like to give a special recognition and a gift to Mrs. Heather McIntosh. Heather McIntosh, thank you for having a listening ear, but also a voice that advocates two-way. Thank you. The next person is a great mentor of mine. We have agreed with her that when we need to quarrel, let's quarrel. But at the end of the quarrel, let's hug each other and remember that whatever the quarrel was about, it should be about the babies. And so we are very grateful and honored to give a token of appreciation to Dr. Nalini Singhal.
Wow.
Despite being retired, she has committed to continue working with us to scale simulation and newborn programming. Thank you so much, Dr. Nalini.
Thank you very much, Professor Nalin, for your commitment to saving lives. You can have your seat. Simulation for Life has been implemented at MUST as a base, and they have scaled out. So the next gift is given to Bara University of Science and Technology. The Deputy Dean, Dr. Jonans.
So when we hatched the idea to start the simulation center in Bara University, there were challenges, but people said this must be done. And they got space and they dedicated the resources to make it done. And so today we say thank you to Mbarara University for planting this seed that is growing across Africa.
Ms.
So Ms. Esther Bebwa, on behalf of Mbarara University, you can come and receive this.
Thank you very much. When the Simulation for Life program was rolled out, some institutions embraced it. We'll now welcome Catholic University of Health and Allied Sciences, KUHAS from Mwanza, to come for your gift of thank you for embracing Simulation for Life. Asante
So
sana.
this accolade is presented to the Catholic University of Health and Allied Sciences. Thank you for embracing simulation-based learning.
Asante sana kwa kuja Uganda. We will now welcome University of Jos from Nigeria. Thank you so much for embracing Simulation for Life.
Thank you.
Now, Gode Sosai Dazuwari. Thank you very much for coming. We welcome Muni University to receive your appreciation token. Thank you so much for supporting and embracing Sim for Life.
So the wording is the same. So it's all worded the same. The accolade is presented to Muni University. Thank you for embracing simulation-based learning.
Lira University, you are very welcome. And now we welcome Bustema University. Thank you for your commitment and rolling out Simulation for Life. Beautiful. Thank you so much for supporting and embracing Sim for Life. During the implementation, some of the health facilities stood out. They got the skills and worked so hard and passed on the skills and even saved many lives. The next award is for being outstanding. So we are giving St. Daniel Komboni Hospital Chamhunga the award for being outstanding in using Prisms and simulation-based learning methods. Thank you so much, Komboni.
So this was a very competitive award, and we would like to thank the team of judges behind that evaluated this. And so this award is presented to St. Daniel Komboni Hospital Chamuhunga for outstanding performance in use of Prisms and simulation-based learning methods. Thank you so much.
Big round of applause.
Keep up the good work.
The other award is for the being an outstanding health facility in implementation of simulation-based learning. And this goes to Muni University.
So this award is presented to Muni University for outstanding performance in implementing medical simulation in teaching and learning. The depth of integration of simulation in Muni University is simply amazing. Thank you so much. And this was a competitive award. We also thank the team that was able to evaluate the universities. Thank you.
Thank you very much. You can have your seats. Ladies and gentlemen, We will have remarks from the program officer, Elma Philanthropies, Mr. Pilar Ola. He's a program officer who is a very strong community and social services professional with masters in public policy and planning, focused in public policy analysis from Makerere University. Welcome with me, Mr. Peter Ola, to give his remarks.
Thank you so much, Sheila. Good evening, ladies and gentlemen. I'd like to start by thanking each and everyone that's here. It's been a long day, but it's been something that's very appreciative. If you see here from the health workers to the students, and also from the Sim for Life team as well as those that are implementing. Amazing results of progress of a journey that started small, yet becoming bigger and bigger. From the Elma side, we just like to appreciate each and every one, right from the ministry for supporting this process, the universities that are offering space so that the simulation can actually happen, the faculty that's taking lead in the simulation training as well, and then the students for embracing it as a way of learning. That's really impressive. So thank you so much. As Elma, we've been with Mbara and the University of Calgary for the last 6 years, right from the establishment of the Simulation Center. We really appreciated the university because they offered space. And then there was an amazing team with Dr. Data and his team leading this up to date. So we're really excited with the journey thus far. And as Elma, we are committed to continue working with Mbara through this process of scaling simulation. In terms of the sharing today, I think the common theme across the board is that everyone wants to have a bit of this simulation work. And everyone knows that it actually works. So we'll try as much as possible through the various approaches. We noticed there were partners in the room already implementing. And then also there were institutions that want to embrace. We know we can't meet all the need on our own, but if we work together, we'll be able to do this and achieve and have more babies and mothers survive. So thank you so much. From the Elma side, we don't do the work, but whenever the partners achieve, that's our joy. So that's why you'll never hear us anywhere, because that's not what we do. We only stand at the back and say, continue doing the good work, and we can continue patting your back and say, go on. So that's what we do as Elma. So thank you. And as we conclude today, we'd just like to thank each and everyone, right from the Sim for Life team, for inviting us to come and see what happens. I'm not a doc, I'm an economist by training, and all I do is analyze. I don't really do much in terms of the implementation of this work. But through this period, I've learned a lot interacting with Dr. Data and team, Dr. Nalini and the team from Calgary. I feel like I actually know this, so it's really amazing. And for us, this enables us to be advocates of this work to our board. I'm here with my colleague, Rita. I'll invite her just to say hellos, at least before we wind up. So over to you.
Thank you, Peter. Good evening, ladies and gentlemen. It's been an honor sitting and listening and really putting our minds down to what really goes on in the field. We do a lot of processes advocating for resources for you. It's one thing to do the advocacy. It's another thing to see the results of that advocacy. And so we go back, Peter and I, better advocates because we are better informed. We've heard from the students, we've heard from the teachers, we've also heard from the implementing partners. And so we want to thank you, and we can only go forward and backward never. Thank you.
Thank you so much. From the Elma team, we'd like to appreciate and say thank you all. Have a good evening.
Thank you very much, Mr. Ola. And thank you so much, the ELMA team. Some participants would like to take the slides of the presentations. After we have finished this session, you can come to the ICT table right here and give them your email addresses, and they will give you the presentations. It is my singular honor right now to invite Dr. Jessica Nsungwa Sabiti to give closing remarks. She is a Commissioner of Maternal and Child Health of Ministry of Health of Uganda, and she is a child health expert. She has studied doctorate in health systems development, and she's been very fundamental to MAST in advocating for us at the ministry and national levels in the different projects that we have done. Welcome with me, Dr. Jessica.
Thank you for that introduction. Good evening, everybody. First of all, I want to thank you for the indulgence. I know it's 5 o'clock, but thank you for your patience. I think on behalf of the Ministry of Health, I want first of all to welcome all of you who were able to come for this meeting. In a special way, I want to welcome our colleagues who have traveled from outside Uganda. I want to thank the universities across the country, and that for me was very fascinating when I came here. Thank you very much, MAST, for networking. I want to thank our partners locally here. I will not mention them because I'm likely to miss a few of them. But in a special way, I want to thank ELMA, I want to thank Said Global, Adara, and I had Japaigo somewhere, and if I've missed your name, please forgive me. I want to thank our Canadian friends. I think the Canadian friends, I don't know whether they're friends or they are relatives of ours, but in a very special way, I want to thank you, and I think I want to request the room to really applaud them. Canada is not very near, you all know that, but I want in a very special way to tell you that most of these people from Canada have been coming here on their personal budget, because I know. So I really want to thank you very much, Team Canada, for really loving us, but also for nurturing this process. And we look forward to further collaboration. Allow me in a very special way to thank MAST Mbarara University for really pioneering this approach. I personally joined the Ministry of Health to initiate a training program so I can really associate with this. We used to train 11 days, so we'd go to the districts for 13 days. And I did that in every district. I was in every district at least for 5 times. And when I look at how much time I spent, I really wonder. But that was a long time ago. Not only has MAST pioneered this approach, but they've also been part of the innovations, the development of the innovations for the simulation training. And some of you in this country may not have felt it, but I can assure you we have a global presence. When you go outside there, you'll hear some of these things and then, oh, Mbarara, really? So Data and your team, in a very special way, I want to congratulate you. You've come very far, but I think your seeds, you have harvested what you seeded. The Vice Chancellor this morning talked about simulation having arrived in Africa. I think it has lagged behind. I think we have been one of those people who have been trying to sit on the edge. So we are very glad that today maybe we are crossing the bridge. One of the things which has been holding us back is the mindset. And when I looked at most of these presentations this afternoon, I kept wondering, they missed a point. Many people fear simulation training. And I can assure you, as we move forward, we need to make sure that we package it, we sell it to the Ministry of Education, we sell it to the Ministry of Health, so they can appreciate. Because I've seen situations where people are clinging on. No, will this work? I remember my daughter joined the medical school here in Makerere. And then she went for an exchange program in Hungary. And then she wrote back and said, Mommy, I'm going to study in Hungary. And I remember the first thing I told her, first year, they don't even cut cadavers. So you can imagine, I'm one of them. So, but the world has moved on. The world has moved on. We can only delay it. Simulation training has been there in the military, in the airline. So I think for the health sector or the medical perspective, we really lag behind. And I'm glad that we are really moving forward, not only in one corner of the country, but there are also many other universities joining us. We've had very many excuses, very many explanations. We don't have the infrastructure. It's very difficult to secure the models. They are very expensive. They can't bid, and so on and so forth. So today, I was very excited when I reached outside there, and there were so many models, but also knowing that many universities already are working on this. 4 years ago, we missed a big bid. We wanted to do skills labs and simulation training. So we mobilized $4 million from the World Bank. And I think data knows we didn't take off for the same excuses. But now we're expecting more money, and I hope with this catalytic work which has been going on, you'll be able to support us to really initiate this training countrywide, or at least in the regional referral hospitals. Today, like everybody said, we have proved that it works, and we are all very excited to run. But I want also to caution, like I said earlier on, I hope we shall have a long-term plan to gradually crowd out the other complex trainings, labor-intensive, patient-intensive trainings. So we need to carefully coin out our plan and how we're going to do that, and probably monitor it. It's also very important that as we move towards this training, which I said we really have to work on people's mindset, that we make sure that we nurture this process. I think it's one thing to run with it, but we need to have a systematic, structured process so that we can sustain the quality of the training. That's when they will believe in us. But we know scientifically that it works, and there's a lot of evidence. We'll be having very many early adopters, but also we're going to be having many late adopters. My friend from Seed Global talked about when he joined the university and they were shifting. When we were shifting from our old system to problem-based learning, I saw professors resign in Makerere. They resigned and went to Rwanda. So we have an uphill task, but as long as we package it systematically and mobilize more people, I guess we'll be there, and we'll have more people adopt these very excellent methods for transfer of learning. I'm very excited that this approach takes a very student-centered approach. And I think that's where the problem has been for many years. When I joined my postgraduate, I think we were 3 years, 3 people across the 3 years, because people did not want to join. It was very difficult to deal with the professors. It was very difficult to pass those drills and those short cases. I'm glad that this approach is able to enable people to have a safe space and therefore be able to join all the disciplines they want to join. And I like the fact that the students are also driving the process. I want, however, again to remind us that we need to make sure that we have Ministry of Health on board and Ministry of Education on board, given that the policy for training health workers is under that sector. But we also need to involve our young people who do innovation. I'm very glad, Kadama, that you're doing this work. Sorry, Mukama. We need to involve our own people so that we can actually troubleshoot. Many of the questions which were being asked have been solved because our own people have been involved, especially in the Prism model. As government, as I've told you earlier on, we welcome simulation training, and you know that our biggest now aim as a country and a sector for that matter, the 3 sectors, is human capital development, and this is the center of all this work. We want to make sure that we have a country, we can secure a country which is very productive, but also have very effective people. So this does contribute to the bigger picture. However, as we dream and move forward, we also need to acknowledge a number of bottlenecks, which, if we don't deal with them very straight, we might be able to delay this process. There are issues of cost of the training. Somebody mentioned it here. I want to announce that increasingly, the government is promoting distance learning. And I think this is the solution to distance learning. Because with distance learning, we worry that our trainees will not be exposed, but if they have some of these mannequins, we're sure that they'll be able to practice. We also know that some of the diseases we used to train on patients are not very common. For those of you who train IMCI, you know it's very difficult to find a child with diarrhea. But with this kind of models, maybe we'll be able to fill that gap. We also know that one of our biggest problems now, increasingly, is that patients in the future will have to consent for you to do the training on them. And I know there are patients who will say, I don't want to be part of the training. So this is a very good solution as a replacement. But more important, we have an area in this country which has suffered most in terms of service delivery: technical supervision. I don't want to say that it has died, but I think it has slackened. When we do supervision, first of all, because most of the work is decentralized, most of our health workers have not had a chance to really observe our health workers and support them in their skills to understand where their gaps are. But we believe with such kind of mannequins and simulation training, and once we're able to procure enough models, we can actually do this on site when we're doing this training. Leave alone the need for us to disrupt their work at the health facility to attend very long in-service trainings based on patients. I'm very excited on the peer-to-peer model, which allows us to do continuous learning. But also, I want to say something. Some people were worried about Prism. Recently, we have started getting litigation cases. And when we get the litigation cases and our Attorney General takes up these cases, one of the biggest problems we have is that the doctors have not documented. So we are losing the cases. Yesterday, I was in Mulago. I went to see a patient. I know there was some sit-down strike. The patient was seen. The doctor did not even sign. So we kept saying, who saw the patient? We want to get in touch with. There was no signature. And the nurse was explaining to me, this is a common habit now. So if you have some point of care instruments like Prisms, maybe some of those errors will be able to be addressed. So we really want to welcome this. Skill-based training and skills labs is already something we have in our plans. Currently, we have about 8 skills labs, but I must say the MUST lab is the most advanced. We have been able to procure models for training. We have procured models for helping babies breathe under Mama Natalie. We've not been able to procure more advanced models, but we hope that with time we'll be able to procure these. Right now, we are also procuring a model for aortic compression, and we'll be bringing this in the country very soon. And again, we have identified MUST as one of our pioneering sites. We have established these labs in the regional referral hospital because we have introduced a regional hub for training in the country, and slowly we are hoping that we'll be able to equip these regional referrals, especially those which are tagged to the universities. And that's why I was very excited to see many universities here, because that will make our work very easy. These local network hubs we have established have also received funding. We are transferring money called G2G, and some of this money is supposed to help our specialists to reach out to our facilities, to train them, to mentor them, but also support them or backstop them when they have a challenge. So we believe that this model could actually be scaled up very easily. Prism in particular has been presented to the Ministry of Health. In the technical working group, we have cleared it. With Dr. Data, we have cleared it. Actually, he has presented thrice due to the demand. And we are just waiting for Data to go and present this and agree with the digital technical working group. And they are waiting for you. We've also been able to promote integration of another sister model called NoviGuide. We had a challenge with NoviGuide because they were already implementing somewhere also. But I was very excited recently. NoviGuide agreed to sit with the Prism so that we can harmonize this. Thank you very much, Prism, for agreeing to harmonize these things. Somebody asked about the electronic medical records and how is this going to work with this? Is this going to be a parallel system? Will it last? I want to assure you that our electronic medical records has several modules, and the different modules have been developed at their different stages. The HIV module is quite advanced, but we also have the MCH module, and we have portals on how we can actually align this. And I think the timing now is the best time for us to be able to work on this. And I want really to encourage Mukama and the other team to really come in and we look at these models, because if you don't bring in your model, somebody else will come in with another competitive model. But we have this model which is evidence-based, which we have tried out. So we really want to thank you a lot. There was also a complaint about the amount of work. We are working on a system for unique identifiers. And I want to believe that once a patient has been entered in the system, some of this information may not be required subsequently, especially when the insurance system starts. And we are hoping that next year, towards the end of next year, this insurance system will be. So some of these challenges at the beginning are just teething problems, and as the systems evolve and technology develops, some of these things will not be a problem. We have still some more work to do. We have a challenge of having a standardized in-service curriculum. The pre-service curriculum is handled by Ministry of Education, and we would like to really partner with all of you in the near future, since now we are trying to secure us funding, to make sure that we have a package we can offer everybody in the country. And we look forward to work with you and our partners here to make sure that that one happens very quickly, as we align, of course, with the Ministry of Education. Further decentralization in capacity building is one of the things we have adopted. We have very many districts, and we are passing on the responsibility for training to the regional referral hospital. And as I said, these hubs now are being funded, and we hope that the specialists will have time to build, to be trained. We need to train the faculty people, the facilitators. We should not assume that clinicians actually can do this. And I think the best thing would be for us to train them in the skills component before we can move to the simulation training. Don't assume that every specialist can actually do this approach. The culture is still very new, so I hope that we can actually invest a lot more. We are concerned that we are not able to access high fidelity models. First of all, they are quickly changing. So this is an area we shall continue working maybe with our development partners to make sure that we can get these high fidelity models in the country. We would also want to develop a standard evaluation system for this training. And I'm glad a lot of work has been done in our sister universities, because this is going to be one of the most important things for us to prove to people that this thing is scalable, not only around universities, but also in our in-service training. And hopefully we shall also be working on the costing of this approach. One of the problems why we could not use the World Bank money is that we had challenges to cost these skills labs. But now that we have many examples, we hope that that will be addressed. We know also we face a challenge of artificial intelligence, and somebody has asked it. I think we need to have a think tank to start thinking about this. I know it will ease our work. I don't think it will complicate our work, but I think we need to jump on these opportunities. We need to have a team which is thinking very fast. And some of the bottlenecks here, I know now there's a system where a health worker can see a patient and you just talk, and the information goes in the system. So this thing we are worried about, data filling and that baby convulsing, could actually be easily something of the past. So I think it's very important that we move on with what is happening. We as government, we have developed a broader integrated training program along the continuum of care. We're looking at everybody. Our department right now is also handling the healthy aging. So we do newborn, child, school children, under fives, adolescents, women and mothers, but also healthy aging. So we are trying to develop a curriculum, a model for training, which can be scaled up. And I also want to announce that for the first time, the ministry has recruited a commissioner for human resource development. The people we have been having there are mostly doing the management, but we have Dr. Druwale now, who's heading this department, and I hope that this will be a very good opportunity for us. We will be facing some of these activities, as I said. We don't expect to change training dramatically, but we have developed a program where we are continuously going to phase out some of the other trainings and replace them. We will continue to mobilize resources, as I said. We are hoping that we shall get, before the end of this year, $1 million to support mentorship, and we are hoping that these models will be some of them. But we also need to do more advocacy, as I said. We need to do advocacy. I was very surprised when I came for this meeting, because initially I thought I was coming to Data's small meetings. But I was very surprised when he sent me the program last night. I said, Data, you should have invited more people. But I know we can always do this again, because there are many people who are really struggling to understand this, to see how they can do it. In all the referral hospitals in Kawempe, in the women hospital, we had a meeting last week on the same things. So I hope we can opt more members so that we can move very fast. As I conclude, I want to assure you of the government commitment, especially for this approach, but also to inform you that the job is not yet done. We're just beginning. But I believe that together, working together with all our partners, our friends here, and all the universities, cross-breeding each other, we should be able to finish and introduce this training, and we stop lagging behind. Thank you very much for listening to me.
Thank you very much, Dr. Jessica. Ladies and gentlemen, we come to the end of our symposium. A big round of applause to all of you. Thank you for working hard, committing to stay till the end. Allow me in a special way, thank Dr. Data. Please stand up again, and the Sim for Life team that puts this all together, that have been working hard. Please stand up. Thank you very much for your hard work, for your efforts, and the organizing committee. Please stand up together with the Sim for Life that has also been organizing. Thank you very much for making this a success. I would like to also appreciate the MCs of the day and the moderators. You have made it a beautiful day. Not boring at all. Was the day boring? We need feedback. There are no evaluation forms. How was the day? Interesting. I believe each of us has been ignited or reignited to advance simulation education at our different levels, whether we are students or staff, in the facilitators, lecturers, the hospital leadership, and the ministry. This has been a wonderful symposium. Thank you to the service providers and to all the people that have supported us. We can see our Twitter handle at Mbara UST. Please always check it out. And also the MAST website, www.mast.ac.ug, for news, for new research publications, for events that come in. At least minimum once a week, you should check it out and not miss the latest news. Our tea is ready. We will sing the anthems, have tea, and also enjoy the sea marketplace. Please understand more from the facilitators, ask more questions, and learn what you really would want to get. Simulation for life, hands-on experience to save lives. I will say that, you will respond, and we will stand for the anthem. Simulation for life. Ladies and gentlemen, rise for the anthems. We'll start with MAST, then East Africa, and end with Uganda. marketplace for Sim for Life.
Student. I have been in simulation, I think, like for 2 years now. It has been like a wonderful experience because we get to have these scenarios where we just use mannequins instead of real life patients. We can make errors and learn from the errors that we make. It's just amazing. It's what we get to administer drugs, we get to know about these different diseases and different things that we might not have seen on watch. It's really, really, really incredible. In simulation, there are various things that we can learn, which include teamwork, working as a team, being a team lead. Ideally, in normal situations before I think I came to simulation, I wouldn't be in a position to be a team leader when leading a case or just playing along as a team member. What are my roles? What am I supposed to do? But with the introduction of simulation, that has really, really helped a lot. I have gained more confidence, I've gained more courage, learning from these scenarios that I can like go back and just do these things on live patients, and I'm like, yes, I actually did this. Like, yeah, it's like really an amazing experience. I'll be at the Simulation Symposium. If you want to learn more, you should come on the 16th of this month.
My name is Makanga Silva Evans. I'm a fourth-year medical student at Muni University of Science and Technology. I've been exposed to simulation training for the past 2 years during my clinical years. And with this training, we're really exposed to real-life scenarios that we meet on ward and maybe elsewhere. What this helps us is that it augments the training we receive in class and on wards, such that in a way that when we actually meet real-life patients, we are ready. Personally, it has helped me. I am more confident and more courageous when I'm approaching real-life scenarios. And because of that, I encourage everyone, and we have been talking to the university administration, to expose this same training to other people of other courses or maybe earlier years who may benefit from it. If you want to know more about the simulation training, come for the Sim for Life Symposium on 16th of this month. I will be there too.
My name is Dr. Albert Muhumza, and I work here at the Simulation Center in Muni University, and I work with a vibrant team to grow the simulation method in Uganda, Tanzania, and Nigeria. And what we're doing in Muni University is that we're extending this methodology to the postgraduates so that we can address the limited number of people that are trained in this method, and also to be able to have a continuity of this method being used even outside the simulation center, like on the wards and in the other learning places. And what we are having with the other universities is really to introduce simulation to their faculty by training them and also enabling them to be able to train their own students. All these people from Nigeria, Tanzania, Uganda, from all these institutions we've been collaborating with will be at the Simulation Symposium on 16th June. You can't afford to miss.
I'm called Tebulwa Joani Taberita. I work at the Simulation Center, also known as the Sim for Life. And at the Sim for Life, we look at many aspects and we have objectives that we target. And one of the objectives looks at gender and equity. In our communities, males are known to be doctors and the females are known to be nurses. But you will all believe with me that from my own experience, this is not true, because we have seen from our hospitals where we have female doctors who are equally good as male doctors. And also the other aspect of gender, we look at interprofessional collaboration, where we see how the nurses and the doctors, how they work or relate during their working hours. So we look at how we improve on how best the nurses and the doctors can work together. And also another aspect of gender, we look at hierarchy, where we know that in our day-to-day practice, the junior staffs, it may be hard for them to pass on their concerns to the seniors, but with this objective, we came up with an advocacy inquiry strategy that we taught to our students to help them improve on the way of how to communicate to their seniors without sounding judgmental or criticizing. More about this, you can join us at the Sim for Life Symposium, which will take place on the 16th of June this year from Igongo Culture Center. Thank you so much.
The Simulation for Life program is a partnership of academic and implementing partners that are committed to introducing and institutionalizing medical simulation methodologies in Africa. We work in collaboration with like-minded people who believe in skills acquisition, skills retention, and reflective learning to drive change in healthcare. We are headquartered at Mbarara University of Science and Technology. And from here, we have worked with several partners in East and West Africa. Currently, we work very closely with Lira University in Uganda, Busitema University in Uganda, the Catholic University of Health and Allied Sciences in Tanzania, and the Federal University of Jos in Nigeria. In Uganda also, we work closely with Muni University. And this work has all been towards introducing and institutionalizing medical simulation. The other part of our work is in capacity development with different multinational organizations for skills retention among in-service health workers. And with this, we have worked collaboratively to do capacity development with many organizations, including UNICEF, Save the Children, Doctors with Africa, and the Clinton Health Access Initiative, to mention but a few. For this medical simulation symposium, we welcome you all to Mbarara to be able to meet all our partners and also know the work that they have been doing in the medical simulation space. See you there.
My name is Nogajo Charles, and I'm a fourth-year medical student at Mbarara University of Science